think we'll start the first session.
The first speaker in the early morning today is Professor Amr Abdel Ghaffar from Ain Shams University, and his talk is about lower limb complications of popliteal artery aneurysm.
Good morning, everyone. Today our presentation about lower limb complications of popliteal artery aneurysm. We have high incidence of amputation for symptomatic popliteal artery aneurysm with acute ischemia. Bilateral popliteal artery aneurysm is found in 50%. Extra popliteal aneurysm, most common is aortic aneurysm association. What's the etiology? Atherosclerosis, popliteal entrapment, inflammation, BHC, trauma, knee operation, infected emboli. Clinical picture either presented with critical limb ischemia, 70% of symptomatic presented with critical limb ischemia in the form of pain, ischemia, claudication, pain, embolization. It may be presented with acute limb ischemia. Less frequent is compression, popliteal vein, sciatic nerve compression, associated aneurysm, aortic aneurysm, femoral aneurysm, and SCVS guidelines recommend that patients who present with popliteal artery aneurysm are screened for both contralateral popliteal artery aneurysm and AAA. And the last presentation is rupture, but it's very rare. Diagnosis, physical exam, we have a pulsatile mass. Distal pulsation may be absent or present. May be present with frank acute ischemia. Doppler ultrasound establish the diagnosis and confirm presence of the thrombus. CT angiography establish diagnosis, confirm extension of the aneurysm, show the concomitant aneurysm, presence of absence of the thrombus, quality of runoff. We have also contrast angiogram and MRA. Management factors that determine graft patency and limb salvage. Anatomy and size of the popliteal artery aneurysm, presence of the symptom, patency of the distal runoff. Indication of treatment in case of symptomatic and some condition in asymptomatic. Some condition like it's larger than 2 centimeter, some say 2.5 centimeter. We have large amount of intramural thrombus, presence of the tibial disease or thrombosis, and rapid rate of the growth. We have a study show that 60% of the asymptomatic popliteal artery aneurysm becomes symptomatic over time. Asymptomatic and the high-risk patient maybe get benefit of endovascular. Repair of asymptomatic popliteal aneurysm has result superior to intervention after symptomatic development. Recommendation about this condition in Society of Vascular Surgery recommended the patient with asymptomatic popliteal artery aneurysm more than 2 centimeter in diameter should undergo repair to reduce risk of thromboembolic complication and limb loss. For selected patient at high risk, repair can be deferred until the popliteal artery aneurysm become more than 3 centimeter, especially in absence of thrombus. We suggest that patient with popliteal artery aneurysm less than 20 millimeter, 2 centimeter, presence of the thrombus, and burn off to be repaired. For asymptomatic patient with a life expectancy of 5 years, suggested to have open repair, and short expectancy may have advantage of endovascular. Type of the intervention. Open surgery in case of mild to moderate ischemia, stage 1, stage 2A, Rutherford acute ischemia, you have to do thrombolysis. In case of a severe ischemia 2B, you have to do open surgery. If you have thrombosis of the sac, aneurysmectomy, and interpositioning graft, incomplete thrombosis of the tibial artery, bypass on the tibial vessels, on the patent runoff, and complete thrombosis of the tibials, you have to make mechanical thrombectomy, adjuvant thrombolysis, intraoperative, and then bypass operation. Rule of the thrombolysis. It has a strong appeal since most frequent cause of the reconstruction failure is thromboembolic occlusion of the outflow. Patient receive thrombolysis by the literature has less occlusive complication and the amputation rate in comparison to non-using it. Intraoperative thrombolysis is of value to restore distal runoff before bypass in popliteal aneurysm presenting with acute limb ischemia. Type of the open intervention. Bypass with proximal and distal ligation. Advantage, it's easy operation. Disadvantage, progressive enlargement could be happen due to collateral feeding. Thrombosed large popliteal artery aneurysm is liable for infection. 2. Aneurysmectomy with end-to-end anastomosis or interpositioning grafting. The graft either in situ reverse esophagus grafting in long bypass or BCE in short bypass, it could be used. Surgical approach, medial approach for large popliteal artery aneurysm extending to proximal and distal segments. And in case of ruptured popliteal artery aneurysm or emergency, advantage, easy dissection of the and exposure of the tibial arteries and harvesting of the great saphenous vein. Disadvantage, more liable for venous and tendon injury. Posterior approach is liable for small aneurysm, in that fast growing due to collateral and large compressive swelling. Advantage, easy exposure and safe ligate collateral and feeding artery, less risk of nerve and venous injury. Disadvantage, difficult to harvest great saphenous vein and difficult exposure for the tibials. Endovascular management is suitable for in case of suitable anatomy with landing zone 2 cm, not frequently bending knee in 90 degree, able to be on clopidogrel for 6 weeks, high risk patient and 2 patents run off, like this condition. Ideal stent-graft, low thrombogenicity, capacity to endure stress and resist fracture or kink, allow maximum flexibility to permit its use across the knee joint, need to have good radial force to maintain adequate sealing and point of proximal and distal fixation to prevent endoleak. And the most commonly used is Viban and Florence. This is one complication of popliteal artery aneurysm. This patient is young age, 35, diabetic, present with critical limb ischemia in the form of embolization. We have popliteal artery aneurysm doing embolization and big toe gangrene. And he received the bypass operation. Between the popliteal above knee. Functioning graft. And now later on, the big toe has been improved. Okay, the next one is acute limb ischemia, popliteal artery aneurysm in the stage 2B. We don't have time to do CT angiography. Ultrasound confirm the diagnosis of the popliteal artery aneurysm. This is aneurysmal dilatation at trifurcation and the bypass between the popliteal above the knee by reverse saphenous graft to the end of trifurcation, to the ostium of the trifurcation, like this condition. In addition to thrombectomy, we have used also intraoperative thrombolysis injection to maintain this runoff, especially at foot arch. Now the limb was saved. Sorry. And this is okay. Is after doing okay, good. Doing fasciotomy, which was healed at the end. So take-home messages. In contrast to aortic aneurysm, the complication of the popliteal aneurysm are limb but not life-threatening. SVS recommend that intervention for thrombotic and or embolic complication of the popliteal artery aneurysm to be stratified by severity of the acute limb ischemia at presentation. In case of Rutherford stage 1 and 2, you have a chance to do thrombolysis to improve the runoff. In case of Rutherford class 2B acute ischemia, you have to do open repair, thrombectomy, intraoperative thrombolysis, and bypass operation. It is recommended that an isolated asymptomatic popliteal artery aneurysm large enough to cause arterial temporals or thrombosis formation to be considered for operative repair. Repair of the asymptomatic popliteal aneurysm has a result of much superior than intervention after ischemic symptom develop. Thank you.
Second talk in this session, ruptured abdominal aortic aneurysm after EVAR, Dr. Muhammad Mahdi Omar, Germany.
counter.
Good morning, ladies and gentlemen. Thank you for your invitation. Today, my topic is about assessment of the outcome. The assessment of the outcome of conversion to open surgical surgery for complication after endovascular repair, EVAR. Our study in multi-center in Germany from April 2014 to November 2021, 30 patients, 26 are men. We subjected to open conversion in multiple center due to EVAR complication. Causes of conversion is multiple from migration, aneurysmal sac growth, or endoleakage, or combination of the three above diagnoses we see here in photos: Nelix prosthesis, anaconda, vascotech, endoleakage, and migration of the stent. Less common is infection, and less common is intraoperative failure technique and immediate rupture in operating theater. In clinical presentation of the patient, most of the patients were asymptomatic. 9 patients have urgent and 5 with emergence. 2 of them was due to failure of technical implantation. The median duration of the operation, I have excluded the thoracoabdominal extraction. In case of EVAR or BVAR, we have only concentrated to the infrarenal or suprarenal clamping without debranching of the superior mesenteric, and celiac trunk was about 200 minutes, and the blood loss was 1.4 liter. Our 3 days mortality was about 23%. In follow-up of 3 months, zero no additional mortality. The post-operative complication from wound adhesions and in the abdomen or the groin region was about 9 patients. This algorithm was published in 2021 from the Journal of Endovascular Therapy from Sievers in Italy in Augsburg University. It is only limited for the migration and endoleak, and it was concerned for 44 patients with treatment of EVAS, endovascular aortic sealing, with Nelix stent. And in this algorithm, to summarize, if the patient is asymptomatic and the growth is less than 1 centimeter in year, we should control with ultrasound. If there is migration or symptomatic and the patient is favorable for operation, no COPD or heart failure, then will we operate, and we preferred to refer the patient to the elective pathway. Technical operative planning and technical operative challenging if we are making a midline laparotomy in case of infrarenal, or in case of EVAR or BVAR, it will be the most minimal invasive incision, thoracoabdominal incision, and the branching of all the visceral arteries. Second is perfusion strategy in this time of only for the renal arteries or for superior mesenteric or celiac trunk and spinal. In this case, it is preferred to use a heart-lung machine and selective perfusion. If it is only for the renal arteries, we prefer to use a cold saline with prostavazine every 5 minutes selectively, or with cardioplegic catheter continuously in the renal artery. Partial extraction of the Stent-graft or total extraction. In this case, we have here a combined debranching stenting in the internal iliac and external iliac and common iliac arteries with Nelix prosthesis and chimney. With complete migration dislocation, and this patient was partially extracted the prosthesis with implantation of aorto bifemoral silver prosthesis. I will jump here. If we have an infection, it is important to do a PET CT to know if the infection is diffuse for all the prosthesis or it is limited for the prosthesis. And if it is limited for the prosthesis, it is better to extract or make a partial extraction to preserve the the aorta and for further suture if suitable. Here, there is a technique of the syringe capture of the main body. If the main body with hooks, we took 20 milliliter syringe and we cut the top of the syringe with prosthesis Brenner and push the syringe proximally and tract the main body distally to extract the prosthesis. What is our decision for graft selection? It's depending on the anatomy and of the original pathology of the aneurysm. Presence of infection is the most challenging case. If we need a pericardial patch, we got a big pericardial patch, and with Hager dilator, we will make homemade epsilon prosthesis. In this case, we have combination of deep veins and pericardial patch. Antimicrobial graft, the most preferable graft for us, we have a good experience with is Synergy, silver impregnated graft, rifampicin soaked graft. Summary, open conversion after endovascular aneurysm repair is challenging. Pre-operative algorithm is very important for planning of the patient. 5 points for the planning the operation: midline or retroperitoneal perfusion strategy, partial extraction or total extraction, syringe cappage. At the end, there is an endovascular solution with this Altora stent. It is a D-shaped stent with 4 sealing points, 2 sealing points at the proximal neck and 2 sealing points at the distal neck, at the distal in the iliacs, to ensure no endoleakage or migration. We have only 2 cases in our center with treated with Altora. Until now, there is no problem. Thank you.
Next we have late complication of EVAR, type 1B endoleak. Always stick to the IFU. And this is my Professor Nasser Al-Said from the military.
صباح الخير. بسم الله الرحمن الرحيم. Today I would like to talk to you about an important issue. Late type 1B endoleak after EVAR. It's better to stick to the IFU. As you all know, this is a different type of endoleak. We concentrate here on type B here. So usually type B occur maybe due to planning error or technical error. Quickly, I just would like to remind you with the causes, maybe the tortuous iliac or short common iliac, short distal sealing length, and also large aortic aneurysm sac. So usually undetectable cause, usually because due to progressive of the disease and dilatation of common iliac artery by time. Considering data from the current literature, usually the type 1B endoleak occur about 20% intraoperative, 30% early, I mean within 6 months, about 50% late, more than 6 months. And as you all know, the treatment may be endovascular, hybrid, or surgery, and usually mainly endovascular with extension of the endograft. This is the main and effective treatment. Most results of approved studies show that there is no significant difference in sex, age, or brand of the stent graft were observed between type 1B endoleak and the control group. Patients in the early type B endoleak had significantly more tortuous and short common iliac and short distal ceiling length, and the late endoleak group had significant larger maximum aortic aneurysm sac diameter, short common iliac and short distal landing zone. Usually treated with extension. The various mechanisms of type 1B endoleak differ depending on the time of onset from the procedure. Careful preoperative consideration of the aortic aneurysm size and common iliac length and tortuosity is essential, and the patient with risky feature should undergo strict postoperative surveillance. Now my case presentation today, this is a chap, 36 years old, has no significant medical or surgical past history. He coming to us with abdominal pain, recurrent abdominal pain. This patient, we done ultrasonic, which show pulsating AAA, and then confirmed by the CT angio. He had a successful EVAR, was done since April 2016. Serial CTA done after 3 and 6 months and was normal. Ongoing follow-up in August 2021, CT show type 1 endoleak from the right side and left side. We did admit the patient and preparing him to manage or to fix this problem, and definitely we thinking first in doing extension. We succeed to get this is the pre-EVAR. It was a nice aneurysm with nice landing zone, proximal and distal. We don't have the conventional angio for the immediate intraoperative one, but we could succeed to get, this is a 3 months post-operative. No comment. 6 months later, and as you see, I think there's a shortage of the 2 limbs away from the common iliac bifurcation. This is 4 years when he arrived to us in August 2021, and we found this, and as you see, a bit aneurysmal right common iliac. I just remind you with the IFU, definitely adequate landing zone is important, usually more than 1 centimeter is okay. Iliac diameter, average 7.720. Oversizing, usually in a healthy iliac, 10% may be enough. In ectatic iliac may extend or increase the oversizing to 15%. Adequate common iliac artery length should be 3 or more centimeter. If shorter than 3, you have to go to land in the external iliac. In case of common iliac artery shorter than, you have to go to the external to make good sealing. This is our CT done on admission. You will recognize leaking, marked leaking, obviously. Right, this is some picture showing the leaking. Here, filling the sac, and this is reconstructive film. So we started to make sure from the diagnosis first, going from the right groin, taking serial picture showing the leak from the right side, taking the measurement of the right common iliac, the stent was about 2 centimeter. So this is a measurement for the right limb. Actually, I think the previous device it's quite different. Another company, not our stent we used. So we manipulate this by using 2 stent. Our main target to get down to the common iliac. So just quickly, 1 minute. Right, here we continue the procedure until we finished, but unfortunately, we should go from above to put the second extension limb on the right, then complete on the left side, as usual, nothing. This is the measurement of the left extension limb. Right, seeking for time, sorry. Here it is. So my conclusion, actually, an extensive sealing lens may be protective against type 1B endoleak, especially when the size of the aortic aneurysm sac is large or when common iliac has risky feature, including large diameter or short lens. So we have to pay some attention to the distal rather than we are concentrating mainly on the proximal neck. Thank you very much.
Thank you, Professor Nasser. We have 2 online presentations ready. Okay. The next presentation by Professor Mahmoud Salah from the Holy Places from Saudi Arabia. His talk is about endovascular versus open surgical treatment for renal and visceral aneurysms. Discussion will be at the end of the session. Sure. Good morning, Dr. Mahmoud. We cannot hear you, Professor Mahmoud.
The problem.
Okay, we are hearing now.
You can hear me now?
Yeah.
Okay, thank you very much.
Thank you.
I wish, Taban, I'll be with you physically because I didn't miss this meeting for years, yeah. But unfortunately, I had to do it by Zoom this year. I need to thank Dr. Mustafa Suleiman and all the organizing committee and the chairpersons for their great efforts to do this meeting. I'm going to talk about visceral aneurysms, endovascular versus open surgical management. Concerning the prevalence, they account only for 5% of all intra-abdominal aneurysms and occur in about up to 2% of the general population. 1/3 of them associated with non-splanchnic aneurysm, iliac, AAA, femoral, whatever. 1/4 of them presented ruptured with the high mortality reaching about 100% in pregnant ladies. In order of frequency, the aneurysms are 60% of them occur in the splenic artery, 20% in the hepatic artery, 6% SMA, 4% in the celiac, and the other 10% in the renal and other branches. Traditional indications for therapy, any symptomatic patient, any patient having real symptoms, any pregnant ladies, this should be treated aggressively. Renal artery aneurysm when reaches 3 centimeter or more. Any visceral aneurysm, celiac, SMA, splenic, hepatic diagnosed should be treated actually because they have high mortality rate with rupture. With the advancement of the radiology, we started to diagnose more cases of aneurysm. This is superior mesenteric, and this is splenic aneurysm, huge splenic artery aneurysm. And you can see this is also one of the hepatic artery branch from the celiac. The outcome of the endovascular therapy, this actually is a little bit old study, but it's having a very good number of patients. They, as you see, they managed to treat splenic and celiac, SMA and hepatic, and they had good number of cases. The technical success rate was nearly 100% of nearly all types except some of the hepatic. The mortality and the complications were in the acceptable range, except this 50%. Of course, this is 50% of the celiac branches were dead, but actually don't be deceived by this, because if we return back here, they did only 2 cases of celiac. So one of them was complicated and the patient died. So they, that's why the 50%, but actually it's a very deceiving number. We should not look at it like that. Concerning the renal artery aneurysm, this is again a more recent study, evaluated more than 800 renal artery aneurysm in 760 patients in 16 institutions. 75% of them were asymptomatic, ruptured were rare, and there was no mortality even with the rupture. Renal artery aneurysm repair was done for severe hypertension, cured about 30% of patients and improved about 26% of patients. 3 patients had ruptured, no death, as I just mentioned. Aneurysm growth rate was very low per year. No difference between the calcified and the non-calcified aneurysm. So the fate of the renal artery aneurysm is much better than the visceral aneurysm. Some technical tips, whether for the endovascular or the open. Of course, if we are going to do endovascular, antegrade access from the arm, especially left arm, is much better. It gives you good accessibility for all the visceral aneurysm. Use stent-graft and coils as the first line of therapy. In case of infection, of course, we need to do open, and we use vein graft. Possible ligation, not necessarily I have to bypass this. I have to excise the aneurysm and make a bypass. Ligation is still an option. Auto-transplant kidney is also can be considered for renal artery hilar aneurysms. Some of our cases, this is the superior mesenteric artery aneurysm, and this is the construction. This is during intervention. As you see, there is a branch immediately after the aneurysm, and there are many branches coming out of this aneurysm. So we were a little bit concerned whether to cover with a stent graft, we will lose all these branches. But actually we did this, and this is the stent, the aneurysm disappeared, but also the branches disappeared. But just the picture will not give the real situation. This video can give us the real situation. You can see that all the branches are filling again from the other branches. So the patient did not lose any of the branches. These are branches for the left colon, and it was saved, alhamdulillah. This is another case, superior mesenteric, very near to the ostium. And this is after the stent graft. This is a splenic artery aneurysm, very tortuous splenic artery. This is after we put stent graft. As you see, stent graft was put, but yet the aneurysm is still filling because it was not covering the whole mouth. So we have to put another stent graft in the as an extension to the first one. And as you see, in spite of the tortuosity, the aneurysm disappeared, alhamdulillah. This is a algorithm to know whether to do endovascular or open. It looks like a little bit complicated, but it is not actually. So I tried to simplify this in this. When to use which? When I use endovascular and when to use open. Or if you have elective aneurysm, you are free to do both. Open is correct and endovascular is correct. For the distal branch point, like the one we saw, again, you can do it open, you can do it endovascular. For the hilar aneurysms, open is the best option for this. For the mycotic aneurysms, where there is infection, again, open is the best option. For the ruptured aneurysm, you are free to do even open or endovascular. If you can see that you can do it endovascular and you have the tools, go for it. If not, open is still a very good option. For the end organ ischemia, open is number one. For the saccular aneurysm, the endovascular is the best option. In conclusion, we should treat all symptomatic and pregnant patients. We, once diagnosed, you should be treated. Treat all visceral aneurysms identified. Rupture is catastrophic, especially in the visceral where there is the peritoneum can accommodate a lot of blood. It's not like the renal. The renal, we can treat it even when it reaches 3 centimeter. The endovascular treatment includes stent graft and coil embolization. This is the first line of treatment. Open surgery includes bypass surgery and ligation. Again, ligation is still an option. You can see many patients with occluded celiac, but the SMA and IMA are patent and there is no problem. You can see the reverse, SMA blocked, but still the patient has no problem. So ligation should be considered. Preservation of the antegrade flow is preferred, but not necessary. This is what we mentioned by ligation. If I can preserve the antegrade flow, it will be much better. If not, still ligation is an option. Mycotic aneurysm should be treated by open surgery, except in very few situations, if in an emergent situation or as a temporary treatment that the situation now cannot allow for open surgery, so I can put endovascular stent graft and to be treated later by open surgery. Thank you very much.
Thank you, Professor Mahmoud, and we hope next time to be with you more than to be with us.
Yes, I know that. Hopefully, inshallah.
Inshallah. Munich, Germany, ready for the online. The next presentation by Professor Hans Henning Stein from Munich, Germany is about EVAR with sac embolization.
Yes, good morning. Good morning, everybody. Hopefully you can hear me. Is that the case? Yes, obviously this is the case. So thank you very much again for this very kind invitation. The same is true as for the speaker before me, that I would have loved to be there with you in person, maybe at another occasion. So my job to do is tomorrow is to give you some information about a new trial that we have designed about sac embolization for the prevention rather than for the treatment of type 2 endoleaks for AAA. I have no disclosures with respect to this talk. As you all know, type 2 endoleaks originate from flow reversal, either in the inferior mesenteric artery as type 2A endoleak, or coming from lumbar arteries as type 2B endoleaks after EVAR. It affects about 20 to 30 of all EVAR cases, and 1 in 4 of those cases you can see an expansion of the aneurysm over time. So once the attachment zones proximally or distally are lost stepwise, the risk for a secondary type 1 endoleak increase even with rupture, and there is a clear association with elevated mortality. The recent AAA guidelines from the European Society of Vascular Surgery says that re-intervention for type 2 endoleaks after EVAR should be considered in the presence of significant aneurysm growth. Significant means at least 5 to 10 millimeters. So currently, this therapy consists either of coiling, as in this example here, or coiling of the whole sac. And this brings you freedom from endoleak rates in about 50% of the cases. Another option is the use of polymer or glue, again with not that very good expansion rates and freedom rates from endoleak rates. So there's little evidence currently supporting the real efficacy of secondary intervention for type 2 endoleaks after EVAR. We also looked at our data from, we treated over a period of time those endoleaks by use of onyx. But as you can see here, the technical occlusion rate after 2 years was just 47%. So this is an unsatisfying and, by the way, very costly procedure. So what can we do in terms of prevention of type 2 endoleaks? This is a scheme drawing about the concept of EVARs, so endovascular aneurysm sealing with a polymer sac besides the AAA bifurcated endograft. As you know, Nalix is not available any longer due to too many side effects and technical problems over time. Another option is side branch embolization before or during the EVAR procedure, as done by Ms. Branstein here from Leipzig in Germany, in this nice example with these embolization here of lumbar arteries during the procedure, or as I said, sac embolization again during the primary procedure. Sac embolization takes you roughly 10 to 12, sometimes 15 minutes additional procedure time, and 2 to 7 minutes additional fluoroscopy time. It requires large sheaths or additional sheaths put in place from the contralateral side. And you need to implant about, or even more than 2 meters of coils in the aneurysm sac. The ESVS guideline also mentioned this principle and wrote, preoperative sac embolization has been suggested as a technique to reduce risk of type 2 endoleak, but the benefit of a reduced number of late re-intervention or decreased incidence of rupture remains to be proven. There is one trial outside, so one randomized controlled trial published last year by a French group, a multi-center trial, where they performed a sac embolization in roughly 40 to 45% and standard treatment in another group. And they found type 2 endoleaks after 12 months in 14% of the actively treated patient cohort as compared to 40% in the other group. But after 2 years, this significant benefit of sac embolized treated patients was not longer statistically significant. So these are the Kaplan-Meier curves, and the problems or the weak points of that study was that the endpoints were not that much and not that clearly defined. Some data were missing. They used coils just from one single manufacturer, and the follow-up was done just by CT plus classical double-X ultrasound, but not with contrast-enhanced ultrasound, which is the standard of care currently, I would say. So we took the decision AAA bigger than 50 millimeters, anatomically suitable for EVAR, of course, and which with a high risk for a type 2 endoleak, which means that at least 5 lumbar arteries, patent lumbar arteries, are visible on the CT scan, and or there is less than 40% of thrombus in the AAA volume. The primary endpoint of this trial will be type 2 endoleak after 12 months as detected by contrast-enhanced ultrasound plus CT angiography. And the statistical hypothesis is that we will be able to reduce the incidence of type 2 endoleaks from 45 to 15%. Secondary endpoints will, of course, also be evaluated, and we intend have also a longer follow-up. And if the outcomes show, yes, there is a potential benefit, then we will try to organize a much bigger multi-center group. So this is the flow chart for the patients. More than 400 need to be screened. And at the end, we will have 50 patients in the standard EVAR group and 50 in the sac embolization group. And the study will be done in Munich, in Dresden, and in Augsburg, and in Wiesbaden at those hospitals. So in conclusion, tight tube endoleaks are a persisting problem after EVAR. Prevention rather than treatment might be a key to improve long-term outcomes, and the EVAR SE trial will evaluate the efficacy of sac embolization in the very near future. So thank you very much again for inviting me, and I'm happy to take some questions.
I think we enjoyed the whole presentations. We'll start discussions. The first presentation was by Dr. Amr Abdel-Ghaffar, the lower limb complications of popliteal artery aneurysm. Any question from the floor? Dr. Adil?
Thank you very much, Dr. Khil. You mentioned for your guidelines about the size and runoff. What about the role of collaterals in decision making? Yes, collaterals from the sac in your decision making. No? No, there is collaterals arising from the sac and coming and away from the sac. Yes. Yes. If we had patients coming to us with late neglected ischemia and direct to the amputation, what about the incidence of thrombosed popliteal artery in these cases for primary amputation? Yes. No, I'm asking about the percent of occluded popliteal artery. We couldn't discover it, only patient going to the amputation. Okay? If we make angiography in this patient, CT angio, we will find only occluded segment. We couldn't find the aneurysm by CT angiography. Okay? But my question, sometimes the patient came to us with neglected acute ischemia, direct for the amputation. Had anyone searched for the incidence of popliteal aneurysm in these patients or not?
He was not like
Yes.
And it's very important to see because being we have contralateral breathing artery association and aortic angle association. So you have little of acoustic and peripheral.
Yes.
So make layers or breathing to other sides.
So this research point for us, because some people had done 11 cases of amputation, and with ultrasound they had found 7 patients from this 11 having occluded popliteal aneurysm. So we must search for this. Thank you.
Any other questions? لا لسه الدكتور عمرو بس اخر سؤال لو حد عايز any other questions to دكتور عمرو. Dr. Amar, I have one comment. You said that you are using fluency in the popliteal artery aneurysm. I don't think it's acceptable. I don't think at all. I don't know what the opinion of my colleagues, but Covera is acceptable, V12 is acceptable. The second thing I want to ask you, you are using thrombolytic therapy in patients either pre-intervention or intraoperatively. How you use it pre-intervention? How you do the thrombolysis for these patients? Systemic thrombolysis, catheter directed in the aneurysm. I don't know how many of my colleagues will accept this. Yeah, I think thrombolysis will be directed to the occluded vessel, not in the aneurysm. The second presentation by Dr. Muhammad Omar Mahdi, ruptured abdominal aortic aneurysm after EVAR. Dr. Muhammad Mahdi. Any question? تفضل يا دكتور.
Thank you, Dr. Muhammad. It is really a problem to have ruptured aortic aneurysm even after EVAR. But by correction by bovine graft, what about the complication and long duration of this bovine graft? Is it safe, or by follow-up we have some complications?
We have 3 cases with homemade bovine prosthesis. We have only one problem because of the etiology of infection. The etiology of infection was Candida albicans, and Candida albicans is a very challenging problem because it is a deep tissue organism which need long time of very costly. This patient, I remember it, we should remove the pericardial patch again and to make a curettage surrounding the tissue. And it was also with Candida albicans. Until now, there is no any local antiseptic or medication can be applied in this situation. We use this getting synergy prosthesis, silver impregnated with extra and we try to, after this treatment with casbufungin, which is very costly, and it costs about 500 euros per day, and it's for 6 months, and for 1 year is fungicam, must be even. This is the only thing with this pericardial patch.
Dr. Magdi.
Thank you, Dr. Mahdi, for your presentation. I agree completely with you that Nelix device is a very bad device. It loses all the parameters of a probable device to be put in aneurysm. The main problem of this device is proximal migration or distal migration. And I think this is what you face in your cases. But the only advantage of this device is that you can partially remove it. I think it is not difficult like other devices. If you deal with Cook device, you face a lot of troubles removing this part.
Yeah.
But for Nelix, the only advantage that you can easily take it out or partially take it out.
With Nelix, Anaconda from Vascotec, there is no suprarenal fixation or hooks.
Yes.
You can remove the Stent-graft easily. With the suprarenal fixation hooks, you need this syringe capture technique,
Okay.
or sometimes with the back of the DeBakey forceps, man can get the graft outside, but it's very risky.
Okay, one last question. If there is any rule for the polymer sac for rupture of the aneurysm?
The polymer sac was reported with degeneration in some cases, and was the cause of the migration of the stent graft.
Just one comment for our junior doctors. Repair of rupture AAA after EVAR depends on the type of endoleak and the CT scan. And so the planning is very important. What you are going to do pre-operatively, either open or endovascular surgery. Any other comments? Okay. Dr. Nasser Said, the presentation was late complications of EVAR, type 1B endoleak, always stick to the eye field.
So, Dr. Nasser, I have a comment and a question. A comment, I think it is not ethical to let the name of the patient in the radiology images, and so in the next presentation I'll ask you to delete or omit the name of the patient from the radiology images in your presentation. You can omit, you can delete in the presentation. It is not ethical, Dr. Nasser. So, the question is not for Dr. Nasser alone. Dr. Nasser solves this problem by a technique which is known as ball button technique. It is the Medtronic technique used for management of dilated common iliac aneurysm. So I asked Dr. Nasser and the chairpersons, some of them are authority in the endovascular repair of AAA, about the best treatment of dilated common iliac aneurysm. Is it the ball button technique, or to extend the graft to the external iliac and put IBE, iliac branch device, IBD or IBG, iliac branch device of Cook, or iliac branch graft of Gore? What is the best in management of dilated common iliac aneurysm? This question is for Dr. Nasser, for Dr. Muhammad Hosni, and Dr. Ahmed Suleiman, Dr. Magda Hagag. What is the best? We have to discuss this, I think, with this case.
So let me start first and say simply, for me, I prefer to extend to the external iliac with or without closing the hypogastric. It depends. If the other hypogastric is okay, so I can embolize it, or just extension for a saving zone and make sure the sealing is okay, simply.
So you mean coiling of one of them, and
if the other hypogastric is okay and the patient is a bit young.
Okay.
Dr.
What,
Tariq.
what you think, Dr. Hosni?
Dr. Tariq, comment?
Dr. Tar, yeah.
No, this is a different point. I was just going to make a comment. It's a very nice.
Can you finish the answer to the first question, Dr. Tariq, at first, or the same? The same?
I think what you did was fine. It's just to do the extension. I think I agree with that.
I think it depends on the age of the patient, the anatomy of the artery, proximal and distally. All of these things will help us in taking the decision. You should tailor the procedure according to a lot of factors, not only one factor, the dilated iliac artery. It's not the only factor that will help you making the decision either you're going to do a bell button or you are going to do a branched iliac or going to occlude the common iliac artery.
I would like to add another factor, Dr. Hosni, that is the influence
Sorry, Dr. Omar.
of industry, yeah.
Sorry, Dr. Tara Abazim would like to add something. And I would like, for me, to ask another question for my colleague and the professors. From the start, for me, I prefer from the start, when I do EVAR, going down distal landing zone should be above the bifurcation in most cases. It doesn't matter about the length of common iliac if more than 3 centimeters. Even I would like to just above the bifurcation. Any other colleague go just 3 centimeters or a bit more?
David?
I would agree with you. I would always use the full length of the common iliac and maximize every seal zone that is available. I think the question about what is the best way to treat the common iliac or to seal the common iliac is, as you say, it's dependent on the anatomy. I mean, you can't always use an iliac branch device because you've got to have quite a long common iliac artery before you can fit an iliac branch device. So if you've got a short common iliac artery, you have almost no option but to either cover or cover and embolize the hypogastric.
One comment, Dr.
This is just a comment. I think this case, you handled it well, and I agree with your extension and everything, but it just emphasizes again the point that the problem with delayed problems following EVAR and the need for re-intervention. And looking back at this case, if I get a 60-year-old patient who is healthy, I think I would choose simply open surgical repair for this patient. And that's not just my opinion. You know, the latest SVS 2021 guidelines say that if you have a patient with a life expectancy of 10 years or more, then he's better served with an open surgical repair. It's a nice case, but it goes on to illustrate the problem of re-intervention with EVAR.
I just have...
I'm absolutely agree with Dr. Tariq, but this patient is not my patient from the start. He's just arrived, but I agree. This patient at the time, 2016, definitely was younger and healthy fit. I choose for him open repair much better.
I just have one comment because I think the presentation title always stick to the IFU. And in this case, I'm sorry, Dr. Nasser, you didn't stick to the IFU.
When you choose EVAR.
No, IFU means, I know that the company, especially this company, always offer this solution to the young doctors. Please, young doctors, Dr. Nasser is a well-trained and very experienced. He can do whatever he wants. But don't go from the upper limb with a limb extension. Please don't do that. The incidence of stroke is very high.
I feel sorry about that, but for me, it was a challenging because portfolio available wasn't satisfying me. So sometimes you depend on the available around. But I agree with you. I don't like
decision, but for
seeking the
please
benefit.
don't do that. Do you have any comment, Dr. David, on this using the lamp from the upper limb?
I would never do it.
Tell the company, please don't offer this solution to anybody. Please don't do that.
I did it
It's
twice and I
against
will
the
never
IFU
do it
and
again.
it has a lot of complications. Dr. Magdi, do you have any comment on this?
I agree with you first. You talk about type B endoleak. For Dr. Nasser, it's a late type type B endoleak in his case. But you have to, as you said, it's a case-by-case scenario. You cannot put algorithm for treatment of all. But my fear is from, if you have a common iliac with such data and you see in this case there is a graft migration and dilatation of the common iliac, so I think it's better to get away from this artery and to land distally away from the common iliac artery, because any manipulation or extension of the limb in this common iliac artery will end up after some time by another type B endoleak. One more point, that when you take the measurement for the limb, the case were done 5 years or 6 years ago. If you take your measurement, the original limb of the EVAR, you expect to be dilated. Don't depend on the old measures. If you put extension 16, it's not going to be 16. It might be 17 or even 18. So don't depend on the old measures and take your new measures to select your extension. Thank you.
We'll move to Professor Mahmoud Salah, the presentation with endovascular versus open surgical treatment for renal and visceral aneurysms. Any question to Dr. Mahmoud? He's with us online.
Dr. Mahmoud,
Dr. Omar.
online. But I'm wondering, Dr. Mahmoud, about the endovascular treatment of the splenic artery aneurysm. Splenic artery aneurysm can be managed simply by surgery. It is a tortuous artery. We cannot have a good sealing proximal and distally in this tortuous artery. It has many branches. So I think the best solution for splenic artery aneurysm is just to do ligation and splenectomy.
Dr. Mahmoud.
Dr. Omar, thank you very much for the comment. I agree that surgery is a very good option for the splenic artery aneurysm. Yet in this situation, she was a young lady, 35, 34, and she was refusing the idea of surgery. It was offered actually. Usually we offer the two options for the patients. Then we said, when she insisted for the endovascular, that we will give it a try. If it's okay, we will do it. If not, actually this was about 8 or 9 months ago. Till now, it's she's doing fine. Actually, she had some abdominal pain after the procedure, and we were thinking of splenic infarction, and we did many CTs, but actually it was okay. But I completely agree. As I mentioned in the table, for the elective surgery, for the elective aneurysm, you can do open surgery or endovascular, but for the splenic, I know that open surgery has upper hand. Thank you very much.
Dr. Mahmoud, a comment for Dr. Omar. I think it depends upon the location of the aneurysm of the splenic artery. Sometimes the splenic artery arises directly from the abdominal aorta, and if it arises here, it will be, it needs a different way of treatment.
Actually, we find a lot of difficulty just crossing the tortuosity of the splenic artery. but we managed at the end to cross, and we did put two grafts with good overlapping, which stretched the splenic artery a little bit, but still it was patent.
So, I think there is an excuse for Dr. Mahmoud because these patients are, most of them are young, pregnant ladies, and the influence of the patient is clear, but I'm afraid it will recur. Thank you.
Any other question, Dr. Magdi? Dr. Magdi?
Endovascular, you escape from problems, but in surgical treatment, it's a hell. Just to ligate the splenic artery and to deal with the aneurysm with the splenic vein attached to it and the pancreas below you, it's a hell of a problem during surgery. You must be a competent surgeon.
Thank you very much, Dr. Magdi. طبعا it's not an easy task at all, the open surgery. عشان كده ال difficulty that you can encounter in the endovascular is much less than the difficulty you can encounter in the surgery. And as Dr. Omar said, it can recur. Yes, it can recur. If it recurred, خلاص يبقى no option other than the open surgery. But it is a hell of surgery. I know that.
Thank you, Dr. Mahmoud. I think we are a little bit late. We have still one presentation left. Professor Hans from Munich concerning the sac embolization for EVAR. Any questions from the floor?
Dr. Eckstein? Can you hear me?
Yes, I hear you.
I wonder how can you measure the thrombus load in the aortic aneurysm sac? You said your parameters is less than 40%. You have high incidence of type 2 endoleak. I'm asking about how you measure. It's a volume measurement or what the kind of measurement of the thrombus load in the aneurysm sac?
Yeah, it's a kind of a volume measurement. We have several softwares available for that, and but you're right. It has to be standardized for the 3 or 4 centers that will participate in this exploratory trial, and we have to make sure that in every center the same software will be used for the assessment of this thrombus issue. But it's mathematically and technically possible.
Do you agree with me? It's one of my observations with my cases. When you operate on small aneurysm, means 5.5 and above, you can find type 2 endoleak more common than you work on 7 or 9 or 8 centimeter aneurysm. It's just that's an observation. Do you agree with me?
Well, I'm not sure whether that's really the case. Maybe that's a feeling that we have sometimes. We see big aneurysms. Usually, not always, but usually with circumferential thrombus, maybe more than in 5.5 centimeter aneurysm. But sometimes the thrombus is just on one side and the other side of the aneurysm is clean. Maybe this is something like a gut feeling, but it's an interesting question, and I think we have to look that up. Thank you.
I think it's very important, yes, and it needs a lot of discussion.
Hello, Professor Eckstein. My name is David Shaw. I'm a UK interventional radiologist. One of the problems when we looked at EVAR in the recent NICE assessment was the cost of the procedure. How much more does this add to the cost of the procedure, given they're using over 2 meters of coils?
Well, that's yeah, money is always a difficult issue if you're doing clinical research. But currently, we estimate the extra costs in the range of 1,000 euros. We look at ways to document that and to put these sort of things that we done also in the DRG system by coding specific code numbers. But it's yeah, that's one of the reasons that we are funded currently, and we get a little bit of money to buy these sort of coils. My personal view is, if this turns out to be effective on a long run, or at least effective in a way that the incidence will be halved or so, then the need for longer coils will increase and the prices will go down. And what we do sometimes in Germany, and the same might be true in UK and many other countries, that we buy packages from the company. So a package means that everything is in one package, including sheath, graft, extension graft if it's needed, etc. And this might be the way to go in the future, especially for companies like Cook, which are able to provide you with coils and grafts, for example.
Thank you.
But I agree, it is not for free, and it is an extra cost.
Thank you for
But
everybody.
if you look, you know, sorry to interrupt you, but these long-term surveillance also is costly, and these late re-interventions are probably even more costly. Not talking about the psychological side effects for the patients. So I think we have to do something about this type 2 endoleak issue. It's really annoying sometimes.
Thank you, everybody. End of this session. I hope you enjoyed it. Thank you.
Thank you very much.
Thank you very much.
Maybe if we as physicians, there are like we
عايزين نبدأ السيشن الثانية بسرعة يا جماعة، احنا متأخرين عشان في صلاة. الحاجة الثانية اللي بالنسبة للرحلة السياحية للأسر، للسيدات والأسر، الناس اللي موجودة، الأتوبيسات موجودة بره منتظرة، كانت المفروض تتحرك الساعة 10، فلو حد عنده أسرته عايزة تروح تتحرك معاهم تلحقهم في الأتوبيس في الباركينج بتاع ناحية الجزيرة. شكرا جزيلا.
Good morning. My name is Werner Lang from Germany, Bavaria, University Hospital of Erlangen. I'm glad to be here. Congratulations. This is an exciting event and I enjoyed the sessions. The next session is about complex thoracoabdominal aneurysms, and the first speaker is Professor Kolo Kudruni. It's online about aneurysms of ascending aorta, pathogenesis, classification, and treatment. So please.
Good morning, and thank you for inviting me to the 16th annual meeting of the Egyptian Vascular Club. I will talk today about the ascending aorta aneurysms, their pathogenesis, classification, and treatment. I'm a consultant thoracic surgeon, and I work in university hospitals, Coventry and Warwickshire, in the United Kingdom, and I am also a member of the coordinated committee of the Hellenic Diaspora Doctors Association, HEDIDA UK. We will start with some historical facts. First of all, the aneurysms of the thoracic aorta were first described in the 16th century. And some 400 years later, in 1956, Cooley and DeBakey performed the first replacement of the ascending aorta using a homograft and in cardiopulmonary bypass. It is interesting that the polyester cloth grafts were introduced by DeBakey, who discovered them in a Houston department store. And the first composite aortic root replacement was performed by Bental and De Bono in 1963. A few words about the anatomy. So as you know, the thoracic aorta is divided in three parts. We have the ascending aorta, then we have the aortic arch, and the descending aorta. The ascending aorta originates just above the aortic valve and ends before the innominate artery and is approximately 5 centimeters long. It consists of the aortic root with the sinuses of Valsalva and the sinotubular junction, and also a tubular segment that leads up to the aortic arch. Some definitions to follow. When we talk about dilatation of the aorta, we mean that the dimension or the diameter is above the 95th percentile for a normal person, age, sex, and body size. When we talk about an aneurysm, this is a localized dilatation of the aorta, which is above 150% of the diameter, again expected for age, sex, and body size. If the dilatation is less, then we talk about ectasia, and it's also interesting that men are affected 2 to 4 times more than women. A few words about the pathophysiology. So the aorta, as you know, is an elastic vessel. It has 3 layers: the intima, the media, and the adventitia, with the adventitia being the outside layer. Between the intima and the media, we have the internal elastic lamina, which separates the 2 layers. In the media layer of the aorta, there are elastic fibers, and this allows continuous forward flow during the whole of the cardiac cycle. As we age, the elastic fiber is replaced by amorphous material, and this is known as cystic medial degeneration. This degeneration leads to increased stiffness and weakening of the aortic wall, and this predisposes to more dilatation of the aorta. And also, additionally, according to the Laplace law, the dilatation of the aorta increases wall tension, which is a vicious cycle which leads to further aortic dilatation. If we talk about molecular findings, what causes the aneurysm of the thoracic aorta, it has been found that the main problem is a TGF-B1 signaling mechanism. Regarding the etiology, so there is a category where we talk about degenerative causes, where it's age-related usually, and we have atherosclerosis, hypertension, and cigarette smoking, as well as age to blame. And this is thought to be because of the increased activity of the matrix metalloproteinases, and these are the proteins that regulate tissue homeostasis. A very important cause for thoracic aortic aneurysms are connective tissue disorders, with the most frequent one being the Marfan syndrome, which is caused by a mutation of a fibrin 1 gene. And these people have their aortic root is predominantly affected. Then we have the Lloyd-Stitch syndrome. This is another syndrome where we have problems with the aorta in a younger age. And also we have Ehlers-Danlos syndrome, but we are talking mostly about dilatation and not aneurysmal growth of the aorta. Another important category is anomalies or congenital anomalies of the aortic valve. The most important, the most frequent one is when we are talking about bicuspid aortic, when we have bicuspid aortic valve, and this is also the most common congenital heart disease. Then we have the more uncommon unicuspid aortic valve and also Turner syndrome. When we have aortopathy, this leads to altered hemodynamics in the aorta, and this also leads to medial degeneration. All this causes aneurysms, aneurysm formation. Another reason, another cause for aneurysms, which we don't see so frequently now, is infectious causes. Especially syphilis was a significant cause 100 years or more ago, but not anymore. We also have bacterial, viral, and fungal infection. We have genetic causes. This is what we say, what we are talking is familial aortic aneurysms, which are sporadic, and they are not a part of any syndrome. There are also inflammatory causes, which cause aortic root dilatation. We are talking about Takayasu or Behçet disease. In this picture, we can see what the normal ascending aorta looks like with the root and the tubular part, and here we have the aortic arch. In Marfan syndrome, we have a dilatation of the aortic root, and also here we have a picture with the aneurysm of the tubular part. How do we diagnose the aneurysms? So often these are diagnosed as part of another examination. So transthoracic echocardiogram is the method of choice for screening and monitoring. It's very good to assess the aortic root and the proximal ascending aorta. However, the distal ascending aorta it cannot be visualized. The CT scan is a method of choice where the whole aorta can be visualized and can be reconstructed extensively. However, we have to bear into mind that we have the IV contrast and also the radiation exposure. MRI is equally good to show the aorta, however, it is not widely available. And also we have the option of the transesophageal echocardiogram, where the visualization is very good, but we must remember that this is an invasive procedure. When to intervene? There are a lot of talks about when to intervene and when to offer elective surgery to repair the ascending aorta. So the consensus is at the moment that when there are no other predisposing conditions apart from hypertension, surgery is offered when the aorta reaches 5.5 centimeters in diameter, or if the patient is undergoing another cardiac surgery with an ascending aorta above 4.5 centimeters, or if the growth rate exceeds 0.5 centimeter a year. For patients who have Marfan syndrome, the criteria are slightly different. So we operate when the aorta is a bit less in diameter of 5 centimeters or above, or in diameter of 4.5 centimeters with the presence of either a positive family history of complications, when the aortic valve has to be replaced, or when significant aortic valve regurgitation is present. Also, again, when the annual growth rate is more than 0.5 centimeters. In bicuspid aortic valve, we operate when the aortic diameter is above 5 centimeters, and in Loris-Stitch syndrome, it's less, as these people are more prone to complications, so the cutoff rate is above 4.2 centimeters. When we use medical therapy, by medical therapy we mean essentially medication, and the aim of the medication is to reduce wall stress in the aneurysmal aorta. Most important is a blood pressure control. Blood pressure control should be ideally below 120 over 70, and it has also been found that Marfan patients can benefit from beta blockers, propranolol or ACE inhibitors, losartan. Moderate physical activity is recommended. However, when we say moderate, we mean mild to moderate, and by no means any competitive sports, which can raise the heart rate. So, what is the role of surgery? The role of surgery, the elective surgery, is to replace the ascending aorta before any complications occur. And when we say complications, we mean essentially aortic rupture or dissection, intramural hematoma, or even aortic regurgitation. The type of surgery that is performed depends on the area of the aorta that is affected. If we have dilatation of the ascending aorta but the root is normal, then the surgery is a tube graft replacement, and we can use a PTFE graft. When the sinuses of Valsalva are involved, the procedures we use is either a Benton procedure, which is this is a composite valve graft replacement. So the aortic valve and the ascending aorta are replaced and the coronary arteries are reimplanted, or a valve sparing procedure. If we use a mechanical valve for Bentall procedure, then patients have to have lifelong anticoagulation. The valve sparing procedure can be done with different techniques which are slightly different. First is the David technique, which is one used preferentially. This is named after Tyrone David, where the aortic valve is reimplanted, or the Yacoub technique, which is named after Martin Yacoub, where the aortic valve is remodeled. There is also the alternative, the Rose procedure, which is used mostly in pediatric cardiac surgery. So this is used, and the aortic valve, if the native aortic valve is diseased, it is replaced by the native pulmonary valve. In general, all these procedures are associated with lower morbidity and mortality if they are performed electively. And the complication rates are less than 5%, and with this we mean stroke, MI, bleeding, and aortic regurgitation. The surgical repair can be used with standard cardiopulmonary bypass if the distal extent of the aneurysm allows room, which is enough to place an aortic clamp. If the distal extent does not allow an aortic cross clamp to be placed, so the surgery becomes a slightly more complicated, because then we have to consider an arch or hemiarch replacement with deep hypothermic circulatory arrest, with or without cervical debranching. In this picture, we have on the left, we can see an aneurysm of this is the ascending aorta, and this is the aneurysm, and here we can see where the arch begins. This is the aortic cannula, and this is the venous return. This is also a median sternotomy. And this is afterwards when the aneurysm is resected and it is replaced by a graft. And lastly, a few words about follow-up and screening. So when a patient is discovered to have an ascending aortic dilatation, but it's not, they have not reached the threshold for surgery, then the evaluation is usually annual. And this is performed with a CT scan. If the aorta is more than 4.5 centimeters in diameter, or if the growth rate is above 0.5 centimeters per year, then more frequent studies are needed, usually 3 to 6 months. However, for newly diagnosed patients, they need to have, after they are diagnosed, they need to have another imaging in 6 months to determine the growth rate. And then accordingly, either every 6 months if they are fast growers, or annually if the aneurysm is stable. Also, the imaging of the aorta is recommended post-repair. And lastly, because familial thoracic aneurysm disease can occur in different patterns, it is recommended that sometimes that first-degree relatives or affected people should have imaging as well, prophylactically. Thank you very much.
So, thank you. The next speaker will be Professor Musa. Tiva is not here, sorry. So the next will be Professor Fagioli from Italy, complex thoracoabdominal repair.
Τώρα μίλησε μια από τον Οφίνο θωρακοχειρουργός, η οποία την έβαλα και μίλησε για τα ανεβρίσματα της θωρακικής αυτής. Πολύ ωραία ομιλία έκανε, τώρα την ποιότητα. Και τώρα μιλάω Φλωρογιάννης από την Ευρωκλινική.
Οκ, Ελένα, τα λέμε, ναι.
Θα τα πούμε, ευχαριστώ, γεια σας κύριε.
Yeah. Are you online?
I'm online. Are you talking with me?
Yes, we can hear you.
Okay.
You can start.
Oh, okay. My program is a little bit different, but no problem. I'm ready. Thank you very much for the invitation. I'm going to share with you my my screen. I have no command for, okay, let me, okay. Can you see my slides?
Yes, it's fine now.
Okay, very good. So thank you once again. I'm sorry? I don't know if everything is okay. I will start my presentation. Thank you once more for the nice invitation. I'm talking about complex thoracoabdominal repair. Thoracoabdominal endovascular repair started in 2001 by the idea of Tim Shooter, who for the first time developed this technique. This technique has several advantages, which are not needing aortic cross clamping, no thoracoabdominal laparotomy, no single lung ventilation, no visceral ischemia. And this work was implemented by the terrific job of Roy Greenberg and subsequently from a series of very distinguished colleagues worldwide, as you can see here. The evolution of these complex endovascular procedures include planning, devices evolution, learning curve of the single centers, but particularly the possibility of a hybrid room. A hybrid room is a significant advantage for our procedure. We have seen that in our experience, starting from the first thoracoabdominal endovascular experience back in February 2010, and to achieve the 100 thoracoabdominal repair with the advent of hybrid room in January 2019. Why is hybrid room so important? It is important because it allows high imaging resolution with a shorter procedure time. The fusion imaging allows vessel navigation with very convenient engagement of the visceral vessels, as shown here. Our experience examined in a 10-year period from 2010 to 2020 include a variety of situations. We usually approach elective thoracoabdominal repair through custom-made endograft, as shown here, and urgent cases with off-the-shelf endograft. Urgent cases are defined as containing rupture, symptomatic aneurysm, or very large aneurysm with diameter greater than 8 centimeters, as shown here. We have also a very strict follow-up protocol with CT angiography before discharge and at 12 months and at 3 years with less invasive procedure in the meantime. A total of 155 cases, thoracoabdominal cases, have been performed in our experience, about 40% with off-the-shelf technology and about 60% in custom-made endograft. Technical success overall was satisfactory, over than 80% of cases, with 80% mortality at 30 days in this very highly complex pathology. Spinal cord ischemia overall is 10%. This is a main issue in this pathology. These patients are very complex patients, as shown by the demographics, with a lot of comorbidities, COPD in a significant number of cases, chronic renal failure, and even dialysis in some patients. These allow us to have a satisfactory complication rate with only 2 patients requiring dialysis after the treatment. And also our follow-up endpoints allowed a 3 years survival of 70% with a target visceral vessel patency of 92% and freedom from reintervention of 83%. So quite good results at the end of these complex maneuvers. There are 3 main issues in this pathology, which are prevention of spinal cord ischemia, visceral vessel patency, and how to deal with previous aortic surgery, which is pretty frequent in this patient. Prevention of spinal cord ischemia include a variety of medical maneuver with cerebrospinal fluid drainage, the maintenance of elevated mean arterial pressure, and try to avoid anemia as much as possible. But what we relied basically is a stage procedure. What does it mean? That means that we like to perform the repair in 2 different stages. Within the first stage, we repair all the visceral vessel we can, except for the celiac trunk. Sometimes we leave the iliac artery open, but this is our main goal, to leave the celiac trunk open in order to allow the perfusion of the sac for a few days, from 4 to 15 days, in order to have to keep the perfusion of the aneurysmal sac. And after that, we accomplish the procedure with the closure also of the celiac trunk. Another issue is maintain visceral vessel patency. This is according with a very significant analysis of the direction of the visceral vessel, as shown from this paper of our group from Enrico Gallito, who studied very carefully the impact of different direction of the visceral vessel to the visceral vessel patency in the long run. And this is very important in order to achieve the best curve and the best patency of the visceral vessel. Finally, previous aortic surgery. Previous aortic surgery has been studied very carefully again by our group, by Enrico Gallito, who showed that there is no difference in survival until the visceral vessel patency in patient with and without previous aortic surgery, with a little advantage in order in terms of freedom from reintervention, and this probably is due to the higher stability of the present of a previous autograft. In conclusion, ladies and gentlemen, the thoracoabdominal endovascular repair leads to encouraging short and midterm results. Endovascular treatment of thoracoabdominal aortic aneurysm is therefore our first choice in patients with aortic anatomy feasibility. However, high endovascular expertise and equipment are crucial to achieve this satisfactory result. I thank you for your attention from Bologna, Italy. Thank you.
Thank you very much. Next speaker will be Professor Florianis from Greece. Aneurysm of thoracic aorta, surgical repair versus endovascular treatment.
Hello from Greece, good morning. First, I would like to thank Professor Suleiman for his kind invitation to present you the topic of aneurysm of thoracic aorta, surgical repair or endovascular treatment. I have nothing to disclosure. The word aorta comes from the Greek word aero, that means lift, hold the heart. My mentor, Denton Cooley, was one of the first surgeons who confronted with this disease from 1952. By definition, aneurysm is considered an increase of aortic diameter more than 50%. If aneurysm left without treatment, the life expectancy is very poor. Starting from the aneurysms of the ascending aorta, we have to treat according to the recommendations. All patients with an aneurysm more than 50% for Marfan, sometimes more than 45 millimeters, whereas when the aortic valve is bicuspid, 50 millimeters are good enough. For the rest of the patients, 55 millimeters is the limit. However, there might be smaller diameter for patients with small stature, or those with rapid progression, or with aortic valve regurgitation, or planned pregnancy, and if the patient's preference is different. Otherwise, we have to follow those patients every 6 months, but we have to be more careful for patients with Marfan syndrome. We have different surgical approaching techniques for the aneurysms of the ascending aorta. Bental and De Bono proposed the composite graft to treat the aneurysm and the valve at the same time. Here is one of our patients with a big aneurysm due to bicuspid aortic valve, who was treated with a composite graft and reimplantation of the coronary ostia. Here is the left main anastomosis, and here we reimplant the right coronary artery. And this is the end result. And the patient was extubated in the operating theater to reduce postoperative complications. Sometimes coronary artery disease might be treated at the same time, and we use total arterial myocardial revascularization using bilateral internal mammaries, as in this patient, who has an excellent result 8 years after Bental procedure and total arterial coronary artery revascularization. The Cabral technique is using another synthetic graft to connect both coronary ostia. When we have aortic insufficiency, we try to save the valve, like in this case of a young patient, using David technique, and this is the result. However, Jakub technique is equally very effective, but in this case, we have to reinforce the aortic annulus too. The results are excellent for both techniques. Also, according to etiology, the results are very good, and these are the results that we published from Texas Heart Institute that are very good also. On the other hand, on the descending aorta, surgical results seem to be not so good as the endovascular result. Volobos in the former Soviet Union introduced that technique, whereas Greg Miller and Stanford put Cooley's diaphragm graft over a stent and popularized this technique. We have to be very careful to address the landing zone for additional success. Here is the preoperative study of one of our patients with an aneurysm of the descending aorta, and this is the immediately postoperative result. This is another patient of ours who had a dental procedure 13 years ago and redo open heart surgery and chronic renal failure. Endovascular, and now he developed an aneurysm of a descending aorta. Endovascular surgery here was very beneficial for this patient and was very successful. Once we cover the subclavian artery, my opinion is that we have to do most of the cases and carotid subclavian bypass to reduce the complications, like we did in this particular patient with an excellent result after a type B dissection. Neurological complications might be appeared during endovascular surgery. And recommendations are class 1 for descending aortic aneurysms. If they were studied very carefully and paying attention on some specific details. Now, Medicare beneficiaries are treated with an aneurysm of the descending aorta, are treated with endovascular treatment. Complicated acute type B dissected aneurysms have to be treated with endovascular treatment also. However, endoleaks might appear after endovascular treatment in a frequency of 60% at the first year and 90% at the second and 2 years follow-up. Customized grafts might be the future for the surgery of aneurysms of the thoracic aorta. And now we left the middle part, the aortic arch. How would we approach the aneurysms of the aortic arch? We may do Cooley's hemiarch repair under circulatory arrest or elephant trunk techniques, or we may approach it with hybrid procedure, open and EVAR at the same time, using the technique of frozen elephant trunk. Sometimes they may use the total endovascular arch procedure. However, when we have to deal with the dissected aneurysms involving the aortic arch too, we have to do with open heart surgery and circulatory arrest to replace the ascending aorta and the arch too, as in this case of our patients. However, recent publications show that surgical open surgery remains the gold standard. In summary, open surgery is the treatment of choice for the aneurysms of the ascending aorta and the aortic arch, whereas the EVAR is the treatment of choice for the aneurysms of the descending aorta and for the dissected aneurysms complicated with type B aortic dissection. From surgical centers that have been dedicated to these procedures. Thank you very much.
Thank you very much. The next speaker will be Dr. Saka. TEVAR for blunt thoracic aortic injury, when and where?
Good morning. Our topic today will be about EVAR for blunt thoracic aortic injury, when and where. Blunt thoracic aortic injury is a rare but potentially devastating event with a reported 85% hospital mortality. The injury represents the second most cause of death due to blunt trauma after head injury. Typically, blunt thoracic aortic injury is associated with significant concomitant injuries, including closed head injury, pulmonary contusion, long bone and pelvic fractures, and solid organ injury, increasing the overall morbidity and the mortality and making use of systemic anticoagulation problematic. Blunt thoracic aortic injury can involve any thoracic aortic segment, including occasionally even the abdominal aorta. The aortic isthmus is by far the most common location. Blunt aortic injuries involve a combination of forces including stretching, shearing, torsion, a water hammer effect, which involves simultaneous occlusion of the aorta and a sudden elevation in blood pressure, and the osseous bench effect from entrapment of the aorta between the anterior chest wall and the vertebral column. This diagram illustrated the various mechanisms involved in blunt thoracic aortic injury. The Society of Vascular Surgery has proposed a classification scheme for grading aortic injury that is based on the anatomical layers involved. Type 1 tear, grade 1 intimal tear, grade 2 intramural hematoma, grade 3 pseudo-aneurysm, and grade 4 rupture. Grade 1 and 2 are referred to as stable aortic injuries, whereas grade 3 and 4 are referred to as unstable aortic injuries. Using a new injury scale system, aortic injuries are classified as severe or non-severe. Severe, radiographic severe injury include findings of total partial aortic transection, active contrast extravasation, or the association of two or more of the following: contained contrast extravasation more than 10 mm in bigger dimension, periaortic hematoma and or mediastinal hematoma with more than 10 mm thickness, or left pleural effusion. Early diagnosis is paramount, as many patients with blunt thoracic aortic injury die within 24 hours if unmanaged. Due to trauma patients commonly being mentally incapacitated for a variety of reasons, chief complaints driving this diagnosis may not be present. CT angio is the gold standard as it enables rapid screening, 100% sensitivity, specificity that matches or exceeds the conventional angiography, inclusion in a whole body protocol to detect other injuries, and ability to plan for EVAR. Over the past decades, treatment of blunt thoracic aortic injury changed significantly, shifting from traditional open repair to endovascular repair. The Society of Vascular Surgery clinical practice guidelines recommended EVAR over open repair for all age groups with suitable anatomy. For grade 1 injuries, medical management alone is a mainstay of definitive therapy. Timing of aortic repair remains challenging. An analysis of patients undergoing early less than 24 hours and delayed more than 24 hours repair showed a significantly lower morbidity rate in the delayed group compared to the early group. The delayed approach allows for management of associated injuries and patient optimization before aortic intervention, which may account for improved outcomes. Of note, grade 4 lesions are not amenable to delayed therapy and require emergent intervention. Our case will be of a male patient, 22 years old, single soldier, involved in a road traffic accident, presented with thoracic aortic injury, intestinal obstruction, fracture right femur, bilateral mild hemothorax. Management strategy: the patient was involved in a road traffic accident in Aswan. He was transferred to Aswan University Hospital, where primary survey was conducted. After stabilization and confirmation of thoracic aortic injury using CT angio, and as he is a soldier in armed forces, they decided to transfer him to Maadi Hospital for further management. This triggered a series of simultaneous events. An emergency computed tomography slot was freed, the shock room was freed, the thoracic vascular orthopedic gastroenterologic surgery and anesthesiologic consultants were alerted. CAS tab was ready and the Bromedco company was alerted. The patient was transferred to our hospital by helicopter 24 hours after accident, arrived at Mahdi Hospital at 11 p.m. On the patient's arrival, he was received in the shock room for second survey, including history taking and proper physical examination. Patient was screened as per standardized imaging protocols. This was shortly followed by computed tomogram and angiogram, and the following data were assessed: proximal and distal landing zones, aortic diameters, distance from left subclavian artery, extent of injury. Full labs were ordered, and the blood was cross-matched. Procedure: 2 hours after arrival to emergency department, the patient was in the angiography room for EVAR. The procedure was performed under general anesthesia. Right common femoral artery was percutaneously accessed with a 5 French sheath, and a wire and a pigtail catheter was inserted in the aortic arch, and the aortogram was performed to confirm injury and confirm landing zones. Okay. Left common femoral artery was a site of stent-graft delivery through an open cut-down technique. The device was introduced under fluoroscopic guidance in the proper position. Okay, here is the injury. Here is the site of the left subclavian artery. Started deployment of the device. After complete deployment of the device, post-operatively, patient was managed in the intensive care unit for 48 hours. Chelixane was given subcutaneously. IV fluids, full labs were rechecked. Intestinal obstruction was managed conservatively. Fracture surgical neck right femur was fixed operatively. Follow-up: patient discharged at home 15 days after later, and asked for follow-up with CT angio at 1, 3, 6, and 12 months, and year after. 1 month after the EVAR, CT angio was done. And this is the CT angio. 1 month later, complete exclusion of the injury with preservation of left subclavian artery. Conclusion: the EVAR for blunt thoracic aortic injury is safe and life-saving procedure when performed in the proper time and will equip the place with an experienced team. In patients with blunt thoracic aortic injury without signs of imminent rupture, delaying in vascular repair beyond 24 hours after injury should be considered. Mean of patient transportation may be life-saving. Thank you.
Online, Professor Carlito, our experience with T-branch.
Can you hear me?
Yes, it's fine. We can see you and can hear you.
Okay. Just a moment. Okay, first of all, I'd like to thank the organizers for this kind invitation and all the friends from Egypt. My talk will be about our experience with T-branch endograft in the treatment of urgent thoracoabdominal aneurysm. EVAR and EVAR is an viable option for aneurysm involving renal and splanchnic artery, but this technology is associated with a custom-made device, so 8-12 weeks are required for the customization of the endograft. The Cook Zenith branch is an off-the-shelf device available in Europe since 2012 to treat acute thoracoabdominal aneurysm. It is an off-the-shelf multi-branch endograft with 4 downward branches for celiac trunk, superior mesenteric artery, and renal artery that require a 12 French sheath introducer. According to the anatomical feasibility study reported in literature, this device has a feasibility ranging between 50% and 8% of all thoracoabdominal aneurysm managed with an endovascular approach. Just some quick advice as regards the planning. First of all, we have to consider that the proximal ceiling is 34, the proximal diameter of the graft is 34 millimeters. So if we have to use the T branch without proximal extension, we have to seal in a thoracic aorta of 28-30 millimeter. Second, it's an important aspect to consider that we need to have space to guarantee the opening of the branch at the level of the paravisceral aorta. So the diameter at this level of the aorta should be more than 25 millimeters. And we have to consider that all target visceral vessels should be cannulated from this device. Another important aspect is that we have to deploy the branch cuff just 1.52 centimeters above the target visceral vessel. So we have to consider that we have a standard length of this graft, and in the most of cases, more than 15 centimeters of aortic coverage is performed above the superior mesenteric artery. So we have to consider a theoretical higher risk of spinal cord ischemia. We recently published in 2021 our overall experience with this device in the treatment of urgent thoracoabdominal aneurysm. The aim of this paper was to report our early and midterm results in urgent cases with this single device. It was a single center study where all urgent cases performed between 2010 and 2020 were prospectively collected and retrospectively analyzed. The definition of urgent cases were patients with contained rupture or patient with symptoms or a symptomatic patient with very large aneurysm, more than 8 centimeters. An important inclusion criteria for this type of treatment is this patient must have an hemodynamic stable parameters, and sure, we have to consider also the anatomical feasibility of the graft. Early endpoints were technical success, spinal cord ischemia, and 30-day or in-hospital mortality, while during follow-up, survival, target visceral vessel patency, and freedom from reintervention were assessed. Overall, 65 cases were considered in this study. 42% of them had a contained rupture, 12% had symptoms, and 46% of patients had a diameter more than 8 centimeters. The majority of cases had the Crawford extent type 1-3, and overall, 240 target visceral vessels were accommodated by branch. In this very slides, we underline the overall preoperative risk, cardiovascular risk factor, and demographic data of the overall patients, rupture cases, symptomatic and asymptomatic patients. In 88% of cases, a proximal thoracic endograft was required. In 66% of patients, an orthobiliac endograft was used, and in 12% of patients, an iliac branch was used to guarantee the patency of the hypogastric artery. It's an important data to underline that the 42% of patients were managed outside the extraction for use. And here we summarize the clinical setting of this patient and the anatomical criteria evaluation that we did. The technical success was achieved in 86% of patients with the patency of target visceral vessel at the completion angiography of 95%. And the technical failure were in the most of cases associated with the intraoperative renal artery loss. Spinal cord ischemia was reported in 17% of patients with only 5% of permanent paraplegia, and at the Fisher-Extra test, the postoperative dialysis and rupture cases were associated with this complication. 8% of patients required dialysis in the postoperative period, with a rate of 30-day mortality and in-hospital mortality of 14% and 19% respectively. Independent risk factor for in-hospital mortality at the multivariate analysis were the rupture cases and technical failure. It's clear that this cohort of patient is heterogeneous, so we have to consider different kind of pathology that we treated. It's clear that rupture cases had bad outcome, but if we consider the asymptomatic cases with large diameter, perioperative results are encouraging. The mean follow-up was 18 months, and the estimated freedom from target visceral vessel occlusion at 2 years was 89%. The freedom from reintervention was 60% at 2 years, and final survival was 47% at 2 years. It's clear that rupture cases had a very low mortality than non-rupture cases. Finally, I have to conclude with a brief literature review of this argument. Our study was one of the single center study with the larger experience and the larger amount of rupture cases. Technical success was in line with the literature data, the same for 30-day mortality and spinal cord ischemia. And finally, very few studies reported the follow-up data. Our mean follow-up was 18 months, and 2 years survival, freedom from reintervention and target visceral vessel were in line with the cases treated in urgent setting. So in conclusion, Mr. Chairman and dear colleagues and friends, T-branch is a safe and effective strategy for urgent thoracoabdominal repair, even in all-able situation, with acceptable rates of spinal cord ischemia and perioperative mortality. Reintervention and mortality during follow-up are not negligible, but they are justified by the preoperative risk of this patient and the urgent clinical setting. And finally, that is the most important message for this presentation, that is important to have an accurate patient selection for have a good outcome in this situation. Thank you for your attention.
Thank you very much. I think you will start with the next presentation about challenging cases. But what's the same?
Just a moment that I'll start with my video. Okay.
Okay.
Can you see the screen again? One
so
moment.
you may start.
Okay. It's okay.
Not yet. We can hear you, but the
Okay. I start again. Is okay?
Yes.
Okay. Now in this video, I'll show you a case of this kind of treatment in the presence of challenging anatomy. The patient is a 70 years old man with multiple risk factors that arrive at our attention for a thoracoabdominal aneurysm. Here we can observe the preoperative CT with a large thoracic dilatation of the aorta, the origin of target visceral vessel with some angulation and stenosis, and a very large aneurysm of the level of the abdominal aorta. So we started with our usual planning consideration. This is the information about the supraortic trunk origin and the proximal ceiling zone that was quite safe. The proximal ceiling was achieved with a 28 millimeter of diameter in the descending thoracic aorta. The thoracic dilatation was 7 centimeters about, and here we can observe some details about the origin of target visceral vessel. As we can see, we have several stenosis of the origin of target visceral vessel associated with a narrow aorta at the level of the renal artery origin and the angulation of the aorta in the paravisceral segment. Here we can observe the details about the diameter of the target visceral vessel and their origin according with the clock view during our planning. And and if we go to consider the, the most challenging target visceral vessel was the left renal artery that has a very stenotic calcification lesion and a stenotic calcification lesion associated with the angulation and a narrow aorta at this level that was 22 millimeters. We have no problem in the navigation of iliac artery. So we decided to plan our treatment with an endovascular approach due to the clinical condition of the patient with a multi-branched endograft device. We performed our consideration for the T-branch feasibility. We have no problem in the target visceral vessel origin, but if we evaluate the IFU of the device, we have a problem at the level of the origin of target visceral vessel where the aorta was less than 25 or 30 millimeters. We planned our approach with a multi-staging approach, as Professor Fagioli suggested before, to reduce the risk of spinal cord ischemia. So we start with the previous step with only a thoracic endograft that was performed and controlled by postoperative CT. Then we move with the second step with the T-branch endograft and all target visceral vessel treatment and the abdominal treatment. And in this step, we decided to leave open the contralateral iliac leg to guarantee the perfusion of the sac. Here we summarize the surgical access of these cases. We started with the two thoracic endograft, then we advanced with the T-branch endograft that was deployed with a partially deployment to guarantee the cannulation of the target visceral vessel in the narrow aorta. So we deployed the T-branch at the level of the celiac trunk branch, superior mesenteric artery branch, and Renal branch. At this point, we partially removed the handle for the reducing time, and then we removed the second handle that guaranteed the opening of the T-branch with the proximal part of the T-branch with the distal part that was not deployed. So we go from the above and we start with the cannulation of the renal artery that at the origin at the level of the narrow aorta. We start with the left one that was the most challenging cases. We cannulate the renal artery. We changed our guide with the Rosen, and then we started with our bridging stent. We deployed the stent in one of the two branch of the main renal artery. We deployed a self-expandable stent distally, and then we completed the bridging with a balloon expandable stent graft at the level of the cuff. We relined with a self-bar expandable metal stent, and this was the angiographic check of the renal artery. The same was performed from the right renal artery, so we cannulate the renal artery. We deployed the distal self-expandable stent, and we complete the proximal implant with the balloon expandable stent graft, and we relined the bridging stenting with a self-bare metal stent with the final angio. At this level, we maintain the guide at the level of the left renal artery. We inflate a balloon, and we completed the deployment of the distal portion of the T-branch in order to avoid any compression of the bridging stent for the left renal artery. We complete our implant. We complete the total deployment of the reducing time of the graft. And now we definitively complete the deployment of the whole device. We performed the implantation the aorto B iliac, uni-iliac endograft at this level. We move in the iliac artery sealing at the level of the common iliac artery, and then we perform a kissing balloon of the aorta at the level of the origin of renal artery. At this point, we start from above and we complete the bridging stenting with the cannulation of the superior mesenteric artery, with the bridging stent with self, Stent-graft distally and the balloon proximally, as we can see, and again relining of the bridging stent with the final angio of the superior mesenteric artery, and the same was performed for celiac chunk. So cannulate the artery and bridging stent with just a balloon expandable stent-graft, because we have to cover a short length between the branch and at the origin of the target visceral vessel. And this is the final angiographic check of the celiac chunk. This was the post-operative CT between the second and third step. We have the patency of all target visceral vessel, also for the renal artery, and the distal endoleak that was sealed in the third step by the iliac leg deployment that was performed with the surgical access of the femoral artery. So we cannulate the gate, we evaluate the origin of the hypogastric artery, and we complete the treatment with the iliac leg. As we can see. So we deployed, we balloon the distal portion to guarantee the sealing, and the final retrograde angio evaluate the origin of the hypogastric artery. So the post-operative course was uneventful. Patient had no problem in renal function worsening, no spinal cord ischemia or visceral ischemia, and was discharged home after 16 days of hospitalization. Thank you for your attention.
Thank you very much. Very promising results. Now we hear something about neurological complications after TEVAR. Professor Kusaya.
Good morning, everyone. Sorry. First of all, I'd like to thank Dr. Mustafa Sulaiman for inviting me for this really nice meeting. I'm going to speak today about neurological complication after TEVAR. I'm going to speak about spinal cord ischemia and stroke. Spinal cord ischemia, all we know the blood supply of the spine comes from the intercostal lumbars and subclavian and internal iliac arteries. But the most important is the artery of Adam-Wickes, which will come from T8 to T12. The factor for CSI in TEVAR is the length of the operation, hypotension, the extent of thoracic aortic coverage, especially if we cover T8 to T12. The indication for intervention, do we do it for aneurysm or dissection? Female gender and inadequate collateral circulation because of left subclavian coverage without bypass or prior AAA repair. But in general, the CSI after TEVAR is about 3 to 8% only, comparing with the open, which is about 5 to 20%. There's difference in CSI between open and endovascular. In open, the CSI happen because of the cross-clamping and prolonged hypotension. So we prevent it by retrograde perfusion, cooling, CSF drainage, intercostal reimplantation. In general, in open repair, we see immediate more than we see a delayed CSI in the patient. In the TEVAR, there's no cross-clamping, no limited hypotension, but the problem, we don't have the legacy of reimplantation of the intercostal artery. How we prevent it in TEVAR? By limited coverage of the important arteries, especially T8 to T12, and maintenance good perfusion to the spine. And in general delay, spinal cord ischemia is more common after TEVAR than an open. How we prevent CSI? Early diagnosis is very critical. We need to increase the spinal perfusion by reducing the CSF pressure less than 10 and increase the mean arterial pressure more than 90. We need to identify and avoid covering the important spinal arteries, especially T8 to T12, and CT angiogram could be sometimes very helpful. Sometimes what we saw from the last case, we leave a type 3 endoleak. So if we do complicated thoracoabdominal aortic aneurysm, we leave off the branch open to keep perfusion to the sac, and we come later on to close this type 3 endoleak. And lastly, we treat reperfusion injury by naloxone and scavengers. So when we do CSF drainage, some people do it routinely, but we like to do selectively. If we cover the thoracic aorta more than 20 centimeters, if patient has a prior AAA repair, if we cover left subclavian artery without bypass, and if the patient has an occluded internal iliac artery. And therapeutic if patient develop any signs of numbness, tingling, or paralysis after surgery. This is very important protocol. When you send patient to the ICU, it's very important to give this protocol for the ICU team. You need to zero spinal pressure monitor to the level of spine, because ICU people, they used to level all the line to the level of the heart. We need to keep the spinal drainage less than 10. Don't drain more than 20 cc per hour because you may get subarachnoid hemorrhage or fatal brain stem herniation. If CSF drain bloody anytime, turn it off. We need to keep spinal drainage at least for 2-3 days. So even if you come next day and there's no neurological symptoms, you need still to keep it at least for 2 or 3 days and avoid hypotension. If patient develop a delay neurological deficit, then you have to check. If patient has a CSF drainage, then be sure that it's working. It's not king, it's not thrombose. If patient doesn't have a CSF drainage, then you need to insert it as soon as possible. And all studies show that the sooner you insert the CSF drainage, the quicker the patient will recover from his neurological deficit. You need to increase the arterial pressure more than 90. You need to keep good spinal cord perfusion because we know it's equal to mean arterial pressure minus the ICP. You need to avoid hypertension. It's very important to write in your protocol to keep saturation more than 95% and hemoglobin more than 10. So in summary, CSI remain a major morbidity after TEVAR. Also, the incidence is less than open repair. High-risk patient include the female who has, patient has a long coverage of thoracic aorta, extensive aneurysmal disease, prior AAA and left subclavian artery coverage. Careful preoperative planning and identification of critical artery is very important. How we prevent it? By limit lengths of the coverage, keep mean arterial pressure more than 90, employ CSF drainage and keep CSF pressure less than 10, and elective revascularization of left subclavian artery. Now we move to the stroke. This is a very nice paper published recently. They look at the silent cerebral infarction, which by definition is a brain injury detected incidentally on imaging MRI without acute neurological dysfunction. Why is it important to look at that? Because they found that the silent cerebral infarction can increase the risk of future stroke, can cause dementia, depression, cognitive impairment, and early death. And when they use the TCD to look at the hits during the procedure, they found that the patient, he get embolization in every step of the procedure. But the majority of the embolization happened during contrast injection and stent deployment. Also, they noticed that the older age of the group, they have a significant positive decline in their neurocognitive test. So they do worse than younger people. What the pathology could be an air, thrombus, or particle from the aortic arch. How we can protect from the stroke by patient selection to avoid shaggy aorta, giving statin and stop smoking. We need to minimize the catheter and wire implant manipulation. Try to keep an ACT at least between 250 to 350. Some people, they use temporary occlusion of carotid artery or left subclavian artery. Recently, we started using CO2 flushing to get the air out from around the graft. And again, recently, we started using the CEP devices. We have about 5 available in the market. The one we used commonly now is a Sentinel cerebral embolic protection. This is the only FDA approved device. It's go through the 6 French go through the radial artery. It's very simple. It has 2 filters, 1 stay in the intimate artery and 1 stay in the left subclavian artery. Like this one of our cases, you can see the 2 filter. one in the left innominate artery and one in the left common carotid artery. And this is during the procedure, and you can see all this debris being removed during the procedure. And this study showed that if you use sentinel device, you decrease all stroke and mortality in 7 days. The other device is the Edward embolic detector. It is CA market, and also it has a radial axis. So in conclusion, high rate of cerebral embolization and neurocognitive decline happen after TEVAR. Brain injury after TEVAR is more common than we thought. All TEVAR had a TCT detected cerebral embolizations, and overall brain injury is 81%, but luckily clinical stroke only 8%, and silent infarction only about 68%. Thank you very much.
Thank you very much. Last speaker will be Professor Ritzk. Stroke, spinal cord ischemia, and upper limb ischemia in patients undergoing TEVAR with coverage of left subclavian artery, the case series study.
Good morning. I'm talking about stroke, spinal cord ischemia, and upper limb ischemia in patients undergoing TEVAR with coverage of the left subclavian artery, a case series study. To achieve a successful TEVAR procedure, we must have an adequate proximal sealing zone. In 1/3 of patients, this seal zone will not be reached unless we cover the left subclavian artery. This may be associated with spinal cord ischemia, stroke, and upper limb ischemia. So what are the protective measures? Either left subclavian revascularization or spinal fluid drainage. Up till now, there was no consensus regarding revascularization of the left subclavian artery. Other investigators concluded that it's safe to cover the left subclavian artery without revascularization, such as Lee et al., who concluded that it's safe to cover the left subclavian artery without revascularization in patients having bilateral patent vertebrobasilar junctions. Another notion by Maldonado et al., who noted that revascularization of the left subclavian artery is associated with increased incidence of cerebrovascular accidents. What about CSF drainage during TEVAR? Drainage of CSF has been widely practiced during open repair, and it is accepted and recommended. But the role of CSF drainage in TEVAR is less defined due to lack of randomized studies or high-quality observational studies. So we turn to our patients. Between July 2014 and April 2020, 23 patients had thoracic aortic pathology, to which we did TEVAR for them. These patients had no proximal sealing zone, safe without covering the left subclavian artery. All patients were subjected to careful history-taking examination, routine preoperative investigations, cardiological examination, and we excluded patients with CABG with left internal mammary artery used. Pre-interventional imaging was done using CT angiography to plan the procedure and plan the number of stents, and we did oversizing by 10 to 20% according to the thoracic pathology. We adopted a routine spinal protocol, drainage protocol. A spinal catheter was inserted preoperatively. We initially drawn 10 milliliters slowly after insertion of the catheter. Then we drew 10 milliliters again during deployment of the stent. We kept the CSF pressure below 10 to 15 millimeter mercuries, and we left this spinal catheter for 48 hours for follow-up. Patients, after the procedure, patients were awakened, checked for signs of stroke, upper limb ischemia, and spinal cord ischemia, and then transferred to the ICU. This is the demographic data of our cohort. This is the aortic pathology. We had 17 patients with dissection, 5 patients with aneurysm, and 1 patient with a thoracic ulcer. In the procedure, we deployed 3 endografts in 1 patient, 2 endografts in 13 patients, and the rest of patients we deployed 1 endograft. The choice of the number of stents was planned preoperatively. In our results, we had 1 death. Also, this patient had spinal cord ischemia 6 hours after the procedure. This patient was having an aneurysm of the thoracic aorta. This patient had an ejection fraction of 35%, and this patient was planned for CABG, but the cardiothoracic surgery refused to do the CABG before repairing the aneurysm. We had 1 stroke, and we had none patients with acute upper limb ischemia. 2 patients developed post-implantation syndrome in the form of fever that subsided after 2 weeks and was managed conservatively. All patients did not show any sign of development of stroke, except for 1 patient who developed stroke, left-sided hemiparesis, 3 months after the procedure. This patient was investigated and was found to have minute infarcts in the right temporal and parietal lobes. This stroke was related to the anterior circulation. Immediately after deployment of the endografts, all patients lost their left radial pulsations, but there was no signs of acute ischemia. During follow-up, left upper limb symptoms were noted in 4 patients in the form of upper limb claudication and tingling sensation that was managed conservatively. This is the follow-up after 6 months. Some of the patients, we were not able to see the origin of the left subclavian artery, and others, the left subclavian artery was seen. The rate of spinal cord ischemia during TEVAR, though it's less than open surgery, it ranges from 3 to 5%. Mazifi et al. Performed routine spinal drainage in high-risk patients undergoing TEVAR, and the overall rate of paraplegia was 2%. In the study by Suarez Pierre et al., which was done over 4,000 patients undergoing TEVAR, it was found that the rate of spinal cord ischemia was 2.5% in patients who underwent TEVAR with spinal drainage and without spinal drainage, and 1.5% in patients with spinal drainage. As for the left subclavian artery coverage, in the beginning it was mandatory to revascularize the left subclavian artery. This was in 2005, but this was not a common practice after then. In the meta-analysis by Reeds v. et al., there was a low-quality evidence suggesting that covering the left subclavian artery is associated with significant increase in arm ischemia, vertebrobasilar ischemia, and spinal cord ischemia, and anterior circulation stroke. Revascularization of the left subclavian artery is a procedure that carries an increased rate of morbidity, and it's done to decrease the risk of stroke and spinal cord ischemia. But as we can see from the above results and the discussion, that the benefits of this procedure is still debatable, as well as the need for routine spinal fluid drainage. Using either methods have a Class C evidence recommendation, which is not backed up by randomized controlled studies. So we need more randomized controlled studies to end up this debate. Thank you.
So thank you very much. We have little time for discussion and some questions. Any question to Professor Colocotroni? To Professor Fagioli?
Yeah.
Okay, thank you. There are no questions. Goodbye, thank you very much. Professor Xloraghinis. Questions to, yes?
The instance of using the T branch, the instance of using the T branch for urgent cases, I think that this is the best way of using the T branch rather than elective, and we have to increase the usage of the fenestrated and the custom-made more than using the T branches. The bias, especially in the COVID era, is the long manufacture, how long does it take? That for Europe and for Egypt 6 months, which is a long time. But I urge people to decrease using the T branch for elective cases. One fits all is not a good way of dealing with things.
Can I answer?
Yes, of course.
Okay, thank you for your answer. This is a very appropriate, interesting observation. We published in the JVS 2020 our experience of complication during the waiting time of EVAR custom-made device. And our mean waiting time from the order of the endograft and the implantation was 89 days, so it's about 3 months. In these 3 months, the rate of patient mortality of rupture during the waiting time was 1.5%. And an independent risk factor for the rupture was the preoperative diameter of the aortic lesion more than 7 centimeters. So according with these results in our clinical practice, if we have a thoracoabdominal lesion with a diameter more than 7 centimeters with the anatomical feasibility for T-branch, we usually prefer to use a T-branch. It's clear that we have to have the anatomical feasibility. If we treat a patient in election, we have no go outside distraction for use. So for elective cases with anatomical feasibility of T-branch, we prefer to use T-branch. It's clear that the problem is when we approach patients with juxtaparietal aneurysm, that you have to cover a lot of aorta in comparison with custom-made device. So I think that it's a very important question and depends from the anatomy. If the branch has a good anatomy, I think that it could be a feasible option. The big problem of the branch in elective patient, or usually in general branch for renal artery, because the branch for renal artery are a low patency in comparison to fenestration. So if it's possible to move to fenestration in cases of juxtaparietal lesion.
Okay, thank you very much. One question again.
You say that you started education if you have a lumen more than 25. by less than 30, you have two more major problems. First one, you have difficulty to cannulate the visceral vessel. The second problem, you have also no place for inflation of your branches. Is that right or not?
I'm sorry, but I didn't hear the answer. Can you repeat for everybody?
Yes, you say that you started your indication if you have a lumen more than 225 millimeter, but normal by 225, it's very.
Okay. It's about the diameter of 25.
Yes, if you have a less than 30, you have major problem that the branch have no place for inflated. On the same time, you have a problem to cannulate the visceral vessel.
Yes, it is a very important point. If you have less than 25, you have problem to cannulate the target visceral vessel, and also during follow-up, because you can have compression between the branch, the aortic device, and the branch for renal artery. So it's clear, if I had an elective patient, I don't use the branch, I use fenestration device. It's clear. But if we report this approach in urgent cases where you have contained aortic rupture, symptomatic patient, in these cases, you can move in this approach with a partial deployment of the graft.
Okay, thank you very much. We move to the next one. Any questions to Dr. Saka?
Thank you very much for your nice presentation. My question is, do you routinely do CSF drainage, or do you have some selection criteria for that? Because, you know, some data now shows some problems with the CSF technique drainage.
Yeah, no, we do selectively. If we cover more than 20 centimeter of thoracic aorta, then yes, we do carotid subclavian bypass. If patient has main vertebra, the left is the main vertebral artery. Is the vertebra coming from the arch, if he has like a limma, if he has like dialysis access in the left arm, if he has a prior AAA, if he has left internal iliac artery occluded. So anything put patient on high risk for spinal cord ischemia, we prefer to do carotid subclavian bypass. This answer? Yeah, so we do selectively, not routinely. Yeah.
Any questions to Dr. Risk?
It's rather also a comment. I'm very much in favor of selective coverage of the left sub. I'm very much in favor of when we cover the left subclavian in selective use of a carotid subclavian bypass. Carotid subclavian bypass has its complications. I'm not, we shouldn't use it as a routine.
So thank you for this comment. Thank you to all chairpersons. Thank you to all presentators. It was a very interesting session, and I will close the session. Yes, after Goma.
I want to thank the panel, the moderator and the chairpersons and the audience, of course. It was a very hot session. We have a break now, and then for Goma prayer, and then we will meet again at 1 o'clock exactly here again. Thank you.
We thank you very much.
Thank you.
Thank you. Goodbye.
ممكن تجيبوا المايكات بقى ايوه هات كله
Test mic test, test mic test, test mic test.
Test mic test.
Test mic test. Test mic.
Test mic test. Test mic test. Test. Test mic test. Test mic test. Test. Test mic test.
بص يا اسطى اول حاجه دي كده بترفع وكده بتدخل ايوه ماشي
Test mic.
ماشي ده رقم كام 3 ده
Test mic test. Test mic test.
Test mic test. Test mic test. Test mic test. Test mic test. Test mic test.
Test mic test.
Test mic. Test mic. Test mic. Test test.
Test mic test.
Test mic.
مكتوب عليك ايه؟ عليه 75 مش ستيكر. ادي وقت الاستيكرات. سبعة 45.
رقم كام؟
ايه تعالى بقى نشوف الأول. جلوكوز اهو في الكراسي عشان ما تبهدلش المايكات كلها محمد علي ملعوب.
تيست مايك تيست.
نفس ده.
لا ده 8. بص ده 8 اهو.
طب اقفل.
تيست مايك تيست. تيست مايك تيست. تيست مايك تيست. تيست مايك تيست.
تيست مايك تيست.
Test mic test, 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 test. Test mic test, test mic test. Test mic test, test mic test, test.
تيست اهم. الاربعه دول احنا عاملينهم. تيست مايك تيست. ده 3 انا معايا ده 3. ده 3 ده.
Test mic test, test mic test.
ده 3 ده.
Test mic test, test mic test, test.
عايزين بس نبصوا.
Test mic test, test.
4 و7 و8. 6 و8.
Test mic test.
تيست مايك تيست. تيست مايك تيست.
Test mic test.
تيست مايك تيست. ده 3. تيست مايك تيست. 4. تيست مايك تيست. تيست مايك تيست. تيست مايك تيست. تيست مايك تيست.
خش كده شوف.
لا هو 7. هو 7. هو 7. تيست مايك تيست. تيست مايك
تيست مايك.
انا قلت لك ده 7.
هلو تمام.
اللي معاه 7.
هلو هلو ده 3. هلو هلو عليه شويه يا حمدي، ده واطي قوي لازم تقربه. علي الهاي، علي الهاي، الهوا بتاعه ده عشان يلقط بس. ده اللي بيجيب لك اللاين ان انت تبعد الصوت بتاعه. يا عم اعمل بس كده. هلو 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 تيست تيست.
تيست مايك تيست.
تيست مايك تيست. ده 7. في حد بياخد كابلات اتش دي من هناك؟ هلو 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 اقفل 7. ماشي اقفل 5. في حد بياخد من القاعة الصغيرة، شوف في ايه مش عارف. هو انت مين اللي هناك بيلم كابلات اتش دي؟
تيست مايك تيست. تيست مايك
طيب
تيست.
ماشي شوف يا ابو محمد.
تيست مايك تيست.
بسرعة يا محمد.
تيست مايك
تيست. تيست مايك تيست. ده صوته حلو قوي كده يا حمدي. هلو هلو تيست مايك تيست. تيست مايك تيست.
تيست مايك تيست. تيست مايك تيست.
ده واطي قوي.
بس خلاص.
تيست مايك تيست. تيست مايك تيست. تيست مايك تيست.
حمدي انا عندي الاثنين. بص ثانية واحدة، انا عندي المايك ده لايت على
لا لا هو 3 فاتح.
هلو 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 تيست 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 تيست.
لا انا عارف هو بتكلم في ايه. لقيت في 7.
ايوه صح كده. هلو هلو بسم الله. نزل ال7 ده خالص بقى كده صح.
تيست مايك تيست.
ده اما تغير التردد بتاعه يا اما نشيله.
ده اللي معاك؟ ده اللي مش لاقط صح؟
غير التردد بتاعه لانكم عليه. تيست تيست تيست.
تيست تيست. تيست مايك تيست. تيست مايك تيست.
تيست مايك تيست.
تيست مايك تيست.
لا احنا عايزين من بعيد، احنا مش عايزين. احنا عايزين الصوت يبقى كده الناس تبقى سامعه.
تيست مايك تيست. تيست مايك تيست.
هلو 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 تيست مايك تيست. تيست مايك تيست.
عايزين نكتب عليهم.
تيست مايك تيست مايك تيست. هلو هلو.
طب اللي شغلناهم طب نقفلهم يا احمد عشان ما نزودش.
لا خليهم شغالين، مش هم اللي لوحده؟
اه
انا عايز واحد كمان. الشاشة عملت كده ليه؟ ده 47 3 اصفار.
بص يا رؤى احمد عايز ايه؟ مايكين هناك. اه ماشي. بص بقى يا ريس. بص 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 بقى يا ريس. دول خليهم ايه؟ ممكن تديني بس دقيقة يا احمد عشان ارص الموجات فوق. معلش دقيقة واحدة.
طب ثانية واحدة عايز افهم حاجة. افتح لي الماركات اللي معاك، قول لي الترددات كده في اللي شغالين.
ماشي اللي شغال 74. لا 7 4 5 5 8 5. ماشي. تاني 7 7 5 3 اصفار. 7 7 5 3 اصفار. و 84 0 0 2 5. اهو ده؟ اه في النص.
وريني كده.
74900 74900
دول الأربعة اتفقوا دول رصهم لي مع بعض.
هو ازاي ده شغال طيب؟ تيست مايك تيست
وده رقم
تيست ده اللي انت طفيه بقى ناحية ده اللي انت طفيه غالبا يعني انت قلت كده هو ده اللي انت طفيه سبعة أربعة تسعة تسعة زيرو زيرو موجود عندك؟
أيوة دول الاتنين اللي مطفين.
8400 موجود عندك؟ 8425 هو ده 74990
ماشي. ايه تاني؟
8425
موجود.
745 58
خد اهو.
هو ده
سيبه ده خلاص ماشي كده غير
في 77 5 3 اصفار
هو فين اللي انت بتقول 74558 الفعل ده؟
السلب رقم كام؟ السلب رقم 2 ديليت 6 انا فاتح المايك لا كله مفتوح تيست 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 مايك تيست 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 مايك تيست تيست مايك تيست
دول الأربعة جربهم تاني.
اللي هناك ده اللي
أنا فاتح الأربعة يا جدعان.
تيست مايك تيست مايك تيست تيست
امسك جرب كده واحد واحد. ثلاثة معاك يا ولد.
ثلاثة معايا.
أربعة.
تيست تيست تيست
5.
تيست 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 تيست
تيست مايك
ممكن تشد هنا ما تمدش ايدك عليه. ده ما تمدش ايدك عليه.
تيست تيست اهو مفيش تيست 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 مايك تيست تيست مايك تيست
6 فضل ده صح؟ ده اللي هو 7 4 5 8 5 تيست تيست بس ده ايوه ياسر التاني اللي كان شغال. طب هو فين التاني؟ افتح الريسيفر من دول كده.
هقول لك انا والله
هم دول التلاتة اللي شغالين.
طب بقول لك ايه، صح؟ همشي الناس. تقول لي اه لا براحتك.
ايوه يا عم
هقدرهم ساعتين؟
قدامك عايز اقدمك.
انا بقول لك انت عشان لو في حاجه انت ضارب بس ابقى انا فاهم. ها؟
يا جو اعمل
أقول
اللي
لهم
انت
امشوا
عاوزه.
اتنين.
هات لي المايكات الاول. لا والله الكبسولة مفكوكة يا اسطى. هات لنا محل نعمل حتة خشنية.
معلش بس احنا بجرب حاجة عشان ايه نعرف احنا هنفتح ايه. ماشي. مفيش مايك تاني ها؟
هو فين انت عايز تعمل خشنية؟ اهو سيبه. مش هينفع، عايزين ناس. مش هينفع ولا عايزين حاجة تمسك فيها. وده كان شغال معانا امبارح. دول الأربعة، دول التلاتة اللي في ايدك صح؟ ماشي. فين الاتنين الهيدسيت؟
Test mic test. Test test. Test mic test. Test mic test. Test mic test.
Test, test, test. Test mic 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 test.
Test mic test. Test mic test.
Test mic test. Mic test. Mic test.
Test mic test. Test mic test.
Test mic test. Test mic test. Mic test.
Test mic test.
تيست مايك تيست تيست مايك تيست تيست مايك تيست لا ده مش ثلاثة تيست مايك تيست
Test mic. Test mic test. Test mic test. Test 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 mic test. Test mic test.
تيست مايك تيست تيست مايك تيست تيست مايك تيست 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 مايك تيست مايك تيست
تيست مايك تيست تيست مايك تيست هذا عزم تيست مايك تيست
Test test test. Test mic test. Test 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 mic test.
تيست مايك تيست
أنهي واحد؟
تيست مايك تيست
Test test test.
تيست مايك تيست مايك تيست
تالي سبعة.
تيست مايك تيست تيست مايك تيست
تيست مايك
ده
تيست
سبعة.
تيست مايك تيست تيست مايك تيست
Test mic. Test mic. Test mic. Test test test.
تيست مايك تيست
تيست مايك تيست تيست مايك تيست تيست مايك تيست تيست مايك تيست تيست مايك تيست تيست مايك تيست بس ثلاثة وأربعة وخمسة تيست مايك تيست تيست مايك تيست لا ده خمسة
Test test mic test.
تيست مايك تيست Test mic test. Test mic test. Test mic test. Test. Test mic test. Test mic test.
تمام كده؟
Test mic test. Test mic test. Test. Test test. Test mic test. Test mic test. Test mic test. Test. Test mic test.
في حاجة ها؟ طب أنا عندي 5 لسه، اللي معايا ده 5، اللي معايا ده 3. هات لي علي علي.
Test mic test.
بس دول كده تمام. هتسيبهم مفتوحين بس هم ما بيعرفوش يفتحوهم. البطارية هتفضل. هم ما بيعرفوش يفتحوهم. البطارية هتفضل. لسه قدامنا شوية.
Test mic test. Test mic test. Test mic test. Test mic test. Test mic test.
Test mic test. Test mic test. Test mic test. Test mic test. Test mic test. Test.
749 749 900. مش شغال اهو.
تيست مايك تيست. تيست مايك تيست. تيست مايك تيست. تيست. تيست مايك تيست.
تمام كده.
تيست مايك. تيست مايك تيست. 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 تيست مايك تيست. تيست مايك تيست.
Test, test, test. Test, test, test mic test. Test mic test. Test. Test mic test. Test, test, test. Test mic test. Test mic test. Test. Test mic test.
Test mic test. Test mic test. Test mic test. Test mic test. Test 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 mic test. Test 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 mic. Test mic test. Test mic test. Test mic test. Test mic test. Test 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 mic test. Test test.
تمام كده. ماشي.
Test mic test. Test mic test.
كل ده في اللايف بتاع الزوم. الدكتور عمال يقول لي كل ده طالع في الصوت وبتاع. ده في الزوم؟ قفلت الصوت انا برضه جاي. عامل الفلاشة خالص؟ استنى انا قفلت.
This mic, this mic, this mic, this mic, this mic. Hello, hello. Hello, hello.
Test, 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 mic test, test, mic test, test, mic test, test, mic, test, mic test, test, mic test, test, mic test. ده يعني وطي وطي. test, 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 mic test, test, mic test, test, mic, test, mic.
هتحط المايك اللي على الستاند ولا لا؟ مش هتحط الستاند يا مستر؟
Test mic test. Test mic test.
Test mic test.
This mic,
Test mic test.
this mic. Hello, hello, hello. This mic, this mic, this mic.
Test mic test. Test 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 mic test. Test mic test. Test mic test.
Test, 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 mic test. Test.
Test mic test. Test mic test. Test mic test. Test mic test. Test mic test.
Test mic test. Test mic. Test mic test.
Thank you very much for rejoining us in our meeting. And now the session number 8, under the name of challenging cases. Let me introduce Professor Dr. Ayman Abdel Fattah and Professor Dr. Hisham Sharaf, our chairpersons. And we will start with the first presentation, and Professor Dr. Ayman Fattah will present the first presenter.
Good afternoon, everybody. We'll start our session by a talk of ruptured abdominal aortic aneurysm with 2 aorta major venous fistulae. Is it possible? This will be introduced by Dr. Hamdi Abu Nil. He is a lecturer in our university, in Shams University, Egypt. Welcome, Dr. Hamdi.
السلام عليكم. نبتدي البرزنتيشن النهارده بتاعت the rupture AAA with two aorta major venous fistulae. Is it possible? Let's start with introduction by basic scientific background. As regard that the many patients of rupture AAA die before reaching the hospital. The more recent
Dr. Hamdi, the mic closer to your mouth, please.
The more recent estimates of rupture AAA incidence are likely underestimating the 2 incidents. Despite the widespread belief that rupture AAA present with classic triad of back pain with or without abdominal pain, hypotension, pulsatile abdominal mass, this triad is only present in 1/4 to half of all rupture AAA patients. Depending on the site of rupture, comorbidity of the patient, condition of the institution, or rescue team, the rupture AAA can be misdiagnosed in up to 30% of patients as myocardial infarction patient, ureteral stones, GIT perforation as provisional stomach, duodenum, gallstones, peptic ulcer, and their respective diagnostic pathway may considerably delay the diagnosis and treatment of this life-threatening issue. In contrast, the vascular surgeons must be aware that those diseases may mimic rupture AAA and that these misdiagnoses can be quite troublesome when rupture AAA is only detected after emergency laparotomy. Individual person suffering from rupture AAA may present in many ways. The most typical presentation is abdominal pain, back pain, with transient hypotension or syncope. However, some symptoms may be vague and abdominal parasitic mass may or may not be present. Depending on the localization of the rupture, the diagnosis may be confused, as we said before. On the other hand, patients with rupture AAA may present in frank shock as evidenced by cyanosis, mottling, unconsciousness, tachycardia, and severe hypotension. That's why we can divide the presentation of rupture AAA as usual presentation or unusual presentation. The usual presentation is the rupture in the retroperitoneal space or intraperitoneal cavity, or unusual, which is rarely occur due to rupture of the rupture of the aortic aneurysm in abdominal veins or hollow viscous. Let's talk about the aortic cable fistula, in which the rupture occurs in the inferior vena cava, which will produce an aortic cable fistula of varying diameter with variable clinical presentations. The high output congestive heart failure may be the leading manifestation with patients showing dyspnea, pulmonary edema, tachycardia, wide pulse pressure, cyanosis, and dilated superficial veins on abdominal wall or legs. A variety of other symptoms may mislead the clinicians in making the correct diagnosis of rupture AAA in the form of aortic cable fistula, as vaginal pectus, palpitation, rectal bleeding, oliguria, venous insufficiency, and hematuria, and acute hepatorenal failure. Probably half of all aortic cable fistula are missed, and aortic cable fistula is frequently incidentally detected during the elective AAA surgery. Hypotension, pulsatile abdominal vein, diminished lower limb pulses may eventually lead to correct diagnosis when detected. That's why it's important the clinician and emergency staff be trained in detecting aortic caval fistula by preoperative detection. It's important nowadays. It should be accomplished by contrast enhanced CT angiography. On the other hand, the other issue in the unusual presentation is aorto left venal vein fistula, in which the rupture occurs in the left venal vein, which is equivalent to aortocaval fistula with special considerations. This type of aortovenous fistula behaves similarly to aortocaval fistula with a possible high output congestive heart failure and all clinical presentation as mentioned before. Due to its rupture site into left venal vein, the symptom signs regarding the kidney and bladder are accentuated, which is best presented by pain and usually felt in the left flank radiating to the groin, hematuria in 85% of patients, and ureteric colic, which is often suspected, rather than AAA, which is ruptured in left renal vein. Despite the fact that the kind of rupture AAA is very rare, diagnosis should be promptly made when these symptoms are present. It's important to note that the more than 90% of these cases rupture occur dorsally in the retroaortic left renal vein, which is a rare anomaly affecting 1 to 2% of people. Our case we are presenting is about 70 years old male patient presented with history of left loin pain radiating to the groin of 3 days duration with hematuria. The patient was vitally stable, so we started with a workup and investigation which revealed hemoglobin drop about 1 gram per deciliter daily, abdominal ultrasound, which show abdominal aortic aneurysm. That's why we recommend to do a CT angiography, which shows juxtarenal AAA with aortorenal AV fistula and aortocaval fistula. The renal vein was normally the retroaortic course. This is the CT angiography 3D reconstruction photos, and it's axial cuts. The patient is prepared for operation with midline laparotomy, and the supraceliac control is done first, then suprarenal aortic segment dissection for suprarenal aortic control and both iliac control, opening the aneurysm with closure of 2 venous fistulae from inside the aneurysm, then proximal anastomosis of bifurcated diaphragm graft, followed by shifting the suprarenal clamp to the graft clamp for distal iliac anastomosis done. The post-operative period passed unremarkably with this post-operative CT angiography showing opacification of visceral branches, celiac, superior mesenteric, and renals, and good configuration of the aortic graft to the iliacs. And this is the axial cut of post-operative image, showing good exclusion of from the aneurysm and no filling of the veins, so either the renal vein or the inferior vena cava. Thank you.
Thank you, Dr. Hamdi, for sticking to the time. Professor Dr. Hisham Sharaf will introduce the second presenter, please.
It is my pleasure to introduce Professor Magdi Haggak from Qasr Aini, Egypt, Cairo University. Challenging case of AAA with short angulated neck and pelvic kidney, a descent endovascular proposal.
Good afternoon, everybody. It's nice to be here with you. I am today here to introduce my case of AAA with short angulated neck and pelvic kidney. Such cases are very rare, and the combination of pelvic kidney and the AAA also very rare, so there is little reporting literature about the management of such cases. The title inspired from this movie, Indecent Proposal, you all know about it. $1 million for just for one night. That's what Page tell Demi Moore. Did she agree or not? She agreed, but she regret at the end. Of course, there must be decent proposal if there is a lot of indecent proposals. The location of ectopic kidney can be present anywhere, but we will talk today about the pelvic site. The incidence, as I said, is 0.3 to 0.4%, and the combination with AAA is very rare. My case is 67-year-old man. He's not diabetic, not hypertensive. He has a huge pulsating abdominal mass, proved to be AAA. Kidney function was normal, and CT angiography was done and showed AAA with short angulated neck and left and pelvic kidney. What's important here is that the artery of the pelvic kidney arising from the proximal part of the left common iliac artery. This is the CT, is a shocky CT with short neck and pelvic kidney down. Also, there is a lot of calcification in the aortic wall and iliacs and dilatation of the right common iliac artery. And you can notice the angulation. Anyway, let us talk about treatment proposal, either surgical treatment or endovascular treatment or others. The surgical treatment, either you do aortobiliac bypass if you have the artery below one of the iliacs, aortobifemoral with renal bypass, aorto-ilio-renal bypass. Of course, and during surgery there must be difficulties, and the most important is the renal ischemia during aortic cross clamping. The surgical technique, you expose the iliacs and the native artery of the pelvic kidney, and you do your bypass and you end in this way by triple bypass. Of course, you start after aortic anastomosis with the renal artery first, and then you complete the iliacs. Another option is you can do only for a graft from the aorta only to one side, and you depend on retrograde flow from the other iliac by fem-fem crossover. Or you can do the conventional way of management with crystalloid perfusion of the artery of the pelvic kidney. Another proposal is you have to do double shunt technique to maintain perfusion of the pelvic kidney. And this is done by a modified shunt like Javid shunt, which is done by axillofemoral bypass, and then you use another shunt like you see here. It's Argyle shunt taken from the iliac to the artery of the pelvic kidney, and then you proceed as usual. Or you are lucky enough to have the renal artery of the pelvic kidney, and we implant it by separate cuff if it is arising from the lower part of the aorta. This is not only the problems in surgery. You can face problem in the venous drainage. You can find the cava on the right side, and you face problems during aortic surgery. What do you think are decent or indecent proposal? In my belief, all are indecent. Let's go next to the endovascular proposals. Either you do chimney EVAR or chimney EVAR with long chimney coming from the neck of the aorta, or you can take it from one of the limbs of the EVAR device. Like in this case, you extended the graft all the way from the neck of the aneurysm down to the pelvic renal artery, or you use this way. You can use the graft from one of the limbs of the EVAR device according to the anatomy and the angulation of the adjustment of your graft. Or you can use a custom-made device with separate branch that go directly to the pelvic renal artery of the pelvic kidney. Or in the same way, you can use also a uni-iliac device with fem-fem crossover, and you depend on retrograde perfusion. Or a custom-made fenestrated device, of course, by measurement. What do you think? Also, this is indecent proposal. So what about my own proposal? I did a bilateral femoral exposure, and I did a mini laparotomy, and I changed the drainage, the origin of the pelvic renal artery, and instead of the proximal part of the left common iliac to the external iliac artery, and then I proceed for regular EVAR. The steps, as you see, I did my anastomosis and took only 7 to 8 minutes, with only renal ischemia of 7 minutes, and then released the clamps and tested the perfusion of the kidney and ligated the proximal part of the artery, so the kidney take flow now from the external iliac artery by a separate bypass. And then I proceed with the regular EVAR, and be sure that still my kidney down is perfused, and went to the other side to put the extension limb here, and ended up in this way. Post-operative follow-up CT scan was, I think it's a very nice picture post-operatively, and you can see the separate graft from the external iliac and well perfused both kidneys. What do you think? I think it's a decent proposal. Thank you very much.
Thank you very much, Professor Dr. Magdi Haggag. And now Professor Dr. Hassan Lotfi will present the third presenter.
Thank you, Dr. Magdi, for this decent lecture. And we hope we are very eager to listen to Dr. Ayman Samadoni for also an ectopic kidney, isolated infected leaking common iliac artery aneurysm associated with ipsilateral ectopic kidney.
بسم الله الرحمن الرحيم. We're forward and we're backward. Next. Okay. Thank you very much, and it's a hard act to follow. Dr. Magdi has presented a very nice case and very challenging proposal, actually. My case is much simpler than that. He's an 81 years old male. He presented to the ER with a 2 weeks history of shaking, chills, fever up to 40.5, and right iliac fossa pain and pulsating mass. He is diabetic, hypertensive with rheumatoid arthritis and chronic calcific with mild urea impairment. He presented with severe anemia, 7.1 with leukocytosis and actually sepsis. The pelvic ultrasound shows an aneurysm of the right iliac artery. So because of the renal impairment, we done an MRI, which showed that almost a flush right common iliac artery aneurysm with, as you can appreciate, with this pointer, and you can appreciate this vessel, which is the right kidney is an ectopic, with the last lumbar artery is replacing the renal artery. So we are in the dilemma what to do, and let us get the patient to the ICU. And you can appreciate, you can appreciate as well the amount of abscess present here in the substance of the iliopsoas muscle all eaten up by the abscess surrounding the perivascular tissues. So we decided to admit the patient to the ICU, hemodynamic support, and recovery support. However, shortly, only a few hours after admission, he developed a hypovolemic shock with failure of fluid resuscitation, so we pushed him urgent to surgery. We've done midline extraordinary incision, right medial visceral rotation, medial mobilization of the ectopic right kidney with vascular control, aortic, and 2 iliacs, excision of all aneurysmal sac, debridement of all underlying psoas abscess, and we reconstruct by fem-fem crossover graft. And that is the MRA after we finish our procedure, and you can see that we maintain the blood flow to the ectopic kidney. However, the patient course was not that easy. He had a stormy postoperative course with grade 2 other respiratory distress syndrome, hepatic impairment, renal impairment, head syndrome even occurred, cardiac depression, and wound infection with partial days of the abdominal wound, and right proximal iliofemoral DVT. However, thanks to the ICU guys, the patient did well afterwards. The antimicrobial regimen, the blood and pus culture showed Salmonella enteritidis, and antimicrobial regimen was given. He was charged with 3 weeks in the ICU stay. On discharge, his only incision hernia with mild right lower limb edema. Etiologic classification of any aneurysmal infected aneurysm is a mycotic aneurysm where the origin is the heart, microbial arthritis where the infected aneurysm coming bacteremia coming from other source or the septic focus on the body, or infection occurring pre-existing aneurysm, or a post-traumatic pseudo-aneurysm. However, regarding microbial arthritis, atherosclerosis is a predisposed bacterial arthritis. Disease the entima allows the bacteria invasion of the submental plane, forming a microabscesses, wall expansion following usually saccular form, not fusiform. Salmonella used to prevail prior to 1965, but later on it comes shifted to staph species. Any septic foci could be the culprit lesion. The special predilection towards the aorta 3:1, however, isolated iliac aneurysm represents only 0.03 at the autopsy and 0.6% of all aortoiliac aneurysm. That's the management. The most sure thing about the management is the policies. You have to have your antimicrobial therapy and support for at least 6 weeks after the completion of the procedure, and debridement and vascular reconstruction, which will give some space to talk about. I'm sorry. No success is expected unless less than wide debridement of all vascular and perivascular tissues. Do not keep the sac in. That's very important. Vascular reconstruction either in situ, that may be okay in perivascular aorta. The grafts could be cryopreserved homografts, and had one case yesterday presented a bovine graft, or superficial femoral vein, or antibiotic impregnated Dacron grafts. However, it has a risk of recurrence and pseudo-aneurysmatic aneurysms. The extra-anatomical reconstruction offer less major reconstruction, but more applicable in infrarenal aorta and iliac aneurysms. Durability is always in question, and in event of further bacteremia, fear of anastomotic aneurysm is not negligible. The endovascular, till the moment, the endograft is still controversial. The failure of dealing with the infected tissues is a major setback for these modalities. However, it might help to temporize the patient over a critical period of time, like for presenting with a leaking. Some authors tried endovascular exclusion with immediate excellent results, yet durability to be tested. Still hold high mortality, any infected aortoiliac aneurysm, 50-70%, maybe because of diagnostic delay or hemodynamic infective instability, high magnitude of surgery, and associated comorbidities. It differs according to the site. The infrarenal aorta around 10% mortality, or 47 to 52 in perivascular area. The organism usually Salmonella, but Salmonella do better as mortality figures than the staph. Any unknown febrile illness for more than 2 weeks, you have to suspect there is something wrong. No justification for antibiotic without surgery. Endovascular management is still controversial, but might tie the patient over a critical period. Choice either in situ or extra-anatomical is still controversial. Antibiotic regimen should start before the surgery in elective cases and continue for 6 weeks in IVV form and at least from 3 to 6 months in oral form. Thank you very much.
Thank you very much, Professor Dr. Amin Samadoni, to stick to the time. So we will reintroduce the second presenter, Dr. Muhammad Abdul Ati. He is presenting the multidisciplinary management of aneurysms associated with congenital vascular malformation.
Assalamu alaikum wa rahmatullah. Today we are going to talk about multidisciplinary management of aneurysms associated with congenital vascular malformations. As we know, congenital vascular malformations represent a rare entity of diseases that affect up to 1.5% of the population. It can affect any part in the body, and these aneurysms are infrequently described in the literature. However, they can lead to life-threatening complications when rupture and bleeding occur. The CT angiography is the gold standard diagnostic investigation, and early treatment is advocated to avoid rupture and life-threatening bleeding. The modalities of treatment include either endovascular embolization, percutaneous sclerotherapy, surgery in the form of either ligation or surgical excision. We should be aware that simple ligation of the feeder without proper ablation of the nidus of the aneurysm will be followed by aggressive neovascularization and growth of the aneurysm. So the ideal sequence of intervention should be in the form of conversion of this high flow lesions into low flow by either endovascular embolization or by surgical ligation, and this must be followed by destruction of the nidus, either by embolization, percutaneous sclerotherapy, or by surgical removal. This patient presented to us with a pulsating aneurysm in the right auricle, and the CT angiography showed multiple aneurysms associated with congenital vascular malformation, receiving blood supply from the posterior auricular artery. There is a technical problem, as I think. Okay. So this is the digital subtraction angiography images. And we see that after endovascular embolization, we achieved complete obliteration of the lesion and of the feeding artery. And clinically, after 3 months, the patient has improved significantly with near complete disappearance of the pulsating mass. This is another patient who presented with pulsating mass in the little finger, and the CT angiography showed aneurysm in the little finger arising from the digital artery. And in this patient, the aneurysm was small and accessible. So we preferred the surgical option by ligation and excision of the lesion. This is another patient with complex lesion. The CT angiography showed that there is multiple aneurysms in the submandibular region originating from the facial and the superior thyroid artery, and there is also multiple scalp aneurysms arising from the occipital artery. To treat the submandibular lesion, we preferred the endovascular option. And we did embolization of the lesion with the obliteration of the feeding vessels, branches from the external carotid artery. To treat the scalp lesions, the aneurysms was multiple, and the patient would have needed several sessions of embolization and this would be with very high cost, so we preferred the surgical option. And we did ligation of the feeding vessels. The planning was based on the perioperative duplex and CT angiography. And this was followed by injection sclerotherapy. And here we can see the post-operative CT angiography showing significant improvement. This is the clinical image of the patient after 2 sessions of percutaneous sclerotherapy with ethanol. And this patient presented to us with pulsating mass in the axilla. The CT angiography showed aneurysm arising from the brachial feeder from the brachial artery. And here we did endovascular embolization of this feeder, and the angiography showed complete obliteration of the lesion. And here we can see the immediate post-operative image showing pigmentation. This pigmentation is related to the onyx, which is the used embolizing material in this patient. But after 3 months, the pigmentation improved, and also the original lesion with the overlying capillary malformation. So in conclusion, the treatment of congenital vascular malformation associated aneurysms should aim to convert this high flow into low flow lesions, and the multidisciplinary approach should be followed, mainly endovascular embolization followed by injection sclerotherapy. And surgery has a role in selected cases when the arteries are accessible, but surgery should aim at complete excision, and if not possible, it should be followed by percutaneous sclerotherapy for ablation of the needles. Thank you.
Thank you very much, Dr. Muhammad, for sticking to the time. And we'll move to the 5th presenter. Professor Dr. Aman Fattah will present him.
Prof. Samer Al-Qusayr, his dear colleague, will present to us a topic of recurrent aortoenteric fistulae after EVAR with nightmare never ends. Actually, I was following management of this patient on our group, and actually it is a nightmare case.
Good afternoon, everyone. I'm going to present a case. It's very complicated. It's very difficult to summarize it in 8 minutes. It took 10 years I've been following this patient. This patient came 5 times to us, and every time he come in complete different presentation. I'm going to go through every stage. The first stage he presented to us back in 2011 was contained rupture infrarenal aortic aneurysms. So he's a 38 years old, healthy male, heavy smoker, unremarkable past medical history. Presented with abdominal dull pain, started in left lower quadrant for the last 3 months. Increased gradually radiating to his back. No sign of symptom of connective tissue disease or vasculitis. No history of brucella, salmonella, TB, or syphilis. No history of infection or drug abuse. All the lab workup were negative. Brucellosis, salmonella titers were negative. Virology, CTD workup was negative. Or culture came back negative. The only thing it was elevated the ESR and CRP, so we thought possibly he has a vasculitis. On CT, he has 3 aneurysms, pseudo-aneurysms. The first one below the left renal artery. Second one is mid-aorta with a container rupture. And the third one just above the aortic bifurcation. Because he has an active vasculitis and he came with a container rupture, we decided to do endovascular as a bridge for now and then bring him back for definite treatment because it's very difficult to do an open repair with an active vasculitis. So we took him to the surgery with an EVAR with a tube graft, works beautiful, and he did fine. At the same time, we did a biopsy from the right common femoral artery looking for vasculitis. At that time, also came back negative. For the last 10 years, he lost follow-up. He never came back. We never saw him for 10 years. But through these 10 years, he's been treated in different hospitals in Eastern Providence of Saudi Arabia. So what he had through the last 10 years, in 2017, he has a type 1 endoleak, so they took him to the surgery, they took the TVAR, and they did aorta by iliac bypass. Year after that, he developed an GI bleeding, aortoenteric fistula, infection of the graft, and thrombosis of the graft. So they took him back to surgery. They removed the aorto-iliac bypass graft. They sutured the aortic stump, and they didn't do any reconstruction. They depend on the collaterals, and they closed the duodenal fistula, and they did bariatric exclusion with a gastrojejunectomy. And he did fine after that. Third presentation in 2021, this is about 2 years after that, he presented also the Eastern Providence of the Saudi with a massive hemoptysis. Hemoglobin dropped to 7. They did an EGD, they found the stomach full of blood, but no source of bleeding. Colonoscopy is negative. CT angiogram revealed inflammation between the aortic stump and the duodenum, but no air or active extravasation. So they thought most probably he has a recurrent of his aortoenteric fistula. So they went there, they coil embolization of the aortic stump, which is complicated with the right renal artery occlusion because of the coil. So they went there, they put a stent in the right renal artery, but also the stent got occluded. Even after embolization, he continued to bleed. So at that time, they decided to send him back to us. So here, after 10 years, he came back to us again, and this time to look for his source of his GI bleed. When he came to us, he was hemodynamically stable, no more bleeding. So we did repeat all his rheumatology workup, and at that time, we diagnosed him with a Bahajat disease, depending on 3 criteria, which is recurrent oral ulcers, positive skin pathology test, and vascular involvement. So we started on high dose of prednisone and ifimiximab, and at that time we took him to the surgery, and the general anesthesia, we did a push endoscopy to look at the both limb of the gastrojejunectomy and to look for source of bleeding, and all the endoscopy was negative. We did not even see any sign or indirect sign of inflammation in the duodenum to tell us he has a recurrent of aortoenteric fistula. Also, we did all the infectious workup, which all came back negative. Also, RBC scan was negative. So at that time, we discharged him home on cortisone. 3 weeks back, again, he has another episode of hemoptysis because he stopped his medication. The patient is completely non-compliant. Every time we discharge him on cortisone, he stopped it after a couple of days. So he came back to King Faisal again. Again, every time he comes to us, there's no bleeding. He's stable, there's no blood. So this time we decided to admit him to ICU, put him on heparin drip to stimulate the bleeding because we want to scope him where he's bleeding. Luckily, after 2 days from admission to the ICU on heparin drip, he started bleed. He has 1 episode of hemoptysis. We pushed him to the OR. We did endoscopy again. And again, when we went in, we just see stomach full of blood. No blood in the duodenum, no blood in the jejunum. So we thought at that time, most probably patient has a dilaphoid lesion. And we don't think has an aortoenteric fistula. But again, we did not see the bleeding, but this was our impression after all this workup. So we don't have a capsule endoscopy at that time. We offered him to do X-lab to look for any other pathology like AVM malformation, but he refused. So we went there, we did empiric embolization of his left gastric artery. We went through the left breaker artery because infrarenal aorta is occluded and has no reconstruction. So we closed the left gastric renal artery with the gel foam, and luckily after that he did fine and no more bleeding. So the bleeding stopped. Then he discharged home, then again no more bleeding. 4 months later he came back to us with a huge tender lump in the left arm, where we use it access for embolization. So he came with a large pseudo-aneurysm from puncture side of the left breaker artery. Again, he stopped his medication. He has an active vasculitis. So we took him to the surgery. We did open. We did patch angioplasty, put him back on cortisone, sent him home. 2 months again, he came back with another aneurysm, same area recurrent of his aneurysm. This is a CT scan. You can see recurrent of his aneurysm, same spot, left breaker artery. So we took him to the surgery. We removed this breaker artery completely, and we put interposition vein graft using a basilic vein. Did well, discharged home in cortisone. 2 months back, he came again with recurrent of his left breaker artery pseudo-aneurysm with ruptures. At this time, we said that's enough. We cannot keep doing surgery. We decided to do endovascular, putting a cover stent. The problem, we have no access because the infrarenal aorta is occluded. His left renal artery is occluded. So we went through the breaker artery, retrograde, and put a cover stent in the breaker artery, and it worked well, and then we evacuated his hematoma. And then he did fine. Then couple months ago, 2 months ago, he sent it back to us. Now he developed a thoracoabdominal aortic aneurysms. So he has an aneurysm starting at just above the celiac, involving celiac SMA and renal arteries. And you can see it here, the pseudo-aneurysms. Of course, we have no option for endovascular because renal arteries complete occluded. So we have to take him to the surgery. We did thoracoabdominal aortic aneurysm on him. In this surgery, I did a debranching for each vessel itself. I did not use any Carotid patch because I'm afraid he will get aneurysm in future at the anastomosis site. So in this way, we have an access to do endovascular in the future if that's happen. We did not use any ECMO because infrarenal aorta is occluded, but we protect the kidney by using a cold 4C ring-elected with 1 gram prednisone and 25 gram mannitol to the left kidney. After surgery, he did fine. Creatinine is fine. GFR is fine. No neurological deficit, no paraplegia, no more GI bleeding, and he discharged home 2 weeks. This is about last month, and so far he's doing fine. We hope he will not come back again. If he comes back, I will let you know. Thank you.
Thank you very much, Professor Dr. Samer Qusayr. We will move to the next presenter. Professor Dr. Hisham Sharaf will present Professor Ahmed Taha.
Thank you very much, Dr. Samer. Now it is my pleasure to introduce my dear friend, Professor Ahmed Taha. Professor of Vascular Surgery and head of surgical department in Cairo University. He will talk about the endovascular option of iliac artery aneurysms.
Thank you very much, Mr. Chairman. Good afternoon, ladies and gentlemen. My topic is about managing bilateral common iliac artery aneurysms with an incidence of about 40% of patients reflecting this association. The risk factors are similar to the degenerative large vessel aneurysms, including the male gender, white race, advanced age, smoking, and hypertension. About the clinical presentation, it depends upon the diameter and location of the aneurysm. They might be asymptomatic. However, they might reflect a sort of compression to the nearby structures, the glioretor, the colon, the lumbar plexus. They might thrombose and give embolization distally, and they might also rupture with an incidence rupture of about that might mount to 70% in 5 years. Of course, the incidence rupture depends on the average size of the aneurysm. With the rupture in aneurysm smaller than 3.5 centimeters is getting very low, and when it's ruptured, it carries a very high incidence of mortality. The indications for repair are if the aneurysm is asymptomatic, we manage the case when the aneurysm size is equal to 3.5 centimeters or higher or larger. If the patient is symptomatic, whatever the size of the aneurysm is, because when the aneurysm is symptomatic, it usually reflects the higher incidence of rupture. Of course, when it's ruptured, it's an emergency procedure. When it's rapidly expanding, this means the aneurysm size gets increased when 0.5 centimeters in 6 months and more than 1 centimeter in 1 year. And when there is a coexistent abdominal aortic aneurysm repair. Which repair should we utilize? There is no randomized trial comparing techniques of open versus endovascular techniques. The 5 years patency of both techniques are almost similar, 98% for the endovascular arm and 100% for the open one. And the endovascular repair is associated with significantly decreased incidence of morbidity. Also, the endovascular repair is indicated when anatomy is suitable and the compressive symptoms are absent. The endovascular repair will not lead to an immediate, that's because the endovascular repair will not lead to an immediate decompression. Once more, the advantages of endovascular repair include elimination of complications like the erectile associated with pelvic dissection, like erectile dysfunction or retrograde ejaculation, avoidance of open surgery in patients with previous abdominal or pelvic surgery, and also it's associated with reduction of the perioperative morbidity, thus allowing treatment of patients at high risk for open surgery. What endovascular repair of common iliac artery aneurysms? The endovascular repair, if there is proximal and distal landing zones covered, since it's very sufficient for this. If the disease involved the aorta and the iliac artery, then we go for the standard EVAR technique. If the distal landing zone relative to the internal iliac artery, then we have to preserve at least one of the two internal iliac arteries, because loss of the internal iliac artery at both sides can lead to buttock-claudication, sexual dysfunction, gluteal necrosis, spinal cord ischemia, and colonic infarction. And these manifestations are exacerbated if the inferior mesenteric artery is also sacrificed. How to preserve the internal iliac artery? There are several techniques. The time, I think it will not allow me to go through all of them. One of these is to revascularize the internal iliac artery by a hybrid technique, by surgical technique, exactly like what Professor Magdi Haggag showed us shortly. And then we have to keep the distal and smooth very far distal in the external iliac artery, and afterwards ligation of the internal iliac artery proximally, and then we go directly for classic EVAR technique like this case. Another method is to do an external to internal iliac artery endografting and femoral bypass like this. The iliac branch device is a technique mandates some sort of anatomical criteria. This is a case I would like to show you. A male patient, 71 years old, with an incidental discovery of bilateral common iliac artery aneurysms, with aneurysm diameter on the right side 3.5 centimeters, and the left side is 4.5 centimeters, with an occluded right internal iliac artery and multifocal stenosis of the left internal iliac artery. Here is the case. You can show the lesions in this 3D angiogram. The decision was to perform EVAR together with utilization of iliac branch device in order to preserve the left internal iliac artery, which is sole internal iliac artery patent on this patient. Here is the angiogram. You can see the right common iliac artery aneurysm, and the left one is huge aneurysm, 4.5 centimeters, with a totally occluded right internal and stenotic left internal one. Here, after we advanced the iliac branch device, and there is an attempt to snare the wire from the contralateral side in order to pave the way, in order to introduce sheath from the right side. And here, after cannulation of through the right-sided sheath, cannulation of the internal iliac artery branch, we managed to cannulate it, to pass stiff wire there. And here is the covered stent into the internal iliac artery, starting from the side branch of the iliac branch device, and properly positioned, and then deployed. And we are sure now that with angiography there is no endoleak at that stage. Afterwards, we managed to do a straightforward EVAR technique in order to cover the other aneurysmal right common iliac artery. Here is the after we passed with the main body of the EVAR from the right side, then this is the final result. So in conclusion, the majority of iliac artery aneurysms can be treated with various endovascular techniques. Preservation of the hypogastric arteries in cases of common iliac artery aneurysms is important, especially if the one side is occluded and the other side is patent, and more specifically if the inferior mesenteric artery is sacrificed. Thank you very much.
Thank you very much, Professor Ahmed. Professor Dr. Hassan Lotfi will present the next presenter.
Dr. Mohammed Hindawi will present us to management of abdominal aortic aneurysm in horseshoe kidney. Dr. Mohammed Hinadi.
Good afternoon, Mr. Chairman, dear colleague. My talk today about management of abdominal aortic aneurysm in horseshoe kidney. In biological background, during the 6th and 9th week, the two kidneys rotate and ascend from the pelvis to their usual anatomic position. On ascend, they receive their blood supply through a series of paired arteries arising from the primitive aorta, which subsequently disappear. Horseshoe kidney, the most common renal anomalies. It represents 0.25% of the population. Abnormal embryonic fusion of the kidney leading to interruption of the normal rotation and ascent with variety of renal anomalies and anomalies of the vasculature and the collecting system. Isthmus is almost always located anterior to the aorta and beneath the inferior mesenteric artery, which impedes its ascent movement. It may contain functional parenchyma in 85% and fibrous tissue in 15%. Vasculature, abnormal vascular anatomy is common observed in horseshoe kidney. There is many vasculature reported in literature. The most common one in 30%, one renal artery on each side of the horseshoe kidney and isthmic branch from the aorta. Horseshoe kidney and abdominal aortic aneurysm. Horseshoe kidney is associated with aortic abdominal aneurysm is rare, found in only 0.12% of the patient that undergo abdominal aortic aneurysm repair. The first successful aneurysm repair is reported in 1955. To date, 32 cases have been reported in literature. Challenge: 3 technical aspects need to be taken into consideration given unique anatomy of each patient. Type of abdominal exposure to reach the aneurysm sac. Number 2, whether to divide the renal isthmus or preserve. Number 3, ligation or salvage of accessory renal arteries. Both the midline and the left retroperitoneal exposure are suitable for dealing with this type of aneurysm. The final decision is based on patient anatomy and the surgeon preference. Isthmus, division of the renal isthmus may lead to urinary leak, renal ischemia, infection, post-operative renal insufficiency, bleeding. Division should be avoided and performed only when the renal isthmus hinders aortic reconstruction. If the decision to divide the renal isthmus has been taken, over and over sutures are used to close the renal isthmus. Accessory arteries. Most also recommended preservation of the renal arteries with significant diameter more than 2 mm. Reimplantation of renal arteries can be performed directly to the body of the prosthetic graft or through a patch that includes the origin of the arteries. Literature review. Report division of the isthmus, exposure done, and management of accessory renal arteries. EVAR is a good alternative option for patients who are unable to tolerate open abdominal aortic aneurysm repair because of poor surgical condition or hostile aneurysm anatomy. Variable renal vasculature is the main technical concern. Introduction of endovascular stent graft include one or more of the accessory renal arteries Covered arteries possibly lead to type 2 endoleak. Preservation of the accessory renal arteries more than 3 mm in diameter is recommended. Two basic techniques of EVAR. Traditional EVAR procedure if no main accessory renal arteries are covered. If they arise from the iliac arteries distal to the graft. Aorto-iliac endograft and fin-fin bypass to preserve any accessory renal arteries that arise from the proximal common iliac artery. Our case, 77 male patient, hypertension, sorry. I want to play the video. Left renal artery, right renal artery, inferior mesenteric artery, the isthmus and horseshoe kidney, the diameter accessory renal artery to the isthmus, الأورigin بتاعه from the right common iliac artery. During exposure, this picture is seen with this mass of fleshy tissue and this artery below. On this section, at the opening of the peritoneum, the artery is present here. Clamping of the aorta and do proximal anastomosis, and beneath the isthmus of the kidney, and the preservation of the isthmus and the preservation of the blood supply from the right iliac artery is done with completion of the anastomosis and the repair of the peritoneum. Thank you very much.
Thank you very much, Professor Dr. Mohammed Al-Hanidi. Professor Dr. Ayman Abdel Fattah will present the next presenter.
Next talk will be by Prof. Samih Mustafa, Alexandria, Egypt. He will speak about traumatic femoral pseudoaneurysm, unexpected scenario by unexpected cause. Welcome, sir.
Thank you, Mr. Chairman, chairpersons, my professors and colleagues. Good afternoon. Today we are speaking about a case of iatrogenic femoral artery pseudoaneurysm with an unexpected scenario. It was 65 years old lady who had stroke and treated through an endovascular transfemoral mechanical thrombectomy through a puncture on her right side. And 48 hours later, she developed a pulsatile mass in her right groin. Clinical exam revealed a large groin swelling with an expansile pulsation. My clinical diagnosis was post-puncture traumatic pseudoaneurysm. Clinically, the patient had very bad general condition due to recent stroke, multiple comorbidities in the form of diabetes, mellitus, hypertension, and ischemic heart disease. She was loaded with clopidogrel, received aspirin and anticoagulation. So generally, the situation was not that good. Imaging revealed by duplex communicating hematoma to the superficial femoral artery, and the CT scan revealed a pseudoaneurysm communicating with the superficial femoral artery, and luckily enough, it was 1 centimeter below the common femoral artery bifurcation. So I felt lucky because I could go through the endovascular option in this critical patient. The endovascular option under general anesthesia, locally through the left side, the contralateral side of the lesion, contralateral femoral artery access, and we had this trilobar lesion here, sorry. We had this trilobar pseudoaneurysm communicating with the superficial femoral artery, and no other sac revealed here in this photo. We sized the artery, it was about 6.2 millimeters, and we did oversized the size of the stent graft to 7 millimeters. So we had about 20% oversizing. A covered stent was put here, covering the whole lesion, keeping the profunda artery patent, and no residual sac is present here. It was just perfect. Post-operative was smooth, compression removed from the contralateral side. 48 hours later, everyone went happy and the patient was improving because our patient was critical. We did duplex surveillance daily. We had very good result on the first, second, and third day until we went through the fourth day where we had, again, Viva Korea, a Korean flag sign. So the possibilities could be stent size mismatch, and this was not the case because we had 20% oversize, a fabric defect and endoleak. We used a very good quality of covered stent or a possibility of another injury that was not revealed due to preferential blood flow through the larger femoral pseudoaneurysm, and when it is covered, the flow was redirected to other minor injuries. Round 2, we did another angiogram through contralateral access. Early, nothing. We had nothing in the image, but on delayed exposure, we had these two new sacs. And surprisingly, they were related to this branch and these minor branches. To complete this, we went through round 3, and by cooperation with a colleague, interventional radiologist, he did a careful duplex examination that revealed normal SFA with no communication and the communication of the two sacs with the medial circumflex femoral artery. So ultrasound-guided puncture of the sac is done like that. Then a dye injection percutaneously to confirm the diagnosis of new lesion here. And as we see here, this is the medial circumflex femoral branch of the profunda artery, and nothing, no flow inside the stent or the SFA. Percutaneous coiling was done perfectly, as you see here. And surprisingly, after coiling of this single side, both sacs disappeared, and this is the duplex confirmation of no Korean flag sign again. Everyone went happy again. What I learned from this situation, always history is important. We had a history of multiple in and out, entry and entry again. So this type of puncture could result in such complication. So to use an ultrasound-guided access is wonderful, and you can avoid such a type of complication. Duplex surveillance and follow-up closely is very important. Teamwork and cooperation is crucial. And finally, in vascular surgery, knockout victory is not always the case. Sometimes you go through multiple scenarios and you need round 1, 2, and even 3. And finally, thank you for your attention.
Thank you very much to stick to the time. There is one added presentation. I am pleasure to introduce Professor Dr. Hussam Al-Wakil to present traumatic femoral, to present, persistent sciatic artery aneurysm, new treatment modality. Thank you.
بسم الله الرحمن الرحيم. I will present a rare case of persistent sciatic artery aneurysm, and we think in this case outside the box. Persistent sciatic artery aneurysm, first described in 1932. It is a congenital anomaly resulting from failure of regression of the sciatic artery. Diagnosis is difficult, and life and limb-threatening complications are well recognized. The reported incidence of this condition is about 0.05% in the general population. As we all know, the persistent sciatic artery the sciatic artery represent the main blood supply to the limb during the embryonal life, and from the 6 weeks it begins to regress, and finally it shares in forming the profunda femoris artery, the popliteal, peroneal, and the arch of the foot, and in this as the internal inferior gluteal artery. This is the modified Bellet classification of persistent sciatic artery. Here we have, it may be, the persistent sciatic artery may be a complete one or incomplete one. This is the most common variety, which is type 2, where we have complete persistent sciatic artery with hypoplastic or rudimentary superficial femoral artery. Treatment of such conditions have many lines of treatment, including ligation, aneurysmography, coil embolization, and the covered stent placement. In the incomplete type, this is no problem. We have blood supply to the limb through the superficial femoral artery. But the problem is in the most common scenario, which is a complete persistent sciatic artery. In this condition, we have to have a revascularization procedure to maintain the blood supply of the extremity. In our case, it is a young age patient, 49 years old, presented to our emergency hospital with an acute ischemia in his lower limb, and his symptoms becomes worsened in the last 24 hours. This is the CT angio, and from the CT angio we can notice that there is no blood supply here in his left foot, and the persistent sciatic artery aneurysm is present in the gluteal region. We have complete persistent sciatic artery and hypoplastic superficial femoral artery. This is the foot showing mottling. What we have to do in such a situation? We begin by putting the patient in prone position, ultrasound guided cannulation of the persistent sciatic artery, and we start thrombolytic therapy for 48 hours. This is the axis, and we have no flow inside the foot, as you all see. We put the caster first in the posterior tibial and in the anterior tibial artery. We succeeded to revascularize his foot, and this is the foot after we regain circulation to his foot. Now we have to think how we solve the problem of this patient. We now save his limb from amputation, and we have to think what we have to do. This is the classic incision. We have two incisions for exposure of persistent sciatic artery aneurysm, the Henry question mark incision and the transgluteal muscle splitting incision. We go through this muscle splitting incision, exposing the persistent sciatic artery aneurysm, and here we expose the sciatic artery in the thigh, leaving an island of piriformis muscle in between. We dissect the aneurysm and we open it and control the bleeding vessels from inside. The patient with having compression of the sciatic nerve leading to slight foot drop. He presented to us with slight foot drop due to prolonged compression. We harvest the sciatic artery all through. This is the exposure. This is the aneurysm, the proximal. This is the distal end of the aneurysm, and the proximal end while coming out from the greater sciatic notch. And here, lastly, is the dissected harvest persistent sciatic artery. The classic decision in such a situation was to ligation and do femoropopliteal bypass. We didn't do so. We do another thing. We do complete harvesting of the artery, passing the artery inside a tunnel of an Elaton tube, passing this tube, creating an artificial opening in the adductor magnus muscle while the patient in the prone position, passing this healthy persistent sciatic artery through the opening in the adductor magnus muscle to the groin. And here, this is the groin. We turn the patient on his back in supine position. Here, the common femoral artery, the rudimentary superficial femoral, the profunda femoris artery, and here is the neonatal tube with the persistent sciatic artery inside. I was planning to do anastomosis to the common femoral artery, but unfortunately it was short, so I have to interpose a segment of saphenous graft from the locality in between. This is the final angiogram. We use the persistent sciatic artery at the conduit, we preserve it, we control the aneurysm, and you have now seems normal blood flow to the foot. Thank you.
Thank you very much. I would like to thank all the presenters to stick to the time, and the floor now is open for discussion. If there is any question for the first presenter, Dr. Hamdi Abou Nil.
Dr. Hamdi, thank you for your presentation for the case of aortovenous fistula, but why you don't using endovascular for exclusion of the fistula, endograft for exclusion of the fistula other than open? And the second question, why you don't use a retroperitoneal approach for this case? It is more easier than intraperitoneal.
As regard the first question, the endovascular option was not available, the device at this time of this, when this patient arrived in our hospital. That's why we proceed with the open repair. As regard the second question, again, please.
Retroperitoneal exposure of the aorta with the left renal vein, it is easier to reach the site of the fistula by retroperitoneal approach than intraperitoneal.
I think it's not getting my mind in this time, but maybe because I'm familiar more with the midline incision transperitoneal, that's it.
I have another question for you, just Hamdi. It was a brilliant case and a brilliant outcome, but I was just wondering, why did you do a CT for the patient postoperatively?
The patient, to confirm that the fistula is completely excluded first of all, and to confirm that the perfusion of renals, both renals, still ossified, because there was transient elevation of kidney function, and there is a picture of mimic intestinal ischemia, but to make sure that the mesenteric vessels is patent.
Okay, thank you. The second presenter, Professor Dr. Magdi Haggag, presented a challenging case of a short angulated neck and pelvic kidney.
Thanks, Dr. Haggag, for your excellent work and very nice presentation. I want to ask you, did you did the renal scintigraphy to identify function of every kidney, right and pelvic kidney?
No. His kidney function was normal. And I know you ask about the pelvic kidney, usually its function is lower than the others. And even in this patient, there is a proximal stenosis at the native renal artery of the pelvic kidney. But still, the function was normal, and even after the bypass and the EVAR, it was normal. I agree completely with you. And one more thing, just to mention, the renal artery of the pelvic kidney is not like the renal artery of the normal kidney. It's a very small artery. It's very, very difficult to harvest or to expose. And alhamdulillah, we managed to expose and did this bypass.
Okay, thank you.
Dr. Magdi, مساء الخير. Great case, really. Question about number one, the conduit. Why you prefer to use the saphenous vein instead of using a synthetic graft? Because I'm afraid that if I put myself in your shoes, I'm afraid that this saphenous vein might have some tortuosity or might be compressed easily. So I would prefer to use a thin synthetic graft instead of having the saphenous vein as a conduit. Second is about the site of the distal of your take-off anastomosis. Okay. what's your tips and tricks regarding this?
Okay, let me tell you, at the beginning we were thinking about iliac branch to be put in this pelvic kidney, and we continue the procedure with EVAR. But measurement showed that this artery was 4 millimeter in diameter with severe stenosis at its proximal part. And usually during EVAR, we don't have brogue light, so we did expose the femoral artery on both sides and the saphenous just in the back door of my incision. So it was easy to get the saphenous and do the anastomosis. Concerning the proximal or the inflow to this one, I exposed the proximal part of the external iliac artery for two main reasons: just to land distally by the iliac limb to the bifurcation of the common iliac, and at the same time it's going to be a landmark for me to put the distal end of this limb on that side.
Thank you very much. To the next presenter, Professor Dr. Ayman Al-Samadouni. I have one question for him. Dr. Ayman, I think you didn't show us what happened to your patient. What did you do?
Sorry for that, I wasn't ready for photographs in the OR, so all I have the pre-op and the post-op of imaging. But what we did is that a midline exposure with right medial vessel rotation, just dislodging the cecum and appendix all the way from the right to the left, and then exposed the common iliac artery at the bifurcation of the aorta. Where I did work, I was lucky enough not to injure the last lumbar artery, which is replacing the renal artery. I had a place, tight place, but I had a place to place my clamp where I oversewn this right common iliac artery, and then I did fem bypass.
Did you need to remove anything? Because
I did remove the aneurysm. I did remove
the sac,
the infection, sac, everything.
Any muscle.
I did curettage the muscles. I did everything in the book. I mean, as I said in my review, the only success is to remove all possible infected and possible infected tissues. You just do not reside to what is really there. It's not only the sac and everything be around it.
But there was no other important structures involved that you had to remove, like the aorta.
Alhamdulillah.
Thank you.
You're more than welcome.
Dr. Hisham.
Thank you, Dr. Ayman, for this challenging case. But you excluding this patient is basic disease because of the aneurysm is more or less secular aneurysm, and it is apparently pseudo-aneurysm.
The patient is coming with definitely with infection, sepsis, and he had this for 2 weeks prior to the admission, and the blood culture come positive for a bacteria, which is Salmonella enteritidis, and all the infective parameters were high. So I did not think of a vasculitic aneurysm. I did think about infected aneurysm, and that was the biopsy really. When I sent the removed the aneurysm to the pathology, it did confirm my diagnosis of microbial arthritis.
The next presenter is Dr. Muhammad Abdelati, who presented the multidisciplinary management of aneurysm associated with congenital vascular malformation. Does anyone have a question to Dr. Abdelati? Dr. Hussein?
Muhammad, thanks for your presentation. I have only a comment about cirrhoid aneurysm of the scalp. I think even in the pictures you have shown us, it is not a curative treatment. Injection and ligation is not a curative treatment. We have a large experience in cirrhoid aneurysm excision. My senior, Professor Yasser Misbah, published this series with me, and I follow him in doing such cases. We do surgical excision, ligation of the feeding vessels, elevation of the flap, and applying a tourniquet on the scalp, and in subgaleal position, we remove all the tissue in one session. Injection, I think it will not solve the problem, and even if in the picture you do several repeated injection, and the patient is still complaining. You have 10 years experience. The paper is published internationally in the World Neurosurgery Journal, and up till now, we have no recurrence. Thanks a lot.
Thank you, Dr. Sam. I completely agree with you. The issue that you are speaking about was mentioned in my lecture, that the ideal treatment is complete obliteration and the destruction of the aneurysm nidus, either by complete surgical excision. But sometimes these aneurysms, like the third case I have presented, the aneurysms were very large. It was very difficult to remove them surgically in a surgical session. So we preferred to give the patient the chance for injection sclerotherapy sessions, and we follow up the patient. If we have seen that he will need surgical excision, we may consider this option in the future.
Dr. Muhammad, as regards to pseudo-aneurysm, الحقيقة I am very glad by the cases, all the cases you present except the pseudo-aneurysm. Pseudo-aneurysm is very high flow, arteriovenous communication, which you need complete excision. You may make use of the presence of a plastic surgeon with you to excise the pseudo-aneurysm and do a rotational scalp flap. But injection alone is not the correct way to treat such pseudo-aneurysm. Okay. Thank you.
Okay, thank you. I agree with you. Thank you.
Dr. Muhammad, thank you for these cases you illustrate in your presentation. But for the cases of the upper limb aneurysm and brachial artery, I think the injection of onyx in these cases is not suitable for obliteration of this branch, and the surgical direct attack for the ligation of the branch or using an coil. But an onyx, it is expensive, the first one, and it is not closing the branch from brachial artery supplying the aneurysm, especially it is accessible at that site.
Thank you, Professor. I agree with you that it's accessible surgically, but this patient came to us after attack of bleeding, after trial of surgical excision. It was mistakenly diagnosed as an abscess, and it was incised. And she came to us with active attack of bleeding. So we preferred the endovascular option for here.
Sometimes we need to do direct injection, duplex guided. After you obliterate the arterial side, you obliterate also the venous. You do that for this patient?
Yes, this depends on the CT angio. We did the CT angio, and we saw that there is a single arterial feeder in the CT angio, so it was accessible by endovascular embolization.
Thank you very much, Dr. Muhammad. We'll move to the second presenter, Professor Dr. Sam Al-Qusayr, about recurrent aortoenteric fistula after EVAR, the nightmare case. Any question to Dr. Qusayr? Dr. Magdi Haggag, give him the microphone, please.
Dr. Sami, wouldn't you think that it's Marfan or Marfanoid syndrome from the beginning, and you exclude this Bassett phenomena? The scenario goes totally with a genetically based vascular disease, maybe Ehlers-Danlos or Marfan or Marfanoid or something.
No, I mean, first, he doesn't look like a Marfan. He has no history. The shape, he's short. It's not like tall. Then we did a genetic, he's not. I mean, he is positive for Behçet disease, so he has an active vasculitis. The reason why he keep recurrent, because he doesn't take medication. Every time we put him prednisone, he stopped it. I mean, he's completely not cooperative. The reason why he keep coming back. Because he's not convinced that a cortisone, he's afraid that if he take cortisone will be fat and all the things, so, I mean.
I agree, Dr. Sam, that also the main problem with Behçet's is the failure of the patient to maintain the treatment. It's the most important to avoid another relapse in another area is to must suppress the activity. And I see many patients like this with multiple starting from femoral, popliteal, aorta, and later on thoracic. Most of this patient doesn't respond to the treatment because they taking 1 month, 2 months, and relapse again. And that's why I totally agree this is a basis with you. Thank you for your effort for this patient and waiting next year for what happened later on.
This is the reason why, you see, when we do a thoracoabdominal, we use a patch, you know, for the SMA celiac. Here, I did not do a patch because I'm sure he will come back. If I leave a patch, he will come aneurysm, be very difficult to deal with it. Now I did a bypass individual. So if he gets with aneurysm, now I can go endovascular and put a cover stent. So the reason why we did individual bypass. And I'm sure he will come back later on with the aneurysm, but now at least I have an access. You have an aorta bifims there. So most probably the future all be endovascular, hopefully. It's free. Saudi, yeah, it's free. Yeah. Okay, thanks.
Dr. Samer, for this challenging nightmare case with recurrence of aneurysms, after your experience in this case, you're recommending a surgical approach for this patient because of the possibility of the puncture site aneurysms as occurred for this patient, especially young patient. Do you recommend to attack the patient surgically and wrapping the site of the anastomosis to prevent the presence of anastomotic aneurysm, or to try endovascular first?
I mean, it's a difficult question to answer. I think both options are the problems, because you see, with a brachial artery aneurysm, we did an open 3 times and keep coming back, you know. With the endovascular, you get aneurysm from puncture site. So I think the most important to control his vasculitis, you know, this is the most important part. But to do surgery or endovascular, I think both you get into trouble. I mean, if you do an open repair, you can get aneurysm, you know, at the anastomosis site. If you do endovascular, also you may get the problems with the puncture site. So really, is no easy solution for these patients, you know. But the most important, I think, is controlling his vasculitis. It's the only way you can prevent recurrence.
Okay, thank you very much. For the sake of time, just the 3 last presenter, everyone can have one question if you don't mind. Professor Dr. Ahmad Taha, actually there are 4 presenters, endovascular option of iliac artery aneurysm. Is there any question to Professor Ahmad Taha? Professor Ahmed Sulaiman?
Yes. If you have a young patient with common iliac artery aneurysm of both sides, and you need to preserve internal iliac artery, what you prefer? You prefer to do IBD graft for both sides at the same time, or you do one side and overstenting the other side, or you do one side and postpone the other one for later on?
Well, it's difficult to answer because I don't have that vast experience regarding both iliac arteries treated endovascularly. But what's reported in the literature, it's better to preserve at least one iliac artery. That's easier, that saves time, that saves money, because it's also bilateral iliac branch is rather costly. So I do prefer to coil one iliac artery and to revascularize the other one.
Thank you.
Thank you. We will move to the next presenter, Professor Muhammad Al-Hinaydi, Management of Abdominal Aortic Aneurysm in Horseshoe Kidney, Dr. Tara Abdulazim, and Dr. Ahmad Nasif.
Yeah, thank you, Muhammad, for a nice presentation. My question is, why did you not go through a retroperitoneal approach? Because that's the standard for a horseshoe kidney. You totally avoid the isthmus with all its problems. It's all pushed forward, and you're coming at it from behind. And if you need to replant any of the accessory vessels, they're right there at you. It's much simpler than going through the approach to get to the neck of the aneurysm. Sometimes necessary to divide the isthmus with all the problems that come with that.
My answer, I wrote it in my presentation, according to the surgeon experience. My experience in aortic aneurysm through transperitoneal approach, not retroperitoneal, and I don't prefer to do the first time in this patient.
Okay.
Thank you. So Dr. Ahmad Nasif, okay, that's fine. So the same question from Dr. Ahmad Nasif. So to Professor Dr. Samih Mustafa, traumatic femoral pseudo-aneurysm, unexpected scenario. Is there any question for him? Dr. Omar?
Dr. Samih, you are lucky to have this aneurysm with its neck in the first part of superficial femoral artery.
I mentioned it in my
yeah,
presentation.
Yeah, but if it is from the common femoral artery, what would you do?
My first choice is surgery, is open surgery.
Why? Just to clarify to me and to our young colleague, why? Why it is better to do surgery if it is common femoral artery?
It is a site of bifurcation, so I need to keep the profunda open. It's a site of common stent fracture.
For later catheterization.
Yes, yes. It's a stent fracture. It's common in this site, so I prefer to do it surgically.
And not to put a covered stent in the common femoral artery, aside of joint mobilizations and dictum.
Very high rate of fracture and thrombosis.
So if it is from the common femoral artery, surgery is number one.
Surgery is always number one.
Thank you.
Thank you. A quick comment from Professor Dr. Ahmed Taha.
Sameh, you my friend, and I will offer you a decent proposal, not indecent proposal.
Thank you.
I faced some of these cases with feeding branches like you met in this case.
Yeah.
But during the procedure, I do something. I use a balloon just by the size of the aneurysm or the opening of the aneurysm, so it is a false aneurysm.
Yeah.
And then I open up this balloon, and then I do angiography when I close this aneurysm, as if I did excise it completely.
Yeah.
And then I wait for even the delayed phase of injection.
Yes.
You will find these branches filling back to the aneurysm.
Yes, I totally agree to what you said, sir. But in this situation, I waited until the delayed exposure.
Just my way
at the first time. I totally agree to your technique, and it's a wonderful one. But when I put my covered stent at the first time in round one, as I named it, I waited for the delayed exposure film. We found nothing. I think it is some sort of preferential flow. I had a very large pseudo-aneurysm, trilobular as we saw in the photos, and another hidden one by the preferential flow. This hidden one revealed open and obvious when we covered the larger one.
You didn't catch my point. When you put the covered stent already, you have a proximal landing and distal landing.
Yes.
So it's a long segment occluded.
Yes.
What I'm saying, just to the aneurysm only.
Yeah.
You put like an occluding balloon in this area and you inject.
Yes.
You will find these branches, because I face some of these cases, and as we are dealing with superficial femoral artery, I took the patient back to the cath lab, and I did angiography and percutaneous ligation of these branches. I didn't inject them. I just saw where they are, and then I go directly by them by stab puncture, and then I get ligated or clip them, and that's it. And then do angiography.
Sir, every time you prove that I learn much from you. I will try it. I promise I'll try it next time.
Thank you very much. The last question to Professor Dr. Hussam Al-Wakil about sciatic artery aneurysm. Dr. Ahmed Nasif.
Hussam, thank you. I've never seen one of those before. So thank you for teaching us something. A couple of things. How did it feel stitching that artery? Does it feel like any other normal artery?
Yes.
All right, okay. Have you thought about, it's a beautiful dissection, no doubt, but it is equally an extensive amount of dissection, isn't it? So what about...
For about 30 centimeters.
So what about endovascular occlusion of that sciatic artery and bypass, and just harvest?
Actually, we do bypass, but we use the native sciatic artery at the conduit of bypass, actually.
No, but to avoid...
Not a synthetic, not a saphenous graft.
No, what I meant, no, totally, and I understand that, I get that, of course. And it's very elegant what you've done, no doubt. It's just a question that came up to my mind as you were presenting. What about in the vascular occlusion of the sciatic artery and harvest the long saphenous vein and bypass? to avoid that buttock and back of side dissection? And
I have to tell you, and in my presentation, I said the patient have sciatic nerve compression resulting in foot drop. I have to resolve this big mass compressing the sciatic nerve and causing foot drop to the patient.
Sure.
And actually, he improved after this.
That was going to be the next question. Has he improved?
Yes.
Right, okay. Thank you.
Thank you very much. I'm sorry to have to end this session now because of the lack of time, and we would welcome Professor Dr. Hisham Mustafa, the moderator of session 9, to start session 9 now. Thank you very much.
لحد لو في برانش تحت من السوبرفيشال فيلم.
مساء الخير عليكم جميعا. احنا we have to start this coming session because we are we having delay in time. Please, we want to start the next session. Professor Nabil Al-Meheri. Professor Hussam Al-Wakil. Professor Ayman Rifat. تمام. طلعت من ورايا ازاي انت؟ I have a short announcement. يا دكتور نادر، دكتور سامح. I have a short announcement that we have today in the coming sessions. There is a tombola. هنعمل سحب على ارقام الناس اللي موجودين معانا، سحب عشوائي في وقت عشوائي بجوائز هايله جدا جدا جدا، احسن من امبارح. لا جوائز علميه ولكجيريوس كمان. سحب عشوائي في وقت عشوائي النهارده، في اي لحظه هنعمل السحب. الحاجه الثانيه ان بكره في نهايه اليوم ان شاء الله في وقت عشوائي برضو هنعمل سحب على جوائز ذهب. جوائز ذهب اللي عايز يجيب هديه لمراته هنديها له واحنا جاهزه. التسجيل بتاع النهارده مع شركه ديفارت لاب. سوري، بتاع النهارده مع حفني جروب، بكره ديفارت لاب. استحالة استحالة. فالنهارده شركة حفني جروب مقدمة برضو جوائز زي امبارح، اللي عايز ياخد منهم رقم وعلشان يخش في السحب. بكره ديفارت لاب مقدمة جوائز ذهب. طبعا هي كانت مفاجأة لكن انا قلتها لكم عشان برضو ما نأذيكوش مع مراتاتكم. ما انا قلت اهو ديفارت لاب تروح تاخد منها رقم عشان بكره. حفني جروب تاخد منه رقم عشان النهارده. هنبدا السيشن. مشكورين. دكتور حسام الوكيل هيبقى المودريتور بتاع السيشن دي. دكتور هشام مصطفى ما جاش.
بسم الله الرحمن الرحيم.
دكتور عمرو جاد فين؟ دكتور عمرو جاد. طب الدكتور رأفت نجا. تعالى تعالى تعالى. يا دكتور حسام اتفضل.
We will start our session on the visceral aneurysm by a topic titled Visceral Aneurysm. What do we need to know for a successful intervention? Professor Gamal Niazi, Ain Shams University.
Good afternoon, dear professors and colleagues, and many thanks for this kind invitation to this very elegant meeting. We'll talk about the visceral artery aneurysms and what do we need to know for a successful intervention or before a successful intervention. They are not very common. However, the visceral artery aneurysms are still clinically important, as 25% of patients with visceral artery aneurysms present with rupture, which is associated with a mortality rate of 25 to 70%. They are often clinically silent or associated with non-specific symptoms, making early diagnosis difficult. And the treatment options include a wide variety of endovascular and open surgical techniques, which are tailored to the individual aneurysm, depending on the aneurysm type, anatomic features, rate of enlargement, and the clinical status of the patient. And first, we should distinguish between the true aneurysm and the false aneurysm or the pseudo-aneurysm. The true aneurysm, as we all know, it's characterized by dilation and thinning of the entirety of the vessel wall greater than 1.5 times the expected vessel diameter. And this is the most important, it includes all the 3 tunical layers of the artery. The pseudo-aneurysms are mostly a result of traumatic disruption of the antemal and medial layers of the vessel, with the aneurysm contained by the adventitia or the perivascular tissues. The most important is that the rate of rupture in pseudoaneurysms, especially the visceral pseudoaneurysms, has been reported to be much higher than true aneurysms. What is the prevalence of visceral artery aneurysms in general? The splenic artery aneurysms come first with 60 to 70% rate. This is followed by the hepatic artery aneurysms, especially they are increasing after the era of liver transplantation and hepatic surgical resections. Then the celiac artery and the superior mesenteric artery aneurysms, which account for 10% of the encountered pseudoaneurysms, and then the renal artery aneurysms, which are 5% of the encountered visceral aneurysms, especially after nephrolithotomies or renal biopsies. Now, what do we need to know before interventions? We need to know the type of aneurysm, whether it's true aneurysm or pseudoaneurysm. We need to know the size of the aneurysm. Again, aneurysm is defined as dilation of an artery of more than 1.5 times its normal. The shape of the aneurysm is very important, fusiform or saccular, narrow neck or wide neck, as saccular aneurysms may be more prone to rupture than fusiform aneurysm of similar diameter due to increased wall stress. And the presence or not of calcifications, because calcifications that occur early in aneurysm development may prevent expansion of the aneurysm. Here is an illustration of how the shape of the aneurysm and its neck can alter the options of intervention, whether stenting or coiling. Now, what are the imaging modalities available for diagnosis and screening and detection of the aneurysms and its criteria? Ultrasound and Doppler, CT and CT angiography, MRI and MRA, and then transcatheter digital subtraction angiography. Ultrasound and Doppler, of course, are the first modality we refer the patient to for diagnosis of visceral artery aneurysms. It has many advantages, but also has some limitations. The advantages, it's a real-time imaging technique. It's a dynamic modality of imaging where the type and direction of blood flow can be detected. It's a screening modality. It's the first modality in which we can diagnose the presence or not of visceral artery aneurysm. It has no ionizing radiation and no contrast agent hazards, which is suitable for patients with renal impairment, those allergic to contrast agents, and of course in pregnant patients. The limitations, small aneurysms can be missed or inadequately visualized. It's an operator-dependent, and it's also a patient-dependent technique, as a bad patient preparation can reduce the diagnostic capability. And details about the size and shape of the aneurysm and its neck and the feeding artery are usually inadequate, what we call a lack of spatial resolution. CT angiography now is the imaging modality of choice for detection, for diagnosis of visceral artery aneurysms. It gives adequate details about the type, shape, size of the aneurysm, which helps in treatment planning and mapping. Also, the rupture of aneurysm can be identified in CT as contrast extravasation. It helps in post-operative follow-up. And now the recent advances in CT imaging allows 3D volume images, 3D volume rendering, which helps to understand a 3D anatomy of the aneurysm, to recognize the feeding and outflow branches, and identify organ risk. The limitations include patients' exposure to ionizing radiation. It's not suitable for patients with renal impairment and those with allergy to contrast agents, and not suitable for pregnant women. This is an example, illustrative examples of how CT can diagnose aneurysm. Here is the picture of a splenic artery aneurysm diagnosed by CT with clear visualization of the feeding artery. Also, a ruptured or a leaking splenic artery aneurysm with perianeurysmal hematoma can be easily and clearly identified by CT. Also, the 3D volume rendering can give more visualization of the shape of the aneurysm and feeding arteries. Here is CT images that can diagnose the stent after stent placement, thrombosed stent, or a patent stent can be easily diagnosed by CT. And the 3D volume rendering, the recent advances in CT can diagnose very small aneurysms with the feeding arteries. MRI mostly used in patients with renal impairment or those with history of allergy to contrast agents or in pregnant women. It has no ionizing radiation. However, some clips and stents and coils can cause artifacts which may render assessment difficult or even impossible. And finally, the transcatheter digital subtraction angiography, it's used in diagnosis of visceral aneurysms and is considered to be the gold standard, especially if intervention is planned, and especially in emergency cases where intervention is required at once. Angiography has highest resolution. However, this is an invasive technique. That's why it's usually only pursued if an intervention is planned. The catheter-based angiography is frequently performed using the digital subtraction angiography techniques. And angiography identifies clearly the location of the aneurysm, the source of bleeding, pattern of inflow and outflow, eccentricity, collateral circulation, as well as other visceral aneurysms. And of course, it helps in direct intervention when it's indicated. This is an example of a traumatic renal artery pseudoaneurysm after nephrolithotomy. Here is the catheter-based digital subtraction angiography with the catheter tip directly in the artery from which the aneurysm is arising, clearly identifying the aneurysm and its neck. And here, after embolization of this aneurysm using large-sized particles, the aneurysm has totally been disappeared. In conclusions, the visceral artery aneurysms are believed to be rare, but their detectability has been increasing with the development of imaging modalities. CT angiography with 3D volume rendering is the imaging modality of choice if treatment is required. And thank you. Please conclude.
The next speaker will be Professor Wael Sha'lan. He will talk about updated guidelines for management of visceral aneurysms.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, dear professors and colleagues. I'll be presenting the Society of Vascular Surgery Clinical Practice Guidelines on the Management of Visceral Aneurysms 2020. And I think Dr. Gamal made it easy for me because he mentioned most of the I'm going to mention. Although it represents a rare pathology, yet it mandates awareness due to their potentially lethal clinical course. This table shows us some of the clinical characteristics of specific visceral aneurysms. For example, splenic artery is the most common, representing 30 to 36% of the cases, followed by the renal artery aneurysm, 22%. In females, the most common is the splenic and the renal artery. Splenic artery aneurysms are associated with portal hypertension, pancreatitis, and multiparous women, whilst superior mesenteric artery aneurysm with inflammation, trauma, and infection. Fibromuscular dysplasia is associated with renal artery aneurysms. The most common to happen during pregnancy is the splenic and renal artery and has a high rate of rupture, while the superior mesenteric artery aneurysm is the most symptomatic one. As regards the gastroepiploic and the pancreaticoduodenal aneurysms are associated with the highest rate of rupture, amounting to 90% of rupture. The clinical practice guidelines include diagnostic tools, indications for the treatment, procedures of intervention, and ends up with the screening and surveillance recommendations. First, for the diagnosis, as Dr. Gamal mentioned, we have three modalities of the diagnosis: CT angio, MRA, and catheter-based diagnostic angio. CT angio is the diagnostic tool of choice, while MRA is indicated for children, women of childbearing potential, contraindication to contrast material like in pregnancy, renal insufficiency, or material allergy. What about catheter-based diagnostic angio? It's indicated for preoperative endovascular interventions, better for delineating distal branches and emergent cases with the intent to treat. The role of duplex in screening as well as in diagnosing celiac artery stenosis that is associated with pancreaticoduodenal and gastroduodenal aneurysms. Inflammatory markers should be done for vasculitis as in hepatic, jejunal, iliac, and celiac artery aneurysms. As regards indications of the treatment, for asymptomatic, non-ruptured, non-complicated renal and splenic artery aneurysm, the size threshold is 3 centimeters. More than 3 centimeters, we interfere. But for celiac, hepatic, jejunal, and iliac, it's only 2 centimeters because of the small size of the artery and the highest rate of rupture. For such aneurysms, if they are becoming symptomatic or presenting with rupture, or in a female of a childbearing potential, or associated with pseudo-aneurysm and the increased rate of enlargement half a centimeter more per year, or vasculitis, we interfere at any size. Don't wait for the size threshold. On the other hand, for a small superior mesenteric artery aneurysm, gastric, gastrohepatic, pancreaticoduodenal, gastroduodenal, and the colic, it should be treated even if asymptomatic at any size for fear of rupture and high propensity of complications. What are the treatment options? These include observational management, surgical intervention that includes either elective or emergent basis, and either revascularization or ligation and excision of the aneurysm. For endovascular interventions, we have deployment of coils or glue, injection of particles, placement of covered stent, or injection of thrombin or ethyl alcohol. We'll go through specific visceral aneurysm and the treatment options for each one. For renal artery aneurysm, it's recommended to have daily antiplatelet therapy. Open surgical reconstructive techniques is suggested for the elective repair of most renal artery aneurysms, especially with acceptable operative risk. For complex distal branch aneurysms, not in the main artery, ex vivo repair and autotransplantation is suggested over nephrectomy when it's technically feasible. In patients with poor operative risk, endovascular techniques for the elective repair of anatomically appropriate renal artery aneurysm are suggested, and this includes Stent-graft exclusion of the main artery and embolization of the distal and the parenchymal aneurysms, as you see here in the photo. For splenic artery aneurysms, for elective treatment, endovascular approach is suggested if it's anatomically feasible. However, elective treatment may involve open surgical methods with splenectomy. In patients with ruptured splenic artery discovered at laparotomy, suggested treatment is ligation and with or without splenectomy. In patients with ruptured splenic artery diagnosed on preoperative basis, treatment with surgery or endovascular technique is suggested based on the patient's anatomy and underlying clinical condition. In the treatment of splenic artery aneurysm, it's suggested that the splenic artery doesn't routinely require preservation or revascularization. And in case of distal splenic artery adjacent to the hilum of the spleen, surgery is better than the endovascular option to avoid splenic infarction and pancreatitis. What if you present with a splenic artery during pregnancy? Treatment decisions should be individualized regardless of the size and the potential morbidity to both the mother and the fetus. Celiac artery aneurysm, for the elective treatment, is suggested to do endovascular intervention if it's anatomically feasible. However, elective treatment may involve open surgical intervention. In patients with ruptured celiac artery aneurysm discovered at laparotomy, ligation is suggested if sufficient collateral circulation to the liver can be documented. And the inpatient if ruptured preoperatively, treatment would include open or endovascular interventions. To determine the need for revascularization, CT angio should be done preoperatively to detect the superior mesenteric and gastroduodenal artery flow. Hepatic artery endovascular approach is recommended to all cases if anatomically feasible. In patients with extrahepatic aneurysms, open or endovascular techniques are recommended to maintain liver circulation. Superior mesenteric artery aneurysms, endovascular first approach to all aneurysm is recommended. For gastric and the gastropublic artery as well, endovascular embolization is recommended, as you see here in the photo. And as well, the pancreatic and gastroduodenal artery is recommended for coil embolization. If coil failed, we can use covered stent or transcatheter embolization or flow diverting stents. If we need to preserve the flow in non-ruptured aneurysm, open surgical reconstruction is suggested. In patients with concomitant celiac artery stenosis, it needs to reconstruction. And lastly, for the jejunal, iliac, and the colic artery aneurysms, elective cases needs an endovascular embolization is suggested, while enduring laparotomy for hematoma evacuation, open surgery and ligation of the aneurysm excision is suggested. And for aneurysms with polyarteritis nodosa, treatment is medical treatment only. Screening for visceral aneurysm entails screening by CT angio and MRA for concomitant intra-abdominal aneurysms. It's recommended to have screening CTA or MRA for segmental arterial medullolysis and for patients with fibromuscular dysplasia to exclude cerebrovascular, mesenteric, and iliac artery dysplasia. Surveillance for non-operatively managed patients to detect any growth or enlargement of the aneurysm, and after endovascular interventions for endoleaks and the possible aneurysm reperfusion. Thank you for your attention.
Thank you, Dr. Wael, about this nice presentation. It is my great honor to present Dr. Ahmed Nasif. He will talk about management of visceral arterial aneurysms.
لغاية لما المحاضرة تطلع. السلام عليكم. Thank you very much indeed, Dr. Mustafa Sliman and the organizing committee. Thank you. أهو. متشكر يا دكتور مصطفى، ربنا يخليك، كتر خيرك. previous two speakers made my life with Dr. Mahmoud Salah in the morning made my life very easy الحقيقة. يعني they gave me 20 minutes and I will now finish you in a minute because I am going to start by the take-home message from the previous three talks. How can I move forward? Yeah, okay. So they are rare aneurysms. Most of them do not require treatment. Treatment depends on their size, their location within the visceral circulation, the symptoms, patient characteristics. They need good planning, and the endovascular approach should go first, like the most vascular problems nowadays. But the open alternative is equally useful. They are rare. The majority are incidentally diagnosed during abdominal imaging. And as the previous speakers mentioned, the splenic aneurysms are the most frequent, and then the rest come after. Some would present with pain, and the pain could be the result of expansion or compression on the surrounding structures, or atheroembolization. In here, you could see a large superior mesenteric artery aneurysm that embolized to the small gut and presented with acute abdomen, and that could be obviously another indication for intervention, and rupture as well. Which one of them would rupture? Well, the exact risk of rupture is not certain.
nor size related, but it is certainly higher with gastroduodenal artery aneurysms and pancreaticoduodenal artery aneurysms. The mortality risk is quite high. It's 50% mortality. If it happens in pregnancy, the maternal mortality is 70% and the fetal mortality is 95%. And that's why, as the previous two speakers mentioned, you should treat visceral artery aneurysms during the childbearing period and pregnancy. So how do we manage them? What do we do? Well, in the majority of the cases, we do nothing. We just follow them up. Because of the perceived low risk of rupture or the low risk of rupture, we manage them conservatively with best medical treatment and surveillance. The frequency of surveillance and the modality would depend on the location of the visceral artery aneurysm and the size stability. If you give them a CT scan or an MR scan or an ultrasound scan and the size is 2 centimeters year on, year on, year on, then you decide perhaps either to abandon surveillance altogether or to perhaps reduce the frequency. We talked about calcification, or the previous speaker. I should just mention that calcification is not an inverse risk factor for rupture, so it should not give you a false sense of security. What about those that we are going to treat? Well, the treatment will depend on the size, as I said, and as the previous speakers mentioned. Some of them would have to be treated because of their location and the patient characteristics, or if they were symptomatic. The workup, we always do an image of some description, either a CT or maybe even catheter-directed angiogram. And what we're looking for, as they said, the location, whether they are proximal in the circulation, whether they are close to the origin of the SMA, the superior mesenteric artery, etc., or whether they are distal, the state of the inflow, the outflow, and the collateral circulation. What would happen if you completely ablate the aneurysm to the rest of the gut? And also image is used to assess a strategy and sort of plan the strategy for approach. So that's a CT scan for a superior mesenteric artery aneurysm. We're talking about a gastroduodenal artery aneurysm, and you could see that the CT scan was not good enough, and we had to do a catheter-directed angiogram to appreciate the anatomy of the aneurysm. Treatment, as they said, endovascular is first. Open if endovascular is not an option because of morphological non-suitability or access issues, or if you would like to maintain the end organ, or if the endovascular approach is going to compromise the end organ. You've seen this before, the various techniques for endovascular repair. It requires a special set of skills. It's different because oftentimes you are working across so many platforms, not just one platform or two platforms for deploying a superior mesenteric artery stent, but for managing a pancreaticoduodenal artery aneurysm, having to embolize the inferior pancreaticoduodenal artery, you might have to be working across 3 platforms, which is quite challenging. And obviously a lot of resources are required. 3D printing and simulation, this is up and coming. It's been there for about 15 years or so to make it easier for people to plan a strategy of attack. I think we can skip that. Well, we talked about why we do open surgery for visceral artery aneurysms, for unsuitable morphology or failure endovascular treatment or end organ compromise. And all options are available. You resect it and you do end-to-end anastomosis or bypass grafting, or you ligate and you remove the organ, like, for example, splenectomy. You could put a prosthetic graft. That's a celiac artery aneurysm that we fixed with a prosthetic graft. Or you could put a long saphenous vein graft. That's a long saphenous vein graft that we put in the middle of the superior mesenteric artery. Or you could do a hybrid approach. So that's a pancreatic or duodenal artery in the presence of an occluded celiac artery, and we had to coil it just simply because it wasn't possible to do anything else about it, but we gave the patient a bypass to the dorsal pancreatic artery to supply the foregut. There hasn't been any randomized control trials comparing the endo option and the open option, but the meta-analysis on the basis of which the SVS guidelines that you've just heard about looked at 1,500 visceral artery aneurysms between 1980 and 2017, obviously a mixed bag of aneurysms and a heterogeneous group, and endovascular repair was at its infancy, but it essentially did not show any difference between open and endovascular repair, and they suggested that each has their place in management of visceral artery aneurysms. And that's excellent that they have decided to finish my talk. Oh, do you want me to carry on? All right. Okay, fair enough. Well, there are only 2 slides left, so, okay. So, what else? It's not moving. Enter? Okay, sure. So that's our experience, and it's not very dissimilar from other people. I think between 2002 and 2019, the period I worked in Sheffield, we looked at 31 of them. About half were managed endovascularly and half with open repair. I think the large number of splenic artery aneurysms and other aneurysms, and the number in the experience or the series in general, I think reflects the fact that we weren't guided by size previously, so we would have operated or embolized an aneurysm at 2 centimeters, for example, which is something that we would never do now. So the last slide is the take-home message. They are rare. They are mostly incidentally diagnosed. They do not require treatment. Treat them in all pregnant women and those in the childbearing period. The endovascular approach should come first. However, open repair or fixing has its role. Thank you very much.
Thanks to Professor Nassif. I have the pleasure to present Professor Dr. Amr Abdelrahim Kasrilani and the title of SMA aneurysm in Behçet disease, possible options.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. I'd like to thank Professor Mustafa Sulaiman for such a tremendous meeting. To start with SMA aneurysm in Behçet disease. First background, as my colleagues mentioned, aneurysm of the SMA represent approximately 6% of all splenic artery aneurysms. Traditionally, to affect men and women equally over the age of 50. However, recently it was shown that it has a male predominance, especially those who are mycotic aneurysm. They occur almost exclusively in the first 5 centimeters of the artery. Its etiology, the most common etiology of SMA aneurysm is infections that say mycotic etiology around or account for around 6% of all aneurysms. Other causes includes the others, including atherosclerosis, connective tissue diseases, polyarteritis nodosa, even arthritis or pancreatitis. The clinical presentations differs according, or it has a different presentations, maybe non-ruptured SMA is just vague colic pain, abdominal angina, and weight loss. Mycotic aneurysm has got fever in addition to weight loss and nausea and vomiting. Maybe associated other problems, other pathology, as in Behçet disease, maybe orogenital ulcer, associated venous disease, although it's a rare condition to occur. Ruptures of SMA aneurysm ranged around from 38 to 50%, with mortality goes around 30 to 90% because of hemorrhage or ischemia. Treatment may be conservative, especially for those less than 2.5 centimeters. Surgical, those are mycotic aneurysms should be repaired. Either aneurysmectomy, reconstruction, just ligation in certain situations. Maybe in the endovascular, the EVAR or covered stent. Our real life scenario is the patient, male patient, 35 years old. He's not diabetic, no other comorbidities. He has got Behçet disease, which is proven by recurrent oral ulcers, previous bilateral, deep venous thrombosis, and pulmonary embolism. He was accidentally discovered to have an SMA and left common iliac aneurysm following an attack of melena due to warfarin overdose. And this is the angiogram of the patient showing the descending. The thoracic aorta is 2.2 centimeters, abdominal aorta 1.9, and there is a large saccular aneurysm, SMA aneurysm, about 3.3 to 3.3 centimeters, and another left common iliac aneurysm, 3.4 centimeters. So, how to proceed with this patient? If it's wise to have a conservative treatment for this patient, I think it's not the good option for this patient, but it may take some time during controlling activity. Just conservative treatment, just to control the activity by immunosuppressants. So we have to intervene, and we have the options, either open or endovascular. So, which of which? The endovascular treatment, we may have a T-branch, but as you know that the T-branch requires specific measurements. As I mentioned before, the descending thoracic aorta was 2.2 centimeters, and the abdominal is 1.9. So the T-branch is with the on-shelf, off-shelf T-branch may be not the suitable solution. Either or it is made, or should be a custom made, and would be not suitable, and with patient with large saccular and aneurysm bending rupture. So the other option would be the covered stent, but the patient, as I've mentioned, has got a large saccular aneurysm with a wide neck and a proximal aneurysm, so to not be suitable for covered stent, and embolization would be not also the suitable solution. So we go for open surgery, but we still have some dilemma. Are you going to proceed transperitoneal? And if transperitoneal, either we go by midline, zone 1 aortic exposure, or medial visceral rotation, or to start getting from the start with the retroperitoneal approach. We choose to the transperitoneal zone 1 exposure because the aneurysm is, if you go with the retroperitoneal, we can get controlling the aneurysm, but we cannot get to the distal part of it. So doing our bypass will be this approach will not help us to do the proper bypass to the distal part of the artery. So we choose the transperitoneal approach. We have also either zone 1 exposure or using the medial visceral rotation, but also we could use the medial visceral rotation, but the same will not have the distal part of the artery. So we choose to use the transperitoneal zone 1 exposure. The other ideas are in going to use an autogenous or synthetic graft, and either to do the SMA aneurysm alone, or doing both aneurysm. I mean the SMA aneurysm and the common iliac aneurysm. Our plan was to use an autogenous and to do a synchronous operation treating both aneurysm. But we started actually with an autogenous vein graft, but we try to control the aneurysm first and before excision of the aneurysm, we do the bypass. So unfortunately, the vein becomes thrombosed at the end of the day. So we reoperate the patient again, and we put a Stent-graft. The same for the other aneurysm. We've tried to do both aneurysm at the same time, but we found that the operation was that tedious, a lot of adhesions, and was that lengthy. So which we was obliged to do the SMA aneurysm alone. So, and this is our CTE after the post-operatively. We have the synthetic graft. Sorry. خلاص اوكي خلاص وصل خلاص ما كانتش خدش من فضلك خلاص اوكي عايز الصوره الايمج بس هي نفس الصورة أخير هي سنت آخر واحدة بس عندي نفس آخر سلايد أوكي بس فاتي الصورة بقى بس فاتي الصورة نفسها So we use the sensitive graft and the nicely patent. We do a retrograde approach through the distal part of the aorta to the SMA, and we postpone the other sacral aneurysm in the left common iliac artery to another session, and that it's similar to the what's Professor Ahmed Taha was showing before, that this maybe at this time we could go for an endovascular approach to control these aneurysms, especially the patient will have a previous operation. Thank you.
Okay, now we will present to the Professor Muhammad Omar Al-Farouk. He will speak about celiac artery aneurysms, endovascular repair.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind invitation, and Professor Mustafa for a great effort to the program. All the cases that you have seen, all of them have got better. My patient has died. And usually the patient that dies usually get most lessons from. So I will share with you this patient who has 9 centimeter of celiac artery aneurysm. He's 87, male patient, presented severe abdominal pain with pulsatile abdominal mass that you would thought it's an aneurysm of the abdominal aorta. He has MI 3 years ago, cholecystectomy 20 years ago, and he has not diabetic. He was hypertensive. On examination, he was jaundiced, dehydrated. He had repeated vomiting with pulsatile mass. And nothing abnormal in his investigation, so we asked for CT angiogram, and CT came with a 9 centimeter celiac artery aneurysm and gastric outlet obstruction. Facts of the matter, celiac artery is very rare, so you wouldn't get a high experience from it, and 87% of celiac artery presented by rupture. This one was not ruptured, but was symptomatic. Operative repair of celiac artery aneurysm have 40%, and this patient have ejection fraction of 25%. Splenic retrograde perfusion is very essential for you to know, if you occlude this celiac artery aneurysm, what is the effect on the hepatic artery, splenic artery, and perfusion of the intestine. His SMA and IMA were patent. So we'll thought about the endo approach or open approach. So, patient developed obstructive jaundice and gastric outlet obstruction, and his clotting went deranged clotting. He was having INR which is going up and down. Well, guidelines 2020 actually in rare cases you don't get much help from. Didn't discuss actually what you do in this case. So this was out of help. So I thought, well, let us ask some of our friends as well. I've summarized, but I think Professor Wael Sha'ran have summarized this better than me, the guideline regarding celiac artery aneurysm. I asked Professor Hussein Rabia, and this is his answer. And when you ask for someone of your colleague, what do you think of this case? He will give you his opinion from his background. Professor Hussein Rabia is very good vascular surgeon, so he said nothing to be done because this is a high-risk patient and he can't see an endo option. I've asked Dieter Reitel. He is a fantastic surgeon from United States, and he said open surgery. I have seen him doing carotid in about 15 minutes, so he's very quick. And he said, well, you can do it quickly. Well, John Wolf from London, he's a famous surgeon. He told me, again, open surgery, and you can send me to London. I can do it on my private practice. Giorgio Biasi, which is very famous surgeon, he said hybrid technique. You can have an occlusion endovascular, and then you can have open surgical excision. A patient was not fit for open at all. Agyat Qotobi, which is a famous IR in Lebanon, he said endo, multiple option, multiple variety. Takayaki Oki, again, a vascular surgeon in USA, and in his hand he said, again, endo option is better. So what we have is problem number one, celiac artery aneurysm, obstructive jaundice, gastric outlet obstruction, chronic renal impairment, his kidney were going down, and he has a coagulopathy. So I've just reviewed literature, but I think you all have seen the high mortality of celiac artery aneurysm. Very important to do what is called occlusion test. So you occlude the orifice of the celiac artery aneurysm, and you see, will this affect his hepatic artery, splenic artery, or there is already the collateral between SMA and IMA through the arc of Ryeland, that nothing matter. And the other lessons that I learned, even if you have an occlusion of SMA, is not end of the problem. You can have recanalization, and it can re-rupture even after occlusion. So this is the occlusion test. You go by local anesthesia, transfemoral, and you put 8 millimeter balloon at celiac artery, and then you have a duplex scan. You see the hepatic artery, or you inject from SMA and you see flow in hepatic, but duplex is much better. You can do, again, duplex scan splenic artery and see if there is any flow. And you ask a patient, do you feel pain in your abdomen for intestinal ischemia? I've done that to this patient, and there was nothing. There was good hepatic flow, good splenic flow. The problem, how to fill a 9 centimeter celiac artery aneurysm with particles that doesn't travel fast. So you can't use molecule, you can't use onyx, you can't use glue. So what I have done is one of the tricks I've lost in the past, that the guide wire, you can cut it into 20 pieces. So I've got 5 guide wires, cut of them 20 pieces, and put it piece by piece through the channel of 0.035 channel, 10 pieces. Why I've selected guide wire? Number one, it is cheap. You can fill as much as you like. Secondly, it will not travel through any collateral from the celiac very easily, because in order to travel, you have. So you get this picture, which I don't think it will be repeated in imaging, with 5 cut guide wire in celiac artery aneurysm. Okay? At that day, I remember he told me pain is less, but you can see there is still flow in the celiac artery aneurysm. There is still flow. You haven't cured it, but at least this part, this is a CT angiogram second day. This part, at least, has been thrombosed. Okay? So after that, the occlusion test was positive. I've put the guide wires, I've cut it in. What happened? Aneurysm decreased pulsation, but this is subjective. And patient continued to deteriorate generally. He was not getting better, still vomiting, electrolyte imbalance. He had 7 units of fresh frozen plasma. Jaundice have little bit improved, and we were thinking about putting a stent in the duodenum for gastric outlet obstruction. Then he has sudden death on the 3rd day. Massive PE, diagnosed by CT scan. Massive pulmonary emboli. So This patient stayed with me for about 1 week, and he ended up by massive PE. So I will share with you the lesson I have learned from this case. Celiac artery aneurysm is rare but highly fatal condition. Both operative endovascular are available and they depend about your experience. There is no unified approach for treatment of celiac. Good assessment of collateral is essential to know what will happen, and there are so many tricks in this part. Final occlusion of celiac artery aneurysm is not the end of the story. You must follow up this patient, because I have seen multiple visceral artery aneurysm recanalize after occlusion and re-rupture. So this patient will stay with you as long as you need to. Thank you very much for this case.
Thank you, Dr. Omar Al-Farouk. Very nice presentation. And now we'll listen to Professor Maisa Abdul Wahab for Azhar University. She will give a lecture about a presentation about a case presentation, giant thrombosed hepatic artery aneurysm. Professor Maisa Abdul Wahab.
Welcome to all, and many thanks to Professor Mustafa Sliman and Egypt Vascular Club board and chairpersons. Giant thrombosed hepatic artery aneurysm. The splanchnic arterial aneurysms are quite rare, with an estimated incidence of 0.1 to 2% in the general population. Like all aneurysms, the natural evolution is to increase in size. The risk of rupture is highly variable from 20 to 80%, with mortality rates ranging from 9 to 40%. Hepatic artery aneurysm is the second most common type of splanchnic aneurysms following splenic artery aneurysm. Giant hepatic artery aneurysms more than 5 centimeters in diameter are extremely rare, and the true incidence is unknown. There are two types of pathology, pseudo-aneurysm and true aneurysm. The most reported causes of true type include atherosclerosis, fibromuscular dysplasia, Marfan syndrome, vasculitis, polyarteritis nodosa, systemic lupus. Less frequently, hepatic artery aneurysms has been associated with Takayasu arteritis. The treatment guidelines regarding hepatic artery aneurysms according to the Society of Vascular Surgery as follows. Patients with asymptomatic aneurysms more than 2 centimeters in diameter, rapidly growing more than 0.5 centimeters per year, symptomatic aneurysms regardless of size, pseudo-aneurysms, women of childbearing age should be treated. The treatment strategy should be based on clinical presentation, the anatomic location, wide variability of hepatic blood supply, associated risk factors, and the risk of intervention. This is the case. A 72-year-old man came to our vascular surgery department at Zahra University Hospital with a diagnosis of giant thrombosed hepatic artery aneurysm. Risk factors included diabetes, smoking, and hypertension. The story of the patient was started 5 years ago by complaining of continuous epigastric and right upper quadrant abdominal pain related to male. He had no history of abdominal trauma or surgery. Laboratory results were within normal ranges at that time. CT abdomen with contrast was done and revealed well-defined huge abdominal hepatic artery aneurysm more than 5 centimeters in diameter in all directions. Thrombosed wall, patent lumen, no leak or rupture, well-seen hepatic feeder, displacing the duodenum and the pancreas medially. Screening to all peripheral arterial system revealed mild atherosclerosis. Coronary angiogram was done to rule the out of Takayasu arteritis, which revealed normal coronary arteries. The patient refused any intervention and asked hepatological and gastroenterology consultation to take medical symptomatic treatment. The typical finding of giant hepatic artery aneurysm include epigastric or right upper quadrant pain, followed by gastrointestinal hemorrhage and obstructive jaundice. All of these symptoms, Kegel triad, are rarely occurred in the same patient. But in this patient, And after 5 years of medical treatment, he was complaining for persistent epigastric pain, a huge hard lump in the right upper quadrant and the right flank, with development of obstructive jaundice. CT abdomen with contrast was done again and revealed well-defined huge hepatic artery aneurysm, more than before in the diameters, thrombosed wall, patent lumen, leak in upper aspect with fine mural calcification. Displacing as before duodenum and the pancreas medially, right kidney and right colonic flexure inferiorly, compressing inferior vena cava posteriorly and portal vein to left side. Common bile duct with dilatation of intrahepatic biliary tree in the liver. This image demonstrates the progressive enlargement in the size from year of 2015 to year of 2020. Sorry. ARCB couldn't be done due to complete obstruction of common bile duct and no flow of biles to the duodenum. So, percutaneous transhepatic cholangiogram and percutaneous transhepatic drainage was done as a fast procedure to drain the biles and decrease the jaundice. In this case, patient prepared for aneurysmal exclusion. After midline incision, we are found a huge hepatic artery aneurysm without any adhesion in the arterial surface by posteriorly to the posterior structure is severe adhesive. But we are lucky to find the good stump of common hepatic artery after its branching from celiac artery and proximal control were done. This is the pulsatile celiac artery, and this is a good stump of common hepatic artery, and this is a stump liver. This picture demonstrates after that, opening of the superior surface of the huge abdominal, the huge common hepatic artery aneurysm to debulking of the thrombus and facilitate the dissection of the posterior surface. This is the mass, but after removal of the mass, this is the injury occurred in the portal vein due to severely adhesive between the posterior wall and the wall of the posterior vein, and by 4-0-proline portal vein repaired continuous suture. The patient was vitally stable post-operative and discharged well conditioned after 10 days. 3 weeks later, hepatojejunostomy Roux-en-Y was done because the patient asked intervention after severe infection was occurred at the site of PTD. Then the patient died from septicemia after 1 week later. Thank you.
I think we will have a lot of discussion in this case. The second presentation will be by Professor Mahmoud Ismail. He will talk about open surgery. Mahmoud Ismail, open surgery of a hepatic artery aneurysm after unsuccessful stent-graft repair.
open surgery of a hepatic artery aneurysm after unsuccessful stent-graft repair. Case report. Hepatic artery aneurysms are extremely rare. It represents 0.01%. It is about 20% of visceral artery aneurysms, and it is the second most common cause after splenic artery aneurysms. Most of them are extrahepatic and solitary. Atherosclerosis is the main etiology and represents about 30%. Other etiologies are vasculitis, fibromuscular dysplasia, trauma, and infections. Most of them are asymptomatic and discovered accidentally during imaging, but the common symptoms are epigastric pain, hemophilia, obstructive jaundice, which is called Twinks symptoms. Rupture and this high mortality reaches up to 70%. The indication of repair are symptomatic, all symptomatic aneurysms or asymptomatic more than 2 centimeters. According to guidelines, recent guidelines published 2020, endovascular first approach are recommended for all types of hepatic artery aneurysms if anatomically suitable to maintain liver circulation. Also, both open and endovascular options for extrahepatic aneurysms. The main aim of the treatment is to guarantee adequate blood supply to the liver. This blood supply is due through the common the main arterial blood supply of the liver through common hepatic and proper hepatic artery, or through collaterals, which is mainly through gastroduodenal artery if the main arterial supply is interrupted. Why we should maintain liver blood supply? Because although hepatic artery supply only 30% of blood as a volume, it represents about 60% of oxygenated blood, which is very important for the liver function. The options, both endovascular and open surgery. If you want to sacrifice adequate collaterals, we use endovascular coil embolization or excision as open surgery, excise and ligation. If you preserve, you would do covered stent as endovascular options or bypass or interposition graft. Partial hepatectomy was used as conjugative was either open or endovascular. Our case is male patient, 61 years old, hypertensive, represented by a recurrent right upper quadrant abdominal pain with no previous intervention, hepatobiliary intervention. The patient has a past history of endovascular intervention and stenting outside our hospital by intervention radiology since 3 months. CT angio, as we see, revealed large aneurysms about 5.6 by 5.2 centimeter from the common hepatic and hepatic artery proper. No other visceral aneurysms. Is included 2 covered stents. The GDA, gastroduodenal artery, was involved inside the aneurysm. And with a small stump, as we see, small stump of patent proper hepatic artery distal to the stent. As we see at the origin, there is the stent is occluded and with type 1 endoleak with patent distal hepatic artery. We do first, according to guidelines, diagnostic angiography, try to find an options for endovascular. We are aimed to recanalize the stent and put relining proximal, another covered stent. But we failed due to occlusion, hard occlusion of the proximal part of the stent, and the catheter is always inside the aneurysm, not inside the stent. We are now going for surgery. We were both team of vascular and hepatobiliary surgeons under general anesthesia, bilateral subcostal incisions, proximal control followed by distal hepatic artery control, aneurysm excision. Then we assess the liver if we need to do bypass or not. First, we access the celiac artery for proximal control. Then distal control was done, then excision of the aneurysm. After excision, this is clamps are put in the proximal and distal part, and this is aneurysm already excised. We do liver assessment intraoperative through visual inspection with the change of the color of the liver, and also we do intraoperative ultrasound to assess if there is any blood supply to liver. But there was no any blood supply in the liver, so we must revascularize. The option of surgical revascularizations using saphenous vein, which is too small in this case, synthetic graft, which was our second option because of fear of thrombotic and infectious complications, cadaveric vein graft, which is not available, and the splenic artery, which was our graft. We dissected the splenic artery about 5 to 6 centimeters and ligated the proximal end and turned it to anastomosed end to end with the hepatic artery proper. This is the final splenic artery anastomosed to the distal hepatic artery proper at the hepatic hilum. Post-operative, the patient was transferred to the ICU for monitoring. He made a good recovery with no immediate or early complications. Plasma levels of conventional liver enzymes and alpha-glutathione transferase to assess if there is any liver ischemia. Ultrasound also show regular flow through the right and left hepatic arteries. Also the color of the liver by sonar was good. We do follow up after 1 month with contrast enhanced CT. There is a patent flow through both hepatic right and left hepatic arteries and the patent graft. Take home message: open surgical treatment of hepatic artery aneurysm is technically feasible, and the endovascular first approach is often chosen as a safer and less invasive alternative. Surgery is the most appropriate option in cases where the anatomical characteristics of the aneurysm prelude against endovascular repair, or as a bail-out technique after unsuccessful stent graft. Long-term follow-up is required for better assessment of patency. Thank you.
Thanks, Dr. Mahmoud. Our next speaker will be Professor Muhammad Ismail from Ain Shams University, who will talk about endovascular repair of renal artery aneurysm.
Professors, dear colleagues, as a fruitful session for visceral aneurysm, we today talk about renal artery aneurysm. It's a rare but fatal, mostly accidentally discovered, more in the females, and mostly the pathology was for fibromuscular dysplasia. A lot of patient asymptomatic, the symptoms presented is hypertension, hematuria, and loin pain. When and why we have to interfere? We have to interfere because it's liable to rupture, it's fatal. We need to interfere if it's more than 2 centimeters, if symptomatic, and female will be pregnant or childbearing period. How to intervene? We have a lot of options, like we are vascular surgeons and endovascular interventionists. Surgical, like aortorenal bypass, patch angioplasty, and interposition graft. Endovascular, we can use onyx injection, coils with stent flow diversion, multi-layer stents, or covered stent. And maybe nephrectomy if huge aneurysm in distal renal artery. Our case today is a female patient, 44 years, medically free, history of varicose vein surgery, suffered from fibroid. When she have a routine ultrasound follow-up for the pain in abdomen and left loin and for fibroid, revealing a mass in left loin, CT angio revealed renal artery aneurysm, like we see. It was a big renal artery aneurysm. This is the preoperative or the intraoperative imaging, like we see after cannulation. Our technique was either transbrachial or femoral approach. In this case, we found this a weak radial pulse. We go through femoral approach with long sheaths and hydrophilic wire and Judkin catheter. We succeed to cannulate the renal artery. Then we change the wire with a stiff wire after cannulation and put a balloon-mounted covered stent Bentley 5 by 59 millimeter. This was post-operative imaging. Like we see, the stent with no endoleak or the normal filling of the duplex was done and shows the successful stented left renal artery and completely thrombosed aneurysmal sac of left renal hilum was measuring for 3.6 by 2.6 centimeter. Thank you.
Thanks, Professor Muhammad Ismail. We still have one presentation in this session. It will be online from Greece. Professor Antonio Polidrou, he will talk about renal artery aneurysm. Please. Hello, Professor. Are you hear us? Could you hear us?
Slides on.
Hello, Professor, we hear you well. Could you hear us?
Yes,
okay,
I hear you very well.
Yes, you can start your presentation and share your slides.
Can you see my slides?
Yes.
Hello?
Yes.
Can you see my slides?
Yes,
My first
yes,
slide?
yes.
Okay. So, Mr. Chairman, dear colleagues, I take the opportunity to thank the Congress President, Professor Mustafa Soliman, and Dr. Mohammed Omar El Farouk for their invitation to present an interesting case to this conference. I have nothing to disclosure. A 36-year-old hypertensive patient was referred to us having a bilateral fusiform renal aneurysm. The patient had normal right renal function and impaired of the left renal. The left aneurysm was intraparenchymal, 6.2 centimeter of diameter, and the right aneurysm was extraparenchymal, 3.2 in diameter, with collaterals coming through the aneurysm, including the artery for the upper renal lobe. The question arised was which path to follow for the left renal aneurysm for treatment and which for the right. For the left renal aneurysm, the discussion was limited whether it will take place partial nephrectomy, total nephrectomy, or if coils could be placed in the aneurysm interventionally. For the right renal aneurysm, we discussed the possibility of aneurysm excision and renal artery repair, the arteriorenal bypass, the cover stent placement, and also the clois placement in the aneurysm. For the left renal aneurysm, the experts decided on a renal transplantation. For the right renal aneurysm with normal function, the experts decided a multi-layer stent placement. This is the result. As you can see for this slide, we have the renal transplantation, and later we put a multi-layer stent on the right renal. Why multi-layer stent? The right renal aneurysm was extra-renal with side branches. According to our experimental work, first on animals and later on humans, the blood flow laminated along the aneurysmal wall without branch, as on the scheme. Then the blood flow directed where there is a branch into the branch, resulting to a progressive collapse of the aneurysm wall, again as shown on the scheme. You can see clearly from our experimental work also the formation of thrombus allowed, yes, the formation of thrombus at the left side of the aneurysm and the side branch wide open to the other side. Also, the struts at the origin of the stent remaining wide open. Of course, vascular treatment of the aneurysm, the harmonious cooperation of the various specialties is very important. And as Charles Totter said on 1983, as physicians, we are all agreed upon the need to treat vascular obstructions in our patients, but we hold a variety of different opinions as to how and by whom this is best done. Thank you very much for your attention.
Now we will start the discussion. The questions for the first presentation, Professor Gamal Niazi. Okay. For the second presentation, Professor Wael Sha'lan. Okay, no question. For the third presentation, Professor Ahmed Nasif. Yes.
Professor Ahmed Nasif, thank you for your presentation. My question is, what is the possibility of rupture of the aneurysm? So it's a common question asked by our patient. What is the possibility of rupture? If it's an aneurysm that was discovered accidentally and it's have a size that exceeds the limit of intervention, so the patient asks, will it rupture? What is the percentage of rupture? What for conservative treatment?
Thank you. I'm not sure I know the answer to the question, but I'll try. Look, the guidelines are just guidelines, aren't they? And guidelines do not always provide the answers, but they're all what we have. So what guidelines are telling us, for an aneurysm in the splenic circulation, splenic artery aneurysm, or a renal artery aneurysm, you have a 3% risk of rupture. يعني لو عندك 100 aneurysm, renal artery aneurysm, 3 منهم هيربتشروا كل سنة. Some aneurysms, however, you would have to treat irrespective of the size لأنهم in an ill-reputed vascular bed. يعني لو عندك gastroduodenal artery aneurysm or a pancreatic duodenal artery aneurysm, you better treat them if you can. Treating an aneurysm is a balance of risk. يعني whether to treat something or not to treat something depend on how, if I understood you correctly, as to what are the chances of death should they rupture. Well, literature and they tell us that there is a 50% risk of death.
But I wanted to know if it is going to rupture or not.
Oh,
so I don't want to proceed with the talk of the patient. The patient refused the operation, but what wanted to know what is the odds of the rupture of the aneurysm. So it's more important to clarify with the patient what is the percentage or the possibility of rupture.
Yeah.
So he refused the operation, but what is the possibility if he refused?
Well, these are the risks that I've just mentioned. And it's a skill that you gain with time, how to communicate with patients and to pass on the message. It's something that you would develop. It's very difficult because you remember that aneurysm treatment is prophylactic treatment. That patient feels nothing. You've discovered an aneurysm and you are telling them, oh, if I don't operate on you, you're going to die. Oh, it's a skill, what to pass and when and how and so on.
So, but with the child-bearing woman, it's a must to operate. That's a higher percent of mortality of the fetus and the mother as well.
Yeah. So
thank you.
Yeah.
Professor Muhammad Omar Farouk.
Okay, thank you very much, Professor Ahmed. I enjoyed your talk very much, and I was impressed by the open surgical experience to visceral aneurysm. My question is, if you have a patient with Ehlers-Danlos syndrome, and you have a visceral artery aneurysm, what do you do to them? Because I have a bad experience.
Difficult, Dr. Mohammed. Well, I haven't had a visceral artery aneurysm in somebody with connective tissue disorder. Neither Ehlers-Danlos nor Marfan. Most of these were degenerative aneurysms, the ones that I've treated. But I suppose in terms of like other aneurysms, you would tend to try the open surgical approach first, should the benefit outweigh the risk, and good luck with the anastomosis, because and recurrence and anastomotic aneurysms and all that. But yes, no, I agree, difficult.
Thanks. Next speaker, Professor Amr Abdelrahim. Any question? Next speaker, Professor Muhammad Omar Al-Farouq, Celiac artery aneurysm. Any questions? Yes.
Thank you, Dr. Muhammad Omar, for your presentation. I have two questions. The first question, what kind of guide wire used? The second question, the patient has two complications. The first is compression to common bile duct, cause obstructive jaundice and gastric outlet obstruction. The patient has coagulopathy. Coagulopathy has two possible etiology. First, liver impairment from obstructive jaundice, and second, consumption coagulopathy from the thrombus inside the aneurysm. The coiling of aneurysm will cause thrombosis, will not solve the problem of compression. And the new thrombosis, I think it will augment the problem of consumption coagulopathy.
Thank you very much for your question. The first question is the type of guide wire. It was PTFE guide wire. We can easily cut it better than Terumo or Nitrix. Regarding the second question, if you put a coil, if you have a 9 centimeter aneurysm and you put peripheral coil, you can see it flying around. It wouldn't stay. So if you do packing, there is a calculation. There is an equation. We say this aneurysm need how much peripheral. They use this equation in the neurosurgery. I've done this equation for him. I think it was 1,000 peripheral coil. So you see, coil was not an option. Surgery, I agree with you. He has common bile duct obstruction, and we asked the GIT team to come, and he said he's generally not well. You need to improve his general condition before we come in. We said same to the gastric outlet obstruction, to put a duodenal stent or do some sort of relief obstruction of putting endoscopic lagage or endoscopic PEG or PEG tubes. But again, they refused because he had bad general condition. Regarding coagulopathy, yes, I agree with you, has coagulopathy. Whenever you put a foreign body inside an aneurysm, you trigger thrombosis, but it's a local issue, not a systemic issue. And the beauty of using guide wire, number one, it will not fly around. So you cannot use PVA molecule, you cannot use onyx, and if you use a peripheral coil, it will fly around and wouldn't know it will go where. Secondly, it is cost is very cheap. Thirdly, you can do it on multi-stage. So you can do stage 1, stage 2. I have filled around maybe 40% of the aneurysm. I didn't want to fill all of it in one go, to see how it goes. But I agree with all your points.
Professor Ahmed Nasif.
Thank you. Dr. Muhammad answered the question already. Thank you.
For the next presentation, Professor Maisa Abdel Wahab. Any questions?
My question to Professor Maisa. During the section of the posterior wall of the aneurysm, when it is adherent, why not to leave it, the posterior part? You insist to dissect the posterior part.
Sorry, again?
Why you dissect the posterior part of the sac while it is adherent to the underlying tissues? You can remove part of the sac.
During dissection of the whole sac, it is easily dissected, except in the posterior. CT angiogram before, with contrast, revealed severe compression, common bile duct, portal vein, IVC, and intraocular bile duct dilatation. When visible in operation, no completely destructed common bile duct. And severely adhesion and severely adhesive posterior to all structure, but not I can leave it. Not I can leave it. Portal vein ooze blood and bleeding during the operation. Must remove the whole structure and the whole wall and repair the portal vein.
Okay. Dr. Omar Farouk?
Yes, I agree with your point. It's a very, very nice point. You can leave part of the celiac artery aneurysm as long as you have tackled the aneurysm. It is not pressurized. Even when you do, same question for celiac artery, when you do an occlusion celiac artery, the tension will go down. Immediately, it will not become a compression. So if you leave a part of the wall, it's like any tissues, you don't need to do dissection. Well, you do dissection to stop bleeding, stop any part where you suspect it will have future compression or recanalization. But if you left already remove, let us say 70% of the sac, I will happily leaving the 30%. My question to you is, I was hoping the case will go well. It was a nice video, nice case, difficult, late, but you said after 1 week, sepsis die.
No. After 10 days, patient improved and discharged. 3 weeks later, infection occurred at BTT drainage. Then asked to hepatojejunostomy Roux-en-Y. And after hepatojejunostomy by 1 week, patient was died. After 40 days from the operation of Roux. This is a good...
Okay, thank you very much.
Professor Ahmed Nasif, want to ask?
Dr. Mesa, thank you. Well, thank you for sharing this with us. Could you have not just embolized it preoperatively to
decrease the size?
Yeah, and make your life easier dissecting?
Already embolized for what? Embolization needs closure of the sac.
Well, just
but the diagnosis reveal.
Just the origin immediately preoperatively.
Thrombosed sac and progressive enlargement in 5 years, triple the size and double the size in some direction, must be interfere and remove the compression on the other structures. And also, I need, we try to found the posterior structure. This is the idea for removing all the sac and remove all the posterior structures.
Professor Yasser Misbah, last question. Yes.
Thank you.
Thank you, Dr. Mesa, for your brief heart, but I have 2 comments. First, you must don't be insisted that don't believe the patient when you saw him for the first time to go for medical advice. I must be firm with the patient. In some risky cases, this is the only solution. You must, we must intervene. I must help him to take the decision. This is the first. Second, when you open the anterior wall of the aneurysm, I suspect that you will evacuate the thrombus and control the defect from inside, or like get the vessel from inside, and you can partially excise the sac, leaving the posterior wall intact. Thank you.
Thanks. Dr. Yasser is talking about, you show us a picture of this patient for the 2015. And then with huge aneurysm, and then he operated at 2020. He is talking about this 5-year lapse period between the diagnosis and the interference. The next speaker, Professor Mahmoud Ismail, open surgery of a hepatic artery aneurysm after unsuccessful stent-graft repair. Any question? The next, Professor Muhammad Ismail, endovascular repair of renal artery aneurysm. Any questions? Okay. Professor Antonio, are you with us? Professor Antonio, Professor Muhammad Omar Al-Farouq wanted to ask you. Yes.
Professor Antonio, I did enjoy your talk extremely, tremendously. Thank you very much for sharing this case with us. My question is, the renal artery always have multiple branches. Why multi-layer stenting exclude the aneurysm but does not exclude branches? How this hemodynamically happen? You did show us your animal experimentation, which is fascinating. Can you explain that to me? Thank you.
Runoff of the water goes straight if you put a plate with holes. So if you put a plate with holes on the top of water, you see that the water goes straight. This laminates the water straight. It's the same in the vessel. If you put a stent with multi-layer, then the blood flow is strained, is laminated. So it goes through the collateral and the aneurysm wall shrinks. So within 24 hours, we see the disappear of the aneurysm wall, and the blood flow laminates on the collaterals. So this is the mechanism.
Thanks a lot for you all, and we will shift now to the next session about carotid artery aneurysm. Thanks, dear Chairman.
Hello, Professor Polidoro with us? Professor Polidoro?
Yes. Hi.
Are you still with us?
Yes, I am with you.
I'm Dr. Suleiman.
Congratulations, welcome.
Thank you. I just want to thank you among all these gathering, because you had done a very big effort with us arranging this meeting and inviting your colleagues in Greece and Europe. And I want to thank you, and I know how you are keen to come to Egypt, but the circumstances prevented you from coming, and you shared us online. So I want to appreciate my thanks to you.
Thank you, Professor Soliman. It's a great honor for me to be with you always. Thank you too.
Thank you. Thank you.
And congratulations for the very good Congress.
We need to start the next session. دكتور محمد اسماعيل. دكتور محمد اسماعيل راح فين؟ دكتور وائل شعلان. please to the stage. Dr. Muhammad Ismail. We'll start now the session of the carotid artery aneurysms. But excuse me, Dr. Ayman, before we start, I want to announce 2 points. Firstly, tomorrow we will have the sessions which was announced in the program about Ask the Experts. For tomorrow, we'll start from 1 p.m. after the break, and we have 5 sessions for asking the experts. We have so far 4 topics fulfilled: diabetic foot problems, aortic aneurysm sizing, carotid artery aneurysms, and lymphedema. And you will face big experts in each item of these. So if you please, whoever interested to attend this for 30 minutes for roundtable discussion with the expert, just go to the registration desk and put your name in whichever session of these. We're still missing the 5th session, and I will tell you about it. But at least we have 4 sessions so far about, again, diabetic foot problems, aortic sizing, carotid artery aneurysm, and lymphedema. Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you very much. Thank you, Dr. Mustafa, for letting me invite for invitation. We'll start the session on carotid artery aneurysms, and I'm glad to invite Dr. Sameh Zarat, from Military Academy, for his talk, carotid artery aneurysms. Dr. Sameh?
Yes, Dr. Ayman.
Oh, sorry.
I'm here. Okay. First, I want to thank Dr. Mustafa for his invitation. So, my talk today about carotid artery aneurysm extracranial. The classic definition of aneurysm is an increase in more than 50% in the diameter of the carotid bulb, or 200% in diameter of internal carotid artery. The carotid artery aneurysm is rare and represents only 0.4 to 4% of all peripheral artery aneurysm. Most tertiary center treat few cases per year. Unlike other aneurysms, carotid aneurysm are not associated with aneurysm in other anatomical location. Bilateral carotid artery aneurysm occur in 15% of cases. In 95%, it affects only carotid bulb and internal carotid artery. Carotid artery aneurysm is true aneurysm or dissecting aneurysm and false aneurysm. There is morphological classification of extracranial carotid aneurysm is type 1 aneurysm of the distal part of the internal carotid artery, type 2 aneurysm of the internal carotid artery, type 3 aneurysm of the carotid bifurcation, and type 4 is aneurysm of the carotid artery and the internal carotid artery, and type 5 is aneurysm of carotid artery itself, common carotid artery. It causes atherosclerosis, previous trauma, previous peritonsillar infection, spontaneous dissection, radiation, and others. Most common presentation of carotid artery aneurysm is pulsating neck mass, and which may cause compression symptoms like dysphagia, cranial nerve symptoms, tinnitus, bruit, hoarseness of voice, tracheal compression, and also another type of presentation is thromboembolic events such as TIAs in 67%, amaurosis Pujax, non-hemispheric symptoms, blurring of vision, or equilibrium disturbance. Diagnosis, first we'll do duplex ultrasound to put us about the diagnosis, then we do CT angiography and MRE. Management is treatment of carotid artery aneurysm. Once diagnosed, you should operate. Don't wait. There is no conservative treatment for carotid artery aneurysm because of its serious and its complication is fatal. In 1997, the first line of treatment is ligation, but now current operative strategy range from excision of the carotid artery aneurysm with reconstruction of the internal carotid artery, either by end-to-end anastomosis or autogenous vein graft, synthetic graft reconstruction, or transposition of external carotid artery to internal carotid artery. Combined major stroke and mortality rate for this procedure are generally accepted, from 3 to 20%. Endovascular reconstruction is repair with covered stent graft if the anatomy is favorable, with minimal tortuosity and appropriate proximal and distal landing zone. Endovascular repair is more often chosen for patients with pseudoaneurysm due to trauma or carotid dissection. Endovascular repair is associated with fewer cranial nerve injury and shorter recovery time. My first case, this patient is 75 years old patient, referred from one of our colleagues with pulsating mass in the neck. CT angio shows that there is aneurysm in the common carotid artery. So I prepare the patient for general anesthesia and classic exploration like carotid endarterectomy. The exploration of the common carotid artery, external carotid artery, and internal carotid artery. The aneurysm was in the common carotid artery itself. Opening of the aneurysm, it was true aneurysm, taken all layer of the carotid artery with removal of the mural thrombus, and the diameter of the artery was normal, huge, so direct repair with Prolene 650 is done. And the patient was smooth with no any complication, neurological or surgical. Second case, this patient comes to the casualty with abdominal pain for investigation, and from history, the patient found is not diabetic, but hypertensive, and there is previous history of 2 attacks of stroke, and the previous history of COVID 6 months ago. A routine investigation is carotid duplex for the stroke, showed false aneurysm in the right common carotid artery and internal carotid artery, measuring about 3.1 centimeter with mural thrombus. CD angiography is done and confirms the diagnosis. It was in the internal and common carotid artery and 2.5 centimeters. The patient prepared for surgery and exploration of the common carotid artery aneurysm, internal carotid artery, and external carotid artery with hypoglossal nerve is high. So we try to mobilization of the posterior pili of the gastric to explore the proximal part of the artery of the internal carotid artery. Opening of the aneurysm with removal of the mural thrombus, and this is the aneurysm, and the mouth of the internal carotid artery, it was in this side. This is the mouth of the internal carotid artery. So it was false aneurysm. So I bought the carotid shunt to maintain cerebral perfusion during surgery. The posterior wall of the aneurysm was unhealthy. So complete excision of the aneurysm is done with interposition saphenous vein graft between the common carotid artery and internal carotid artery. Is done. And the patient was smooth with no complications and go home. So our conclusion is extracranial carotid artery aneurysm is an uncommon but serious condition. The morbidity and the mortality of extracranial carotid artery aneurysm are assumed to be high when untreated. So once diagnosed, you should operate. Extracranial carotid artery aneurysm treatment presents a challenge because of accessibility of the carotid artery and the lack of evidence-based guideline. Resection of the aneurysm with restoration of blood flow is still considered the gold standard with acceptable procedural risk and a low risk of late stroke. Less invasive endovascular technique need to be further evaluated. At present, there is no long-term follow-up data to advise this novel technique in the management of extracranial carotid artery. Thank you.
Thank you, Dr. Sam. Thank you very much. Next speaker, Dr. Ali.
Next speaker, Dr. Professor Mus'ab Suleiman, covered stent-graft for treatment of carotid artery aneurysm.
Good afternoon. One of the cases that we need to cover is
the carotid artery aneurysm with a kind of a covered stent. Yes. So when it comes to the atherosclerosis, we will find that atherosclerosis is responsible for the development of strokes in 10 to 15% of the cases, and every attention should be made toward prevention of the stroke, either through the best medical therapy, or we can choose the CEA, the carotid endarterectomy, in the aim of reduction of ischemic stroke in these patients in 10 to 15% of the cases, only when they are symptomatizing, and also in patients with failed best medical therapy. Then it is the era of the CAS, which is widely accepted as an alternative to CEA, and the CAS is being used in symptomatizing patients with high grade of stenosis and deemed to high medical risk to undergo open surgery, or when there is some anatomical limitations, as in inaccessible lesions, highly situated restenosis, or in cases of neck radiation. With the development of technology, we had either the bare metal stents, covered stents, tapered stents, or free cell stents, and the self-expanding stents seems to be the cornerstone for every kind of protection because of the chronic compressive forces applied in the stenosis, in addition to the discrepancy in the size of the internal carotid compared to the common carotid and the mobile nature. So in the list of potentials for uses of the covered stent in the carotid, it is the same as every lesion somewhere else, like in the cases of trauma, dissection, true aneurysms, false aneurysms, and in cases of stent restenosis. Nonetheless, there is no commercially available approved covered stent to be used in the carotid area. In this case, we had this 65 years old fox with diabetes, smoking, and suffering from ischemic heart disease, and was prepared for cappage. And during the preparation, the routine Doppler in the carotid have shown this kind of fibrofatty eccentric lesion affecting 70% of the internal carotid with the proximal part of the internal carotid artery, and post-stenotic dilatation in addition to an attenuated segment of the internal carotid running far towards the high up in the neck. So the same findings were proved by CTA, and a basal CT of the brain didn't show any acute or unestablished former cerebral infarction. So we ran through the option of using the stent pathway, the CAS pathway, instead of the CEA because of the comorbidity of the patient needing a cappage and in need for general anesthesia. So the CAS was the best option, and we started preparing the patient with a clopidogrel in a loading dose of 300 milligram. Under local anesthesia, we ran the guide wire towards the carotid, and we negotiated in the area. Was that easy passing through the area of stenosis, and we have reached to the base of the skull, crossing the attenuated segment distally. And at that time, we had to run a diagnostic angiography to confirm the left common carotid and the internal carotid stenosis inconsistent with the ultrasound and CTA. And we deployed the kind of covered stent from the attenuated segment distally to the proximal common carotid, and we used the Advanta V12 in a size of 6 by 60 millimeter to cover the area of the stenosis, post-stenotic dilatation isolation, and the attenuated distal segment. And at this level, we have the concern because of the discrepancy in the size of the stent. So we intentionally dilated the stent distally at 4 millimeter, and at the site of the aneurysm at 5 millimeter, and proximally at the common carotid at 7 millimeters. So this dilatation was intentional by the balloon from different sites because we don't have the tapered stents, although the Covera stent, which belongs to BARD, is a tapered stent, but it is not available in that size. It's only 6 distally, so you cannot reduce the size at this level. So we had this picture, good flow distally. We had a CT brain that didn't show any kind of embolization in the peripheral territory, and the patient went uneventful for the first month, and CTA 2 months later showed the same. So what we had in plan to isolate all the particles in the area of the stenosis and the post-stenotic dilatation, because this is a major part in embolization in the peri-procedure period, and also 1 month later, these particles can go through the struts in the bare metal stent, and it is a major impact for the development of peri-procedure cerebral stroke. It is all about the fragments that goes in between the struts, causing distal embolization. So the idea was to isolate all and press it against the vessel wall, preventing distal embolization. So the main advantage in this covered stent was its simplicity and the cost saving, because you don't use any filters as a protection device, and strokes have been reported in 24 to 30 days post-procedure just because of the embolization of the particles in between the struts, and it has been reported by Shinozaki that by IVUS there is an incidence of struts in between the struts embolization and the bulging of the material in 7.8%. So to take our home message, CAS with covered stent offers a fast and single-step procedure, despite it is not popularly wised because there is no such dedicated covered stent for use in the carotid. Thank you very much.
Thank you, Dr. Mosad B. Dr. Ahmed, can we?
Actually, we need these tips and tricks from Dr. Walid Khriba, Professor أزهر.
طبعا هو يعني مش عارف هقول ايه بعد الدكتور مسعد والدكتور سامح، هم خلصوا الكاروتيد تقريبا يعني، فالدكتور مصطفى ظلمني يعني بوجودي بعدهم.
انت هتقول تيبس وتريكس احنا محتاجينها برضه.
بسم الله الرحمن الرحيم. Surgical treatment of extracranial internal carotid artery aneurysm. Extracranial carotid artery aneurysm is an uncommon but important clinical entity. Cooper is the first one who detect and treat the internal carotid artery aneurysm by ligation. Winslow is the first one did case serious study about carotid aneurysm, and he reported in his study that mortality rate of internal carotid artery aneurysm without treatment is about 71%, and with the ligation about 30%. And so treatment of internal carotid aneurysm is very important, as Dr. Samah say, once you diagnosed, must be treated. I will pass fastly to tips and tricks. Tips and tricks in diagnosis. We should be aware about atypical presentation and expect internal carotid aneurysm in with patient with atypical presentation as compression manifestation, and don't exclude internal carotid aneurysm as patient with dysphagia, Horner syndrome, hoarseness of voice. Duplex study is non-invasive technique, can confirm that patient is presented by internal carotid aneurysm or not. About investigation, Duplex study is non-invasive and the gold standard to diagnose internal carotid aneurysm. Arteriography is a pre-operative investigation, and we must be determine the level of aneurysm to be sure that the internal carotid artery aneurysm is anatomically accessible to be corrected surgically. Treatment, the primary objective is to prevent the permanent neurological deficit, choice of therapy, endovascular treatment or surgical treatment, and surgical treatment must be done in young patients without comorbidities, good pulmonary function, cardiac function, to prevent metal behind. But in high-risk group, anatomically accessible lesion, maybe endovascular treatment is indicated and recommended. Reconstruction for internal carotid artery aneurysm, ligation is done only in life-threatening condition and very, very limited situation. Anesthesia can done internal carotid artery aneurysm treatment under general anesthesia, regional anesthesia, and local anesthesia. If we routine do internal carotid artery aneurysm treatment under general anesthesia, balloon occlusion must be used to monitor balloon occlusion must be used to maintain cerebral perfusion all the time of the operation, and must be on shelf. Before surgery, we should maintain and mapping by duplex study anterior jugular vein, external jugular vein, and as may be used as interposition graft. Internal carotid stump pressure must be measured to evaluate the patient will tolerate clamping of internal carotid artery or not. Some technical problems may occur, and so you can depend on stump pressure if it's 60 or more, and do clamping at ease and complete your procedure. But balloon occlusion shunt must be on shelf, as in this case technical problem occur, and you can do the operation at ease with balloon occlusion shunt. And be sure that all the time of operation we maintain cerebral perfusion. This is balloon occlusion. Excision of the internal carotid artery aneurysm and end-to-end anastomosis. No post-operative complication. Nasothoracic intubation may be used in a high level if you want to extend your incision to mastoid and styloid process to access the proximal part, and in this case you must be use balloon occlusion as a routine. Antithrombotic therapy, up till now, no evidence base that is recommended post-operatively, but most of literature recommend to use it 2 to 12 weeks. Statin may be used in the case of internal carotid aneurysm post-operatively if the cause of internal carotid aneurysm degenerative atherosclerotic disease. Antibiotic may be used if the cause of internal carotid aneurysm is infection. Open or surgical repair. Open repair is recommended for young age. No pulmonary function disturbance, cardiac function disturbance, fit for surgery, no contraindication for surgery, and accessible lesion, anatomically accessible, and so surgical repair or open surgical repair is recommended. Endovascular repair is indicated in high-risk group or anatomically accessible lesions. Tips and tricks, and in conclusion, in diagnosis, we should aware by atypical presentation and suspect it and evaluate the patient with multidisciplinary team, neurologist or GIT, and do duplex to confirm that the patient is presented by internal carotid artery aneurysm or not. Proper decision making and select the suitable procedure for the patient according to the anatomy and general condition of the patient. Cerebral protection should be maintained all the time of operation, start from 0 day once the patient is diagnosed, pre-operative till the end of recovery. Cerebral protection from the start, everything causing hypoxia, causing hypoglycemia must be monitored. Hemodynamics of the patient, intraoperative by 1 minute. Intraoperative monitoring if the patient under general anesthesia, tube occlusion is satisfactory to maintain perfusion, and monitor hemodynamics of the patient, cardiac and pulmonary function for cerebral protection. If patient under local anesthesia, you can monitor the patient by some tests can be done, and you notice everything it changes in the patient if done under local anesthesia. And lastly, surgical repair in recommended patient and fit patient is advised. No metal behind. Long-term result is favorable for endovascular treatment, but to be cautious, to be observe it for patient indicated old patient, inaccessible anatomical lesion, high risk group. Thank you.
Thank you, Dr. Walid, for these tips and tricks. Our next speaker will be Professor Hassan Lotfi from Alexandria. He will be presenting 1-year results of a stent-graft repair of carotid artery pseudo-aneurysm in Behçet's disease.
Bismillahirrahmanirrahim. Dear Mr. Chairman, my dear professors and friends, good evening. First of all, I want to thank Dr. Mustafa Sliman and the all organizing committee for this international conference, and I hope you all the best of luck. Today, we are going to discuss an endovascular treatment of somewhat rare condition, which is a pseudo-aneurysm of carotid artery affecting patient with Behçet disease. This is my disclosures, and Behçet disease, as we know, it is a multi-system disease of unknown etiology. It is named after Turkish dermatologist Hulusi Bahçet, and although it is a rare condition, but it is more common in Middle East and Far East than other parts of the world, with prevalence of 13 to 20 cases per 100,000 population. It is manifested by recurrent ulcerations, eye manifestations, skin lesions, and somewhat it involves vascular territory. And the arterial involvement in Behçet disease is not that common. It affects about 2 to 6% of all the cases. And the baseline of these lesions are vasculitis. Vascular complications ranged from either superficial thrombophlebitis or DVT up to you may have some sort of acute ischemia, arterial thrombosis, or aneurysm. And aneurysm affecting different territories, and from literatures, from different literatures, the incidence of affection of vascular territories are varied, but they are consistent that the carotid affection is the rarest one to be affected. The pathology is vasculitis, so if you have a patient with carotid aneurysm in a patient with Behçet, it is important to treat this patient in order to prevent rupture and that may cause to the patient. And surgical treatment is the cornerstone of this treatment, but it carries its drawbacks or complications of suture line aneurysm or affection of the artery with thrombosis. Our study is a retrospective study. All the patient fulfilling the international study criteria group to diagnose patient disease, and all patients are treated with stent-graft exclusion of the aneurysm, and all of them did not have any previous surgical intervention. The patient, first of all, before doing any interventions, they were exposed to a rheumatologist to control the active state of the disease for 1 or 2 weeks before intervention with corticosteroid or immunomodulation drugs. And after the procedure, we did a duplex ultrasound to make sure that the aneurysm is excluded and there is no endoleak or thrombosis of the lumen of the stent. And after 1 year, we did a CT angio of all the patient to ensure exclusion of the aneurysm and absence of any associated aneurysm. We have through this our study period 9 patients. Most of them were male, only females. They were in middle age group. 1/3 of cases affecting common carotid artery, and the 2/3 in the internal carotid artery, and the mean size of the aneurysm was 3.3 centimeter. Our technical success was 89%. We have a failure in 1 case that has a common carotid artery aneurysm. We could not negotiate the internal carotid by wire, and so the patient is converted to open surgical treatment of the patient. After treatment of the patient, duplex ultrasound that was done on the 2nd postoperative day reveals no thrombosis of the stent or no expansion in the aneurysm or endoleak. You have to pay attention in stenting carotid artery because of presence of side branches, but in our case, so you may need to do embolization of these side branches, but in our cases, we did not do any occluder or exclusion of side branches because we were lucky enough because the first branch to have is more than 3 millimeter from our affection of the aneurysm, so we did not do any embolization for branches. As regard the complications, we have 2 complications as regard the access site. We have a patient with false aneurysm at the access site, and it is a groin pseudo-aneurysm. The patient goes with some compression therapy with ultrasound, and he was followed and did not need any intervention. And we have 1 case of superficial femoral artery thrombosis. The patient goes well with conservative treatment because the patient refused to do any surgery and he went good and respond to conservative measures. As regards follow-up by CT, as we have said before, we have complete thrombosis of the pseudoaneurysm, but we have 1 case of thrombosis stent. The patient was asymptomatic and was discovered by CT angio, and it could be due to a rich intracerebral collaterals that present in this patient. Another cause, we have a recurrent pseudoaneurysm at the distal end of the stent graft. We transfer the patient to a rheumatologist. He has a very strict control of the activity of the disease. We followed the patient regularly with ultrasound, and we did not do anything for him because it remains stable through the 9 months of follow-up. After this, we lost the follow-up of this patient. We may conclude from this that an endovascular management of patient with pseudoaneurysm in the carotid and patient with PASHIT may be of a good choice. It has a high technical success and an accepted midterm primary patency rate. It may help to avoid complications of surgery that you may face during surgical treatment of the patient, and it could be the preferable choice for treatment of the patient with an aneurysm. This is a male patient, middle-aged patient, had an aneurysm that he was diagnosed as having a PASHIT disease and has aneurysm, CT angio of the patient. The patient was treated by fluency Stent-graft, and 1 year later, this is aneurysm, and this is a CT angio follow-up. Thank you for your attention.
Thank you, Dr. Hassan. Unfortunately, Dr. Osman, the last presentation, he felt sick and he couldn't come. So we will start our discussion. Start first with Dr. Sameh Zalad, the carotid artery aneurysms. If any question. Actually, I have one. Okay, sure.
Thank you, Dr. Sameh, for your interesting presentation. My question is, if the aneurysm is small in size, is there any rule for conservative treatment and strict follow-up for the patient, or we should intervene as soon as we
You should interfere. Once diagnosed, they should interfere. You have about 50% more than the normal diameter. 50%, not double lumen. So if it's 1.5 centimeter, you should operate. Because you don't know what's inside in the aneurysm. There is luminal thrombus. If any showers happen, nothing. You don't have anything to do. So it is a prophylactic surgery for the patient.
About anticoagulation, we give.
You have an aneurysm and the mural thrombus. Anticoagulant will never do anything. So surgery is important.
Another question: if the aneurysm is higher inside, so the patients you did were
there is a slide about the types of the morphological types of the aneurysm. If it's too high, the endovascular will solve the problem.
If it is with not favorable anatomy for endovascular, you will go for surgery,
we'll go
or
surgery.
with
You'll go
tracheotomy?
surgery for surgery, ligation of the artery.
Ligation.
Yes.
Thank you, Dr.
Sameh, thank you for your excellent presentation, actually. Just a little, in your first case, I couldn't see a cerebral protection device.
Yes, because there is a good backflow from the internal carotid artery, and the aneurysm were localized in the common carotid artery. So I don't need to use a shunt in this case.
Thank you very much. Next speaker, Dr. Musad Suleiman. Any question from the floor? Actually, I have a few couple of questions. If you can tolerate me, please.
Okay, question. You know this patient is covered during preparation for cardiac surgery. Yes, is that right? Yes, and it was an aneurysm. So the patient will go for the open surgery. In this situation, if you put covered stent, and during cardiac surgery, the patient will go for high potential. So instance of thrombosis of the stent will happen. For this case, if I go with the cardiac surgeon in the same time of their surgery and do repair of the carotid aneurysm, then they will continue with open surgery. It will be okay for the patient.
It's exactly the same way that between the cardiologist and the vascular surgeon for coronary artery disease associated with carotid artery stenosis, and there are many randomized controlled studies for how to manage this kind of patients. Is it by synchronous intervention or sequential intervention? And the results was to start sequential with the carotids and then with the coronaries. So this problem has been already solved because the results was better to do it sequential than to do it synchronous, because the morbidity increases when you go through at the same time.
Well, you have a question?
Dr. Moussa, thank you for your presentation. I have a question. How can we overcome the size mismatch between the common carotid and the internal carotid if the aneurysm span the bifurcation?
It's the same way that we used it in a personal way to dilate the stent, which is the Avanta, the V12. It is a dilatable graft which can accommodate the size of the balloon. So it's an intentional dilatation. I dilated a small balloon at 4 millimeter at the distal part, and then 5 millimeter in the middle part opposite the aneurysm, and then 7 millimeter inside the carotid, while the carotid was 6 centimeters, so I had 10% oversizing. So I fixed the graft distally as a common carotid and had it tapered, but in an intentional way. At the same time, there is a kind of tapered stent produced by Bard, but the problem is that its distal most end is 6 millimeters, so it doesn't fit with me.
What was the original size of the V12 you used?
It's 6 by 60.
6 by 60.
Yes.
Yes, I know. You you dilate for 4 millimeter distally and 6 millimeter
7
proximally.
millimeter
Yes.
approximately. Yeah.
Oh, 7 millimeter.
Yeah.
The problem is that there is a nominal diameter. This stent will reach. I mean, being dilatable, I mean, the shear force and the resistive radial force of the stent of 6 millimeter. You left it at 4 millimeter. There is buckling of the stent, and there is thrown in of the fabrics that might hinder the flow later on. Wasn't you afraid about that?
I was already putting it in consideration, but when we did the compilation angiogram at the end, we got this kind of good flow through the stent, good caliper, no discrepancy, and we didn't find any embolization in the proximal territory. And this has been confirmed also after 1 month by the CTA and 2 months of the CTA. We didn't find this kind, but was a great part of our concern at the beginning, because 4 millimeter in an attenuated segment should give you some kind of attention. Yes.
Lastly, the patient was scheduled for open heart surgery.
Yes.
Right? I mean, how you deal with the antiplatelet therapy or antithrombotic therapy post?
It's the same way as they do in patients with multiple coronary artery disease when he runs toward the stenting and then will be switched toward cabbage. So they stop the antiplatelets for around 1 week before. Sometimes they do it 2 weeks.
Is it safe?
Yes. No, it's not safe. But for my recommendation at this time, I asked it to stop the double antiplatelets and to replace it in a prophylactic dose of low molecular weight until the time of surgery. We stopped it 12 hours before intervention.
Okay, thank you very much.
Thank you.
Any other questions, Dr. Mohsen? Okay, Dr. Walid Khaliba. Any question from the floor? Yes. Sure. Mike, please.
Internal carotid, and you say if it is more than 60, it will be safe. Excuse me, I think it is less than this. More than 40 and more is more enough. If you have the stump pressure of the internal carotid by invasive means more than 40 millimeter mercury, it is safe enough not to use shunt. Thanks.
دكتور مجدي اتفضل.
بس يعني عايز اقول انه الستامب بريشر في الاستينوزس او الاوكلوجن يبقى مهم، لكن في الانيوريزم اتس فورورد فلو اصلا من الاول، فيعني التفكير في النقطه دي بعيد عن المنطقه خالص. اللي عايز اقوله بس لو في تيبس اند تريكس انه في السي تي انجيو لازم تشوف الديستانس من السكال بيز مع الانترنال كاروتيد ارتري، يعني اتليست لازم يبقى ليك 1 سنتيمتر عشان الديستال كلامبنج اللي هو لو انت هتشتغل اوبن سيرجري يعني. وان كان في الانيوريزم يمكن الامور تختلف شويه، يعني ممكن في الانيوريزم تستعمل اوكلودنج بالون even if you are very near to the skull base. وفي الحاجات دي في طريقتين للديسكشن. Either you start from the skull base down or you go from the bifurcation up. It depends upon the CT angiography finding and the site of bifurcation of the carotid artery. بس اللي عايز اقوله في الحالات اللي اتقدمت من الكاروتيد سواء كان اتعمل اوبن او اتعمل ستنت، اسمحوا لي اقول لكم انها حالات سهله مش تشالنجينج. انا بتكلم في زون 2 نيك، يعني اتس ان باك دور اور ان ذا باك يارد، يعني انت في سهل في ثانيه تخش تبقى عليها على طول، مش محتاج التشالنج فيها. لكن هي مشاكل دول في لما يبقى انترنال كاروتيد ارتري انيوريزم وسمول انترنال كاروتيد ارتري هتعمل فيه ايه؟ دي المشاكل الاصليه من الكاروتيد ارتري انيوريزم. لكن اللي يتصلح بالجراحه انا في رايي يتصلح بالجراحه، ما يتصلحش لا بستنت ولا بكفر ستنت ولا حاجات من دي، لانه ده انا في تقديري ان هو بريشس ارتري، يعني نص الهيمسفير ده ملهاش الا هذا الارتري، فانا عايز له حاجه تعيش. ايه اللي هيعيش، الستنت ولا الجراحه؟ لا، يبقى الجراحه.
طب
وكل الكاروتيد ممكن يتعمل بلوكال انستيزيا مش شرط الجنرال يعني.
طب سؤال حضرتك دكتور مجدي، the pathology does make a difference in your decision? I mean a patient with a Behçet disease or a patient with atherosclerotic degenerative disease?
هو مشكلة البهست في أي انفلاماتوري انيوريزم الخوف من الانجري اللي حواليه. لكن البهست يمكن حسن قدم حالة فيها كفر ستنت. أنا اشتغلت حالات كفر ستنت سواء في كاروتيد أو في بريفرال. تقريبا بوست اوبراتيف بتروح كل السويلنج او كل الفليجمون اللي حوالين الانيوريزم بيروح تماما وبترجع لارتري كانه نورمال. It depends upon the size of the stent. المينيمم 6 ملم مينيمم ده وانت تبقى طالع قايل انا حاطط ستنت صغير. لكن لو هتحط ستنت 5 أو 4 طبعا absolutely contraindicated.
Thank you very much, Dr. Mahdi. Lastly, دكتور حسن لطفي عزيزي وصديقي العزيز. Any question for Dr. Hassan? Dr. Mosad, تفضل.
Dr. Hassan, thank you. Your concern about the branches from the aneurysm, and if you ever encounter it, you should have rushed toward embolization, and you fortunately didn't find any of them with branches. On the other hand, I would consider this is very unsafe for me to embolize branches feeding a pseudo-aneurysm in the carotid area, because these branches, if they are present, they are intracranial, extracranial communicators. So embolization of them will be driving to hell. You had this in mind?
Yes, I have this in mind, but what I mean about is branches from external carotid. You know, some people, some researchers doing occlusion of the external carotid artery, not branches from internal. We do not, if I understand you correctly, sir, we don't employ.
So the aneurysm was in the internal carotid?
We don't have problem with internal carotid, but the problem is to have aneurysm in the common carotid artery, and you have to occlude external carotid artery to make sure there is no end leak. But we didn't do it, and the patients were good.
Yes, thank
you. Dr. Hassan, I'm sorry, but there is a review article come from Galloway, spoke about the carotid artery aneurysms and their treatment of endovascular. Actually, it happens when there is a wave of immigration from Iraq to Ireland, and 3 to 4 years afterwards, they rush into the use of endografts, I mean the covered stents, and they discover that more than around 35% of those who received the stents, they came with a complication of stent extrusion. Actually, the disease fulminate, and then the stent actually, I mean, the stent was the القشرة التي قصد ظهر بعيد, and they came with rupture with total extrusion of the stents.
Totally agree with you.
What do you think, how to think that's to avoid this complication in your advice? Thank you very much.
Totally true. It goes, if we go back to the cases that Dr. Kusayr presented today, the most important part is the patient must be compliant with treatment, and you have to not touch your patient before controlling the inflammatory stage of the disease. So in all our cases, we at first treat them with rheumatologists to decrease the inflammatory phase. Number 2, the patient must continue for treatment for life, and he must be followed regularly with rheumatologists in order to avoid what you have said.
Thank you very much. But what inflammatory parameters is he looking for to declare that the patient now is stable? Is it a quiescent phase?
The most important is ESR and CRP.
And that's all. No.
The most important.
Okay, that's nice. I mean, that's available everywhere in the market. I mean, it's not sophisticated test.
No, it is. We don't do sophisticated test because of financial issue, and we find that in most of the cases, the patient within 10 to 3 weeks, 10 days to 3 weeks, the inflammatory markers return back to normal, and you can go on.
Thank you very much, Dr.
Thank you, sir.
Any other question from the floor? Okay, that will conclude our session. Thank you very much for listening. Please join us for next session.
هيقدمها بقى دكتور احمد بدوي. بس السبيكر ده هو لسه كبير ولا مش هنيجي ولا يبقى نبتدي باحمد بدوي على طول. انفكتد سودو انيوريزم بالظبط.
لو عايز خد
اشتغل بس هو كان لا بيشتغل. طيب. We opened a session number 11, peripheral aneurysms, and the first presentation is infected groin pseudo-aneurysms in drug addicts, presented by Dr. Ahmed Badawi.
بسم الله الرحمن الرحيم. السلام عليكم. Infected groin pseudo-aneurysm in drug addicts. This study was a prospective study that was carried out on 20 patients with drug administration by injectable route with arterial lesions due to this injection. All patients were subjected to
order please in the hall because he started to take his presentation.
Clinical assessment and complete history taking. As regard material injected by the patient, time recording time passed since injection till presentation, site of the needle as regard sinus or discharge or bleeding or history of bleeding from this site. Investigation, lab investigations, complete blood count, hematocrit value, blood grouping, clotting profile, liver and renal function, virology markers for hepatitis C and B virus and HIV. Investigation to assess the arterial system of the affected limb. Duplex ultrasound was done preoperatively. Was a first-line diagnostic tool. It helps to show hematoma or abscess connected to the artery, aneurysm formation, true or false aneurysm, arteriovenous fistula if present or not, distal flow pattern if triphasic or biphasic or absent. CT angiography served three purposes. Diagnosis was confirmed. Exact location and number of pseudoaneurysm were detected, thereby enabling us to better plan surgical management. Distal run-off vessels were imaged in case of bypass, graft had to be performed. This is a CT angiograph, preoperatively. Management, medical treatment in the form of anticoagulation, antibiotic, empirically, then according to culture and sensitivity, corticosteroid to reduce inflammatory response, vasodilators and prostaglandins, and the antiplatelets. Surgical technique. Proximal control was done through suprainguinal approach to external iliac artery retroperitoneally. Distal control by exposure of superficial femoral artery distal to the pseudoaneurysm. Assessment of the vascularity was done intraoperatively with handheld Doppler and assessing the capillary refilling. Cases with preserved distal flow, ligation only was done. Cases with absent distal flow, extra anatomical iliofemoral bypass was done using PTFE ringed graft 8x80. This is showing proximal control. This is another case. This is the extra anatomical iliofemoral bypass, and this is the end of the surgery. Follow-up, patients were followed up clinically and by duplex and socially by referral to social services for follow-up of addiction states. Comorbidities in the studied group, 40% had HCV positive antibody. Presentation of intra-arterial injection in the femoral artery was ruptured femoral aneurysm in 10 cases and impending ruptured femoral pseudoaneurysm in 10 cases. Cases done ligation of common femoral artery, superficial femoral artery, and profunda femoral artery were 12 cases. Cases with iliofemoral bypass was 8 cases, which has no Doppler flow after clamping of femoral artery. This is a case showing male patient, 32 years, with femoral artery pseudoaneurysm, proximal and distal control of the pseudoaneurysm. Ligation of common femoral, superficial femoral, and profunda femoral arteries, and the debridement of the necrotic tissue was done. Outcome of this case was limb salvage. This is another case showing extra-anatomical iliofemoral bypass, which was thrombosed, and the patient referred again with infected graft, and the graft was removed. Outcome. So patient with who did ligation present in the follow-up with mild claudication only. In the first two cases with bypass group, after 2 weeks, one case presented with infection and irreversible ischemia due to graft thrombosis and did above knee amputation. After 3 to 18 months, the iliofemoral extra-anatomical bypass group came with infected graft, and the graft was removed in all of them with no need for reconstruction, except in one patient who presented with neglected ischemia and infection of the graft, and above knee amputation was done. Conclusion: simple ligation, debridement of infected groin pseudoaneurysm in IV drug abuser is usually a sufficient line of treatment, and revascularization is not warranted in most cases. Infection of the graft is common after revascularization of patient as the patient re-injects themselves with drug again, and reoperation for graft removal is common. Thank you.
We move on to the next presentation, femoral artery pseudoaneurysm, recent treatment modalities, presented by Professor Muhammad Ismail.
Bismillah ar-Rahman ar-Rahim. I am extremely grateful to Dr. Mustafa Sliman and his organizing committee for this kind invitation. Femoral artery pseudoaneurysm. I have nothing to disclosure. Objective will be an etiology, presentation, treatment, and management strategies to improve care and outcome. What is a femoral aneurysm? This is explained markedly by previous talkers. Aneurysm is a permanent focal dilatation of an artery more than 50% of its original diameter. We have two types of femoral artery aneurysm. Femoral artery pseudoaneurysm consists of outpushing of one or two layers of the vessel wall. A true aneurysm, on the other hand, involves all the three layers, intermediate and adventitious. True femoral aneurysm very rare and mostly found in individuals over the age of 65. Usually unilateral, but bilateral in 10%, associated with other aneurysm in more than 30% of cases. Unlike pseudoaneurysm, the risk of rupture is low, but thrombosis and limb ischemia is high. As regards etiology, femoral pseudoaneurysm can typically be caused by any form of percutaneous intervention that cause femoral artery at their entry point. Classically, intervention was done by cardiac catheterization for coronary stenting have been implicated as culprit, especially those used for therapeutic reasons, as they use a larger sheaths. Widespread of percutaneous procedure performed now by cardiologists, intervention radiologists, and also ours, vascular surgeon. Incidence has been reported from 0.5% to 9%. In some series. There is other causes like trauma, infection, and anastomotic disruption. So endovascular intervention is the main etiology of the femoral artery pseudoaneurysm. What is the factor associated with formation of pseudoaneurysm? Antiplatelet and anticoagulant, larger sheath size, old age, obesity, poor procedural compression, simultaneous artery and vein catheterization, hypertension, diabetes, peripheral arterial disease, complex intervention, low or high puncture sites. The patient presented clinically, it may present by pulsatile hematoma, pain, ecchymosis with active extravasation. In chronic scenario, once fibrous capsule has been formed, it may present by persistent flow communicating the arterial to the arterial lumen. It may present by complications, expansion, rupture, embolization, or infection, especially in IV drug abuser. Again, complication, embolization, ischemia, gangrene, Plateau syndrome, rupture, venous, and nerve compression. We assess the patient detailed clinical history for vascular examination, recent remote vascular intervention, or trauma. Should not be mistaken by another differential diagnosis like hernia, lipoma, inguinal lymph nodes, psoas abscess, saphenopharynx, and inguinal hernia. Imaging drug ultrasound is the first line with sensitivity up to 96%, with show characteristic flow to and fro flow pattern between arterial lumen and the sac. Comment also in the dimensions, the size of the sac and the neck, as the treatment will be based on this dimension. Imaging also, ultrasound also assess proximal and distal artery for thrombosis. Other investigation like CT angiography, MRI angiography, done used preoperative for preoperative planning. How to fix it? This is a chart of the treatment, either open surgical repair, ultrasound guided compression, ultrasound guided thrombin injection, selective embolization, covered stent placement, closure device like Vascade. Open surgical repair is the gold standard, especially in complicated patient with arteriovenous fistula or hemodynamical instability and limb ischemia. Surgical principle, controlling proximal and distal, and then repair of the arterial defect transversely, better transversely. Retroperitoneal incision if the large pseudo-aneurysm to control external iliac. If the primary repair cannot be successfully achieved, then we shift to vein graft should be used. While surgery is a gold standard, some patient may be too ill to undergo this procedure and may benefit from less invasive percutaneous procedure. Like ultrasound guided compression, utilize to visualize the neck of the pseudo-aneurysm and apply pressure until the neck is occluded. Care should be taken to avoid compression of the femoral artery itself. Highly successful when the neck is long, more than 2 centimeters. Technical failure up to 30%. Factor affecting success of ultrasound guided compression: ability to compress or anticoagulant status, pseudo-aneurysm size, age of pseudo-aneurysm, chronic with epithelialization and fistulous capsule, neck width and length communicating tract. Contraindication for ultrasound guided compression: inaccessible site, limb ischemia, infection, large hematoma with overlying skin ischemia, or compartment syndrome. Other line of treatment: ultrasound thrombin injection, first described in 1986 by Copé and Zay. This is done by a bedside, and it's good for long neck, using a spinal needle, and from 100 to 500 units per millimeter thrombin is injected in the sac on the neck until thrombosis is achieved. Technical failure in 10%. Cochrane review suggests slight support of this thrombin injection over compression, but not significant. Stent placement first reported by McGraw et al. 1998, and as a surgical reconstruction, I need For 2 minutes. Technical, particularly for drug abuse, patient with bleeding pseudoaneurysm. Other option, embolization and coil embolization for the neck or the sac, as explained by my colleagues. Closure devices like Vascade and AngioSeal. Vascade is a vascular closure device that can insert it into sheaths 5, 6, or 7. Fully integrated system have the ability to close femoral access without leaving any permanent component inside, using bioabsorbable extravascular collagen component to achieve hemostasis with the aid of compression from an expandable endovascular. Shown as a safe by respect trial, superior to AngioSeal with eliminating the need for have anchor within the artery. This is the AngioSeal in the خلاص كده تقريبا.
Can I have another minute?
تقريبا خلصت يعني.
You want another minute?
Conclusion بس. This is a Vascade on the left side, and this. This is a Vascade, and this is the cartilage, and this is the AngioSeal. This is the algorithm to show how to manage from smaller by conservative treatment, smaller pseudoaneurysms to complicated by skin necrosis operation. How to improve the outcome? I showed conclusive surgical intervention should be avoided except if indicated. Manual compression is the method of choice. Thrombin injection might be possible in special cases. Intervention closure devices is recommended for previously failed cases. Stent placement has a crucial role in femoral artery aneurysm. Use different technique depending on the anatomy, size, complication of femoral pseudoaneurysm. Thanks.
We move on to our next presentation, pediatric pseudoaneurysms. دكتور محمد علي.
بسم الله الرحمن الرحيم. Pediatric pseudoaneurysms. Pediatric pseudoaneurysms is extremely rare. However, their management is considered to be very difficult. According to literature, the most common site for pediatric pseudoaneurysm is the femoral artery due to cardiac catheterization procedures. The body of literature on pediatric pseudoaneurysms is lacking the answers to key questions such as, how can we prevent iatrogenic pseudoaneurysm? Can we predict which lesions will thrombose or rupture? The rarity of pseudoaneurysms is the primary barrier to answering these questions. Surgical management can be more difficult than expected in these cases due to weak supportive surrounding tissue, spasmodic tendency of the vessel, and more fragile vessel structures. What about conservative management? Many reports advocating for the use of conservative management for pediatric pseudoaneurysms. However, there must be fulfilled criteria to apply this sort of management. What are these criteria? The lesion should be asymptomatic, stable in size on serial Doppler ultrasound examination, and the location is low risk for accidental traumatic disruption. Ultrasound-guided thrombin injection is a less invasive treatment option, which is considered a valuable alternative to traditional surgery, but it requires meticulous technique as well as great expertise because it's become more challenging to perform in pediatrics than in adult. Some drawbacks of ultrasound-guided thrombin injection in pediatric that it requires general anesthesia, prolonged compression make distortion of the pseudoaneurysm, and there may be some problems with needle tracking due to low subcutaneous fat. To our knowledge, only 5 cases went ultrasound-guided thrombin injection for pediatric pseudoaneurysm. 2 of them were complicated with limb ischemia due to propagation of thrombin in arterial lumen in 1 case and compression of the native artery by the thrombosed sac in the 2nd case. So, surgical corrections remain the choice for cases of complicated pseudoaneurysm, failed conservative management, and complicated thrombin injection. Our first case, male infant, 8 months after cardiac catheterization, present with groin mass, exploration for the pseudoaneurysm, and repair to the artery. A second case of a 1-year-old child, present with a swelling in the axillary region. A pediatric surgeon thought it was an abscess, so he rushed for open. Surprise of bleeding. We explored, and we did repair to the proximal part of the brachial artery with interrupted sutures. Another case for a child, chronic kidney disease on dialysis, has previous attempt for insertion dialysis catheter in the left groin, but failed. Then he proceeded to the other side. CT angio showed lesion in the SFA. With clinically, he was ischemic. We explored, found superficial femoral artery pseudoaneurysm, opened it, and we did interposition graft with saphenous with interrupted sutures. Here another case was a female child present to us with a swelling in the neck, in the left side of the neck after broken glass with a thrill. CT angiography show pseudoaneurysm in the common carotid artery with AV fistula between the carotid and internal jugular vein. We explored, repaired the artery as primary. Another case of a child present with swelling at the hypocenar eminence after repeated trauma. CT angio showed a ulnar artery pseudoaneurysm. Exploration was done, excision and repair to the ulnar artery. Another case of a male child, chronic kidney disease, brachiocephalic fistula. He had pseudoaneurysm over the cephalic vein. We did exploration after tourniquet. We can realize that the tourniquet present distal. Excision of the pseudoaneurysm and repair to the cephalic vein. Another case of a male child had localized trauma, a puncture to the popliteal fossa. CT angiography show pseudoaneurysm in the popliteal artery. Through posterior approach, we repaired the popliteal artery. So, conclusion. Pediatric pseudoaneurysms are extremely rare, represent a type of vascular trauma despite intact peripheral pulse. There is certain criteria to apply conservative management for pseudoaneurysm. Ultrasound-guided thrombin injection need meticulous technique as well as great expertise to be applied. Surgical correction remains a choice for complicated pseudoaneurysm, failed conservative management, and complicated thrombin injection. Our take-home message is combined Doppler scanning with CT angiography is valuable for diagnosis and planning for management. Classic proximal and distal control is preferred over direct attack under tourniquet control. This is because we may miss posterior wall injury. Pediatric vascular anastomosis should be taken in interrupted manner. Autologous conduit is preferred over synthetic graft. Also, we should use magnifying loops with a specialized pediatric instrument. Thank you.
We move on to our next presentation. The topic is management of urgent aortic problems in the COVID era, presented by Professor Ehab Ali.
Dear chairpersons, professors, and colleagues, thank you very much for this kind invitation. Special thanks to Professor Mustafa Sliman for this invitation. I'm Associate Professor of Cardiothoracic Surgery at Ain Shams University, and it will be more of a relaxing session from the crude science that we have been having all day, just shedding some light on the urgent aortic problems in the COVID era and how our department managed to deal with it. I'm honored to be part of the aortic surgery program that was set at Ain Shams University in collaboration with the Royal Brompton as well as the vascular department at Ain Shams University. We share experience with the UK department in Brompton. We will share some experience, as I said, on the impact of the COVID crisis on our daily practice, as well as the approach towards the management of cardiac surgery services during the pandemic. Just some quick facts about the pandemic caused by SARS-CoV-2. It was declared as a pandemic on the 21st of March. It represented a big challenge to all human healthcare services all over the world. All ICU beds and ventilators were occupied, and there was deficiency in all protective measures, materials. There was shortage in healthcare workers, mainly because they were falling sick every day. The problem is that there is a risk for patients undergoing cardiothoracic surgery and developing COVID-19. At the same time, heart disease itself is a risk factor for developing a severe form of COVID. And studies showed that there is a positive cardiac insult in COVID patients as well. The impact was that the health care services repurposed or refocused on the management of the COVID-19 patients, and this represented a very big challenge on our cardiothoracic surgery department because we rely mainly on ICU resources which were exhausted by the COVID patients. So the approach was to triage the urgency of the daily surgical practice and to consider non-surgical management options whenever possible. Guidelines have been put to try to deal with the problem and provide safe and effective care for the patients. And in USA and Canada, a task force was put or was arranged to put some guidelines on how to deal with the problem. And this was published in the Annals of Thoracic Surgery. The aim of the study or the goal of the task force was to provide guidance on how our adult cardiac surgery and aortic surgery emergencies will be dealt with during the pandemic. The task force came to a conclusion that we should postpone or cancel cardiac surgery cases, especially the elective ones. We have to, the consensus was that number one, we are protecting our patients from contracting COVID. We are protecting the institution and preserving the valuable resources for the COVID patients. Number three, we are protecting the healthcare system because non-essential operations may increase the chance of COVID-19 exposure. So it's all a balance between significant cardiovascular disease, have their definitive disease patients have their definitive treatment delayed, and the fact that they might contract COVID. They stratified the crisis into tiers. Tier 1 was up to 30% inpatient COVID-19 load, and this caused or corresponds to mild reduction in the operative capacity. All patients waiting for surgery, including emergency services, or inpatients waiting for surgery, including emergency services, were done at this stage, as well as outpatients who are at greater risk of adverse events. Asymptomatic outpatients are delayed or postponed, and elective interventions are considered. We have to say that all patients have to be screened regularly, and all percutaneous therapies should be considered as well during this tier 1. Tier 2 corresponded to 30 to 60% inpatient COVID-19. Tier 3, 60 to 80%, and this caused severe reduction in the operative capacity. All inpatients who cannot be discharged safely without surgical intervention should be dealt with. Tier 4 is more than 80% inpatient COVID-19, and this means minimal operative capacity. Only emergency cases are done. This is another study from the UK And they came to a similar conclusion that daily multidisciplinary team should be done. COVID testing should be done for everybody. Cardiac surgery teams are redeployed to intensive cares, and the centralization is often done to a major unit. They quoted a reduction in the cardiac surgery service by 83%. Another study from the UK on the impact of coronavirus pandemic on the surgery practice concluded that elective and non-urgent procedures have been postponed, and again surgeons have to encourage using telephone and video conferencing. Cardiothoracic surgeons can greatly support the general ITU services as well. They quoted the NHS England guidelines for which procedures that should be dealt with during the pandemic. They quoted acute type A aortic dissection, severe coronary artery disease, ventricular septal rupture, urgent thoracic surgeries. Interestingly as well, there is a study from Egypt who discussed this dilemma, and they came to some interesting conclusions. They said that regarding the cardiothoracic surgeries, surgeons practicing in Egypt during the pandemic, 80% agreed that they are at risk and that this was their major fear, that they contract the virus. More than 90% agreed that they may carry the infection home. Ain Shams University set some very important guidelines and was one of the first universities to set guidelines on how to deal with the problem. And this was published on the website. The plan should be dynamic, keeping the service running, especially for emergencies, gradual reduction in the volume of elective cases from 100% to 50% to 25% according to the situation, daily MDT meetings, screening for everybody, strict use of PPEs, and encouraging or postponing some clinics. Also, all healthcare workers have to be screened. One of the papers that I co-authored regarding the effect of coronavirus disease on the cardiothoracic hospitalization rates and emergency services, we also quoted that the main problem is the collateral damage. When we concentrate on dealing with the COVID-19 crisis, many cardiothoracic patients will be facing the problem of being neglected from their treatment. We did a retrospective non-randomized descriptive study conducted from October 2019 till September 2020, according to the number of emergency cases that we experienced in our department, and the same period from the previous year was the control. There was a significant reduction in the number of emergency cases presented to the department from 16 to 8, and not only the acute aortic dissections, actually all the cardiothoracic emergencies showed a very big reduction, which was a bit of a dilemma why this is happening. We went through the literature and we found there are lots of theories explaining why. I would need another minute, if you don't mind.
1 minute, please.
Yeah, just 1 minute, yeah, maybe less. Thank you very much. The explanations showed fear of contracting the virus, so patients are not presenting to the ER, fear of social stigma, fear of being a family burden. Some also suggested that the lockdown made it difficult to access the ER because there are lots of COVID patients, so patients with MIs are not accessing the ER. Many professionals believe there is lack of consensus among the public that they should go quickly when they feel chest pains and stuff. Some said that there is minimal exercise and activities, and this might make the presentations of cardiac problems less pronounced. So this was an interesting fact, to be honest, because we thought that emergency cases will continue to proceed as before, but we found lots of reductions in the emergency cases presented during the time of the pandemic. We came to a conclusion, like a take-home message, that although the American College of Surgeons and the American Society of Anesthesiologists recommend the reduction a reduction in the COVID-19 infected patients should be awaited before initiating again elective surgeries, we agree with Keskin article who suggested that cardiovascular interventions, including open heart surgery, can be performed safely with acceptable morbidity and mortality rates during the pandemic if we adhere to the recommendations of the infection control units and the strict use of PPEs and disinfection protocols. Thank you very much.
move on to our final presentation in this peripheral aorta aneurysm session. The presentation is iatrogenic arterial aneurysms, and it's going to be presented by Dr. Ihab Hamdi.
Iatrogenic arterial aneurysm. Iatrogenic arterial aneurysm is a common complication of post-diagnostic and therapeutic vascular interventions, commonly performed by vascular surgeons, intervention radiologists, cardiologists, or as a complication of surgery in many other specialists, such as nephrology, urology, neurosurgery, or orthopedic surgeons. Management may be observation or surgical intervention, ultrasound-guided compression, ultrasound-guided thrombin injection, ultrasound-guided perianeurysmal saline injection, or embolization. This is a case of common femoral artery pseudo-aneurysm developed due to inadvertent insertion of temporary dialysis catheter. This is a case of common femoral artery pseudo-aneurysm that developed post-PCI. This is a case of internal iliac artery aneurysm that developed in a female patient with history of lumbar disc surgery 6 months ago. This is a case of common carotid artery pseudoaneurysm that developed in COVID-19 positive patient after a trial of central line insertion. This is a case of peroneal artery pseudoaneurysm that developed in a patient after orthopedic fixation. This 40 years old female patient that developed a pseudoaneurysm over profunda femoral artery after intramedullary nail insertion. This after hystoarterial embolization. Thank you.
We open the floor for discussion, starting with the first presentation. Dr. Ahmed Badawi. Is Dr. Ahmed Badawi here? Dr. Ahmed, I have two questions for you regarding your infected groin pseudoaneurysms in drug addict presentation. My first question is, you said in your presentation that you take the decision intraoperatively whether you're going to ligate alone or do an extra anatomical bypass. And my second question for you is the choice of a subcutaneous iliofemoral bypass. And wouldn't you have preferred an extra anatomical transobturator bypass that's well sealed from the groin infection? So
the first question, yes, we did assessment of the vascularity intraoperative using Doppler, and if the flow is heard by handheld Doppler, we don't do a bypass.
Wouldn't you have preferred to ligate, anticoagulate, and observe over the next 12 hours?
No, if no flow was detected, we had to do...
There's always going to be a flow, but how sufficient the flow is.
If no flow was here at all, we did bypass.
Okay.
We recommend is not to do bypass as the graft will be infected.
Okay, and the second
question?
I'll repeat the question to you. In the slides that you showed.
Yes, we did one case.
It was a subcutaneous iliofemoral
yes,
bypass.
In most cases, but we did obturator bypass only in one case.
So what's against doing obturator bypass?
The spread of infection.
In every case.
It's a difficult approach, and we did it in one patient who.
But infection is more when you are putting a subcutaneous graft very close to the groin.
Yes.
Okay.
We preferred obturator bypass. We did it in only one patient.
Yes, Professor Hisham.
For the same question, you need to do bypass after control of infection because all of these patients developed chronic ischemia after that. I agree that during the emergency, you can ligate the femoral artery and the patient come after with chronic ischemia, and you must plan for doing bypass, extra anatomical bypass, because of the thrombosis of the distal arteries later on. Yes. And the patient may end by amputation. So you must plan as a cold case for bypass. You can ligate during operation, during emergency because of the presence of infection, especially this patient coming with severely infected groin. So you can ligate and later on, but sometimes if there is no backflow and the patient is critical, you can do simultaneous bypass as you do in some cases.
Yes, I agree with you.
Professor Adel Husseini? No? No, I have a question for you, my dear colleague. Actually, it's a question and a comment. My comment is, you told us that you depended on the presence of a backflow from the distal artery. And as Professor Sharif said, you always, or most of the time you have flow, but you ask yourself if it is sufficient to survive a limb or not. This is a question. Another predictors, we had a lot of experience in the infected femoral pseudo-aneurysms in Alexandria University, especially in drug addicts. We have a lot of addicts in Alexandria, you know.
We have in
yes. In the first times we dealt with such a problem, we tried to ligate, then waited for some times. We put our patient on close follow-up, and if the limb becomes ischemic, we do the bypass, as Professor Hisham said. But after that, we developed some criteria to predict when to ligate and when to do a primary extra-anatomic bypass. And there is a paper published in the Annals of Vascular Surgery in 2019 about these predictors in more than 25 cases. We found that if you ligate below the level of the deep circumflex iliac artery, iliac branch of the external iliac artery, it's safe to ligate alone, and you don't need to do a bypass. But if you put your ligature above this level, no one can tolerate it, and even you need to do a very high above-knee amputation or even a disarticulation for this patient.
We ligate as far as possible, distal as possible.
No, you have a limit. You have an anatomical landmark, which is the deep circumflex iliac branch of the external iliac artery. This
we're
is
guided
the landmark.
by spread of infection.
If you are above this level, you need to do the bypass. If you're below this level, you don't need to do the bypass. Yes, sir.
We ask ourselves about where is the pathology in these cases. The pathology is precipitation of crystals in venous capillaries. And so you have a blue tooth in spite of presence of distal pulse in some of these patients. So, and there is stagnation of blood because of occlusion of the venous side.
Totally agree, Professor Hussein. Totally agree. Totally agree.
Some people try to put criteria, and what we have is non-invasive ankle brachial index. And they had found that if the patient is in chronic ischemia, such as ankle brachial index is between 0.4 or 0.6, you can ligate safely from the start. But if ankle brachial index more than 1, after your ligation, you will change this patient to acute ischemia.
This is done after test clamping, or you do measure the ABI from the start?
No, before and after clamping.
Yes, you
And
do a
if you
test
find
clamping.
that the value is the same before and after, you can ligate.
Yes, totally
If there
agree
is
with you,
change,
Professor Hussein.
you must go to
Totally.
revascularization, whatever the route.
Totally agree. My second question is, I'm sorry. My second question was about the use of obturator bypass. As Professor Sharif asked you, you have a problem with such cases with a superficial graft, superficially inserted graft. This kind of patient, they usually use this synthetic graft for injection of the drug, and he comes again for you with an infected pseudoaneurysm, and your only option is to remove the graft. Did you face such a problem with your patients?
Yes, we have found that the patient re-injects themselves in the graft, and we recommend the obturator bypass. We did it only in one case.
I think this is the best.
It was a difficult surgical approach to obturator.
Yes. Professor Nasser Said?
Just would like to make stress, we build up some experience with dealing with such cases of addictions. We will never ever put a subcutaneous bypass for this patient, because you are making their life easy to continue for injection. I agree with you, transobturator is the ideal, but it's demanding operation, sometimes a bit difficult, need experience, carry high risk. And instead of that, you can do the bypass on the medial side, doesn't really throw the obturator foramen, but deep on the medial side instead of to be superficial on the lateral side or lateral aspect.
Among the proximal part of the adductor muscles, you mean?
Sir?
Among the proximal part of the adductor muscles?
Yes,
You mean this?
as deep as you can, doesn't matter, but when become on the medial aspect, it is not an easy for the adductor to use it, and at the same time away from infections to some extent. But our policy actually, ligate, whatever the result, until everything settled down, and later on, if the patient, as Dr. Hisham said, may suffer from chronic ischemia, it depends. But usually, this patient not coming again for collidication, he's just coming for another pseudo-aneurysm due to injection somewhere else.
Yes, thank you. Thank you.
Is there any questions for the second presentation for Professor Muhammad Ismail? Professor Muhammad Ismail, any questions for his talk, femoral artery pseudoaneurysms? Okay. Are there any questions from the floor for Dr. Muhammad Alewa regarding pediatric pseudoaneurysms? Dr. Hisham?
الحقيقة أنا يعني congratulation to طنطا team. أعتقد الجلسة دي طنطا يعني في الانيوريزم peripheral aneurysm. But I want to ask you about the conduit for pediatric. This is a problem to use any synthetic graft for aneurysm in pediatric age. If you don't find the autogenous graft, what you can do for this age?
Well, first, as you could see, we deal with many ages from 9-month-old, 1-year-old, and 14 years old. We first try to do a primary repair, possible if we can, with interrupted sutures. If there was a gap between the artery, we do a conduit through nearby vein or saphenous vein. Sometimes we use the synthetic, but we recommend against synthetic graft unless there is no way to be autogenous conduit in the patient. Also, there is a discrepancy between the synthetic and the vessels of the pediatrics, and we don't have a synthetic procedure or a synthetic conduit unless 8 millimeter and 6 millimeter, which is much bigger than the pediatric vessel.
Do you do any case with endovascular technique?
No,
One
we don't. We didn't apply endovascular because such cases was very young and the vessels were very small for any endovascular technique. Also, we don't have the facilities or the tools for endovascular for this young age.
Okay, thank you.
For our final presentation, iatrogenic arterial aneurysms presented by Dr. Ihab Hamdi. Are there any questions from the floor? Okay, we conclude this session. Thank you very much.
Assalamu alaikum. By ending this session, we got the end of the activity today. And tomorrow we have a very hot sessions. It will be all problem solving, either challenging cases, either tips and tricks, either inflammatory cases, difficult cases, all will need very strong discussions. So I eager all of you to attend, and it will be a very hot topics tomorrow, inshallah. And again, tomorrow also we'll do the sessions of Ask the Expert sessions, as we announced before. And there will be 4 sessions for Ask the Expert. And it will start at 1:30 p.m. Every session will be 30 minutes. The first one will be diabetic foot problems. Second one will be AAA sizing. Third one will be carotid artery aneurysms. And the fourth one will be lymphedema problems. So you can go for the registration desk and book your place, and it is limited places again for it's only 5 places for each topic. Tomorrow, inshallah, after the end of the program and the end of the event, will be a gala dinner, inshallah, in Blue Nile boat. It is very near from here, and there will be a very nice program also for recreation. We'll move from here 7:30 p.m. and it take 10 minutes only to the boat. And all of you are invited. And now there will be dinner now. Yes. I'm coming to you. Tomorrow also we will do the planning for the coming matches of the Vascular League. We reached the semi-final stage, so we'll do the choice of the matches and dates for the semi-final matches and the final match. The semi-final will be on January 28th, and the final match will be on February 11th. I hope we will follow these matches on the website of the society. Online, there will be live streaming for it. Last thing that we will we'll do the tombola for today, so many gifts, so many surprises. Also again for whoever wants science or other things. Okay. So we can start now. شركة حفني Group Pharmaceuticals is giving these gifts for you. And for instance, شركة حفني Group have a very nice workshop tomorrow for the control of bleeding and hemostasis. There will be a workshop for whoever want to attend from 3 p.m. to 5 p.m. And now we can start. هنبتدي بالكتب برضه. بنبتدي بالعلم الأول طبعا. اتفضل. 145. حاضر. 145 جنيه. خلاص شيل دي. انا عايزك تقول انت الرقم الفايز. انا خدت من على الوش اهو.
99.
الجيش المصري وهو الجيش طبعا هو مين؟ هو اولادنا واخواتنا واولاد عمنا وعبد العاطي. عبد العاطي صائد الدبابات. شكرا جزيلا. The new version of Rutherford, all the parts, 8 parts, original book for المعادي Medical Center. لا هيحطه في مكتبة القسم. يتحط في مكتبة القسم، ولو ما فيش مكتبة هو يجيب مكتبة يحطه فيها. ما هو رئيس القسم لما هم يذاكروا هيبقوا يشتغلوا كويس، يوم ما يدهلكش بالليل. طبيعي. ألف مبروك ألف مبروك ألف مبروك ألف مبروك. And now for the copy, the original book of Frank Vieth. اقرا.
247.
247 فرانك فيث latest edition. 247. مفيش 247؟ مش عايز يطلع، مش عايز يكتب. ما مش هيجي تاني.
226.
226 مش موجود. قلب. لحظة واحدة. اسحبي انت يا ياسمين.
119.
119. ده رقمك كام يا عم انت؟ رقمك كام؟ رقمك كام قول لي. عشان ما اندهوش.
157.
157. ارقامها 100 كلها ولا ايه؟
143. 143.
143 جنيه.
المشكلة في الجايزة.
المشكلة في الجايزة صح. انا اجيب اخر حاجة تحت اهي. انت ايه؟ 143. حد معاه 143 تاني؟ اي حد غير الدكتور ايهاب بس والنبي. اي حد. مش معقول. ده الدقن دي بتعمل حاجات كتير قوي. الف مبروك. الف مبروك. الف مبروك.
شكرا يا باشا. انا عارف ان طبعا زعلان من الموقف ده، بس يعني
هترجع لنا البرفان بتاع امبارح.
ماشي خلاص.
ماشي. الف مبروك. هنسحب بقى الساعة والولاعة. ساعة جوفيال تقليد صيني. اسحبي يا ياسمين تعالي. لا مش هاي، حتى مش هاي كوبي.
400.
400. استني 400. 400 والله اهي. صور عشان محدش يظن حاجه بس. 400 اهي. متشكرين. صور يا عم. انا بقى اهو خد يا عم. شكرا جزيلا والله. الف مبروك للدكتور مصطفى والله. برضو ماشي. انا اول مره اكسب في حياتي والله
308
اهي. 308. عرفنا بنفسك.
دكتور احمد الشهيدي، مجمع كوبري القبه العسكري.
جيشنا برضو يبقى المعادي مره وكوبري القبه مره. ألف مبروك.
شكرا
جزيلا. اتفضل. بالكرش ما ينفعش. هنسحب من الناحيه دي. فاضل ايه؟ سماعه كمان وسماعه كمان. 248. كوبري. الكباري بتنفع برضو، خلي بالكم يعني. هديله نص ساعة. ألف مبروك. اتأكد من الرقم يا ابني. 248. عرفنا بنفسك.
دكتور كرولوس عطلة، مستشفى كوبري القبة العسكري.
ألف مبروك يا كرولوس. ألف مبروك. آخر حاجة تعالى أحمد اسحب أنت.
مية 121.
الجلال العسكري بقى المرة دي. الجلال العسكري عشان نبقى اثبت العدل. اهلا وسهلا. الزهراء اهلا وسهلا. 100 كام؟ 121. انت قايل كام؟ انت قايل 128 يا ابني.
دكتورة شيرين أسامة، مستشفى الزهراء الجامعي.
مبروك يا دكتورة شيرين. اتفضلي. بصي له هنا، بصي له عشان شكرا. اخر سحب بقى على العربيه البي ام. مفيش بي ام؟ بكره ان شاء الله سحب على البي ام. شكرا جزيلا. عايزين صوره لو سمحتوا للناس اللي اشتركت النهارده، لو سمحتوا، لو تكرمتوا، يبقى شرف لينا نحتفظ بصورتكم. ما اقدرش